that type 2 lissencephaly, that is cobblestone lissencephaly, is more prominent in WWS, and agenesis of corpus encephalocele, Dandy-Walker malformation, microophthalmia, and congenital cataract, ocular coloboma, and persistent hyperplastic primary vitreous. So these are the primary features in WWS. In my case, it was fetal hydrocephalus was present, agenesis of corpus callosum was there, meningocele was there, Dandy-Walker malformation was there, microophthalmia and ocular cataract was also there, and PHPV was also present. And it is more of a clinical diagnosis and can be suspected by prenatal CT or MRI and can be confirmed by genetic testing. A examination can also identify the characteristic eye findings of WWS. The disease affects both male and female in equal numbers, and it affects 1 in 60,500 newborns worldwide. So according to the discussion, so WWS is an extreme that affects male and females in equal numbers. WWS is inherited as an autosomal recessive trait. Prognosis of the patient is very bad, and most patients die within 1 year of life. Muscle dystrophy and hydrocephalus since birth. So here I would like to mention that the muscle dystrophy is due to the deficiency of the protein dystroglycan, and WWS is one of the severe dystroglycanopathies. And the etiology of Dandy-Walker malformation, genetic counseling is needed, and the most commonly mutated genes are POMT1, POMT2, CRPPA, FKTN, FKRP, and mutations in these genes are found in about half of the individuals with Walker-Warburg syndrome, and the eye abnormalities include a high incidence of retinal lesions such as retinal dysplasia and retinal detachment. Capacities may be there, that is shallow anterior chamber cataract, glaucoma, microophthalmia, PHPV, and antenatal ultrasonography is diagnostic, and the treatment, it has not been shown that treatment is mainly according to the problems we treat the disease. So there is no specific treatment discovered for this disease yet. Thank you.
So we have 3 judges for today right now. Dr. Pankaj is over here, Dr. Ajay sir is there, Dr. Deepak sir is there, and Dr. Anju ma'am is there. So I request the judges to please take over and ask for the questions and for further marking also.
Hello, Dr. Aromita, Dr. Pankaj Garg here. So very well presented case. My two questions
good morning, sir.
are,
good afternoon, sir.
You did mention the role of genetic counseling in this patient. So it was a consanguineous marriage.
Yes.
So genetic workup was done in this baby? Was the
genetic work was not done because of the patient did not give consent for genetic workup. After that, they took LAMA and they away. So genetic workup, we were about to send karyotyping to other laboratory, because in our institute it is not available. So they did not give consent for it. We explained
but for this you don't need karyotyping.
So they told that okay,
suppose they don't give you consent for karyotyping.
Karyotyping is.
What could you have done? So this case does not require karyotyping. It's not a chromosomal disorder. It's a genetic single gene mutation disorder.
Genetic disorder.
What sample you could have stored without their consent also? This could be used in. See, there's so many patients at that time they don't give consent, and later on they come back to you. So you could have done something which is without any cost, and some blood could have been stored. You know what could have been stored? So DNA. So DNA can be stored. Just a 2 ml EDTA sample. So that is one. Second is what type of hydrocephalus this baby had? What type of hydrocephalus this baby had?
The baby had obstructive and non-communicating.
Right. Any particular family history, drug history in the mother you like to ask in this patient?
Yes,
any drugs in the mother
about whether the mother. Yeah, valproate, valpirine, sodium valproate.
Thank you so much. I'll hand over to other judges.
Okay, sir.
Thank you, Dr. Pankaj. Dr. Kumar, would you like to ask some questions?
Dr. Kumar.
Anyway, already we have done the 2 questions. Thank you, Dr. Aromita. It was a nice presentation.
Thank you, sir.
All the judges.
Thank you, sir.
She is Aromita Dev. Now we go to the next presentation.
Okay, sir. Thank you, sir.
For the next presentation, I invite Dr. Sudhir Kumar, and I request him to give a short, very short introduction, and please start over the case.
Okay, ma'am. Uh, Good afternoon to the great members of all over India, pediatricians. Myself is Dr. P. Sudhir Kumar. I'm a PG resident in Safdarjung Hospital. Uh, Now I'm going to present the prognostic significance of serum procalcitonin uh, in critically ill patients, especially of 2 months to 12 years of age, who admitted in pediatric intensive care in Safdarjung Hospital. All of us know, like, procalcitonin is a member of calcitonin superfamily of peptides. It is a peptide of 116 amino acids with an approximate molecular weight of 14 kilodaltons. It is mainly produced by parafollicular cells of the thyroid and by the neuroendocrine cells in the lung and the intestine. Its level usually its level is below the level of detection of clinical assays in normal persons, but the level of PCT rises in response to pro-inflammatory stimulus. It can be used as a marker of severe sepsis caused by bacteria, and it grades well with the degree of sepsis as published in many articles. The level of procalcitonin follows the intensity of the inflammatory response and the severity of the infection. So the increase in concentration or persistence of high values is considered as a prognostic indicator for severe forms of the disease with an adverse outcome. Its concentration is not affected by neutropenia and immunodeficiency and NSAIDs, unlike CRP, which usually used as a which are currently used as an inflammatory marker. It is important to know the severity and prognostic factor of the underlying disease to treat patients urgently and effectively in PICU. For this reason, there are so many special scoring methods developed. Besides these scoring systems, there are some biochemical markers which are also related to the prognosis of critically ill patients. The main aim of our study was to see prognostic significance of serum procalcitonin level in critically ill patients admitted in PICU, and also to correlate its severity with a different organ system involvement. And also this study also compared, as I mentioned, special scoring systems are available in ICU, and to compare the results of this study with PRISM 3 scores. The main aims and objectives of this study are to know the serum procalcitonin as a prognostic marker of mortality in critically ill patients admitted in PICU and its association with different organ system involvement. So my primary objective is to see procalcitonin as a prognostic marker based on its level at the time of admission, and also I followed the patients for day 3 and day 7 to see whether the procalcitonin is improving with clinical scenario. And also my secondary objective is to find its to find out the association level of serum procalcitonin with different organ system disease involvement, and also to compare the results of serum procalcitonin with PRISM 3 score in detecting the severity of the illness of the patient. The study design of my study was a hospital-based observational study in a pediatric intensive care unit, VMNC and Safdarjung Hospital. Study population are those who critically ill patients admitted in PICU, especially in between 2 months to 12 years of age. And also my study sample size was 183. The inclusion criteria, all critically ill children aged between 2 months to 12 years who admit in PICU. And the exclusion criteria is post-operative surgical patients, and also because in post-operative surgical patients, the serum procalcitonin is factitiously high, and also in children who have been in PICU prior to study, children who clinically suspected of autoimmune disorders. The main outline of this my study was patients meeting inclusion criteria were enrolled during the study period. After obtaining informed consent, patient name, address, and contact number were taken, and complete general and systemic examinations were done, and investigators contact provided. Immediately after admission into the PICU, serum procalcitonin sent on day of admission, and PRISM 3 score were calculated on the day of admission for each patient. And also the serum procalcitonin sent subsequently the serum with different organ system involvement. Hello, am I audible?
Yeah. Please go ahead.
Sir.
Please carry on.
Sir. A total of 180 patients were enrolled with a median age of 5 years. And also the procalcitonin day 1, day 3, and day 7 were sent. When compared with the alive patients and also with the expired patients, the serum procalcitonin level on day 1 and day 3 and day 7 all are significantly high when compared with live patients. And also, as I mentioned earlier, in my study, there is no significant association found for age, gender, and different organ system involvement with outcome, and no significant association found for different organ system involvement and rise of procalcitonin level on day 1, day 3, and day 7. But when compared in between day 1, day 3, and day 7, I found that
What happened, Dr. Sudhir?
Dr. Sudhir, are you connected?
I think he seems to be lost.
I think there is some connection issue with his.
Yeah, he's not. I think he's lost his connection.
Backend team, can you please contact Dr. Sudhir?
But his video, his screen is still shared.
So we have added.
Hello, Rohit.
Yes, sir.
What happened?
Yeah, now is panelist, sir.
Okay.
Sudhir?
Dr. Sudhir, have you joined back?
No, his name is not there. He's joined now. Yeah, he's joined. Yeah. He's raising his hand.
Okay.
Sudhir,
Dr.
can you
Sudhir,
continue?
please finish.
He's been seen in the panel, but he's not.
Mr. Sudhir, Mr. Rohit, please see to it.
Yes, sir.
He's raising his hand.
Please give him the video link.
Ajay, we are wasting time. It's already 10 minutes. Can we go to the next?
Yeah, I think we can go to the next presentation and he can join back and we can give him again a time.
Right. So, but how to remove this screen? He's on the screen still. Screen share. Yeah, it's
Rohit
fine.
can do it.
Yeah. Now it is done. Yeah.
So I request the next delegate, Dr. Bhushan Gupta, to please share the screen and start his presentation. Dr. Bhushan Gupta.
Yes.
Hello.
Yeah.
Am I audible?
Yeah. Dr. Bhushan, start, please, sir.
Good afternoon, everybody. I am from Kathiawar Medical College, PG President. Today I will be reporting a case of very big disease, Pelagius Masbate disease, that too from Kathiawar Medical College. The child was brought by an orphanage. The child was 8 months of age. And the details given by the orphanage was the child was of Hindu family from non-consanguineous marriage, was submitted in orphanage for unknown reason, was born after full-term pregnancy, normal vaginal delivery, died immediately after birth, and was appropriate for gestational age. No prenatal factors such as radiation or any drug history was there. The child brought with complaints of difficulty in feeding since birth, inability to hold his neck up to 8 months of age. There was no head control. As the picture is the picture. Was unable to roll to sit without support.
Please be a bit louder, Mr. Bhushan.
Hello.
Please be a bit louder.
Your voice is not very clear.
Please speak near the mic. Stop your video, and I think then sound will be better.
Stop my video.
Go ahead.
Hello.
Yeah. Speak.
Okay. So The child came with complaints of difficulty in feeding since birth, unable to hold his neck till now, unable to roll over, unable to sit with or without support. Vocalization was not achieved, and seizure started after 1 month of age. On examination, all anthropometric that is height circumference was between -1 and -2 standard deviation. Length, weight, and mark was within normal range. On examination, we observed that the child is having feeding difficulty, global developmental delay, axial hypotonia and limb hypotonia was present, and which were more prominent in lower limb. Till now, no head control was achieved, and nystagmus was present, and small penile limb with hyperpigmented scrotum was noted. Both testes were present. We did some basic investigations, and MRI brain was done. In MRI brain, we are able to see that in T1 image, there is lack of myelination, evidence of white matter destruction, and in T2 image, we appreciate revealing poorly myelinated cortical and cerebral white matter. So these were the findings in MRI. So it goes in favor of Pelizaeus. It is hypomyelination disorder. Pelizaeus much better disease is X-linked leukodystrophy, characterized by developmental delay, nystagmus, hypotonia, cerebral intellectual deficit. It was first described by Pelizaeus as in 1885, and again much better again introduced it in 1910. This is PLP1 and phospholipid protein 1. It has again three subtypes: conical, transitional, and classical. The conical type is of severe, classical type is of most common type. Here we could not perform genetic study, and the molecular genetic study for PLP1 protein was again in classical type. We can say that as the classical form, we can say this as classical form because the features started appearing after 2 months of life with nystagmus, which was progressive and which was again replaced by spasticity. Later signs included ataxia and impaired motor development and intellectual disability. In our case also, the same thing appeared, which started after 2 weeks of birth, and seizure was noted at 1 month of life. Here, the most common mutation noted is PLP1 gene duplication that occurs in about 70% of the population, and most common clinical phenotype of PMDE, PLP1 duplication corresponds to. So, by above history and MRI findings, we can say that the patient was of classical type of Pelizaeus much better disease. The genetic study is required to confirm it. Again, on conclusion, a male presenting with leukodystrophy can be a Pelizaeus much better disease if head circumference is normal. If a head macrocephaly type, that can be of Alexander's type. Thank you.
Can you stop? Yeah, stop sharing your presentation. Then we can see you.
Thank you, Dr. Bhushan. Please stop sharing your screen. Thank you.
Okay.
So, Dr. Bhushan, as in your case, you could not do the genetic test again. So, in according to you, without a genetic test, what will be the two differential diagnoses for your patient?
Sir, one is Alexander's disease.
Yes.
And another is Fowler's disease.
So clinically, if you know this patient was a child who came from adoption house, and you don't know the history at birth. So apart from the MRI findings, everything fits into a severe birth which can lead to all the developmental delay or the common causes of neurological deficit at birth.
Actually, the family which gave the child to orphanage, they had some documentation. Documentation was of many institutes from they came. So on taking the history in retrospective way from the documentations available, we came to know the fever was at 1 month of life, and from 1 month of life onwards, the disease progression second variation. So, on that conclusion, it is a provisional diagnosis that it can be a PMD, but we need a genetic study to confirm it, especially karyotyping and PLT1 study.
So you have to document a regression of milestones in any adrenoleukodystrophy or any leukodystrophy, which you cannot say here because it was a child came to you late from an adoption house. Thank you.
Can I ask for a few comments from Dr. Anju ma'am as she is there? I think for any neuro case, ma'am can comment on this. Dr. Anju ma'am.
Okay, Dr. Bhushan, let me ask you, do you suggest any palliative care for such children where the prognosis is not very good?
Sorry, sir, I cannot get you. Hello?
Any palliative care, like what do you tell the parents? How do you manage these children?
So the prognosis is bad in such kind of patients. We can give palliative things like we can add antispasmodic drugs, and we can delay the events. That's it. We can do that much only in such kind of cases.
Okay.
Okay. Thank you. Dr. Anju, can she join? Dr. Anju, are you there?
I think she's not there.
Okay, we can
We
go
can
to
go to the next. Hema, we can go to the next one.
Yeah,
If
so
we
can we
come
go back to Dr. Sudhir? Yeah, we can go back to Dr.
let him
Sudhir and he
finish.
can finish up
Yeah.
in a few minutes.
Yeah, sure.
Dr. Sudhir, yeah.
Dr. Hema? Hello.
Dr.
Yes,
Dhruv
yes.
Gupta.
I have one question from Dr. Bhushan, if you can allow me to ask.
Yes, Dr. Deepak, please, sir.
Dr. Bhushan, are you there?
Yeah, he's there.
Yes,
Yeah, please go ahead.
I just want to ask, you said in white matter tract disorders, leukodystrophy, generally we have spasticity, and you yourself said gradually replaced by spasticity. But in your clinical case, at no point of time the child was spastic. How will you explain this?
Initially, the child was hypothermia, and after that, it was.
किसी भी कैंडिडेट के पास कोई भी अपनी कैंडिडेट नहीं होने चाहिए.
Mr. Rohit, can you please mute everybody?
Yes, ma'am.
Hello.
Yeah.
Hello.
Dr.
Yes,
Bhushan,
please
please
go
carry
ahead.
on. Please carry on.
Yeah. The child was for period to 2 to 3 months, and initially when the child came, the child was having features of hypotonia. After that, in progression, as he was having the feeding difficulty, he used to come every week for replacement of NG tube. So after that, we noticed the child is going into spasticity. Hypotonia was gradually replaced by spasticity. So that in favor of Pelagius much better.
That's fine. Hema, we can go to the next. Thank you.
Yes, sir. So, Dr.
Thank you,
Sudhir, sir.
Thank you, Dr. Sudhir. Please go for the next.
Dr. Sudhir, please continue.
Sorry for the inconvenience I have created. Actually, my network got gone. As I was saying, when compared the serum procalcitonin on day
share
1,
your screen, please. Share your screen.
Madam, could you please ask the
Dr. Sudhir, please share your screen.
Actually,
we'll share, sir. We'll share.
Okay.
it's not fair. Hello.
Yeah. Go ahead, Dr. Sudhir.
Sir. As I was saying, when compared the serum procalcitonin on day 1, day 3, and day 7, day 3 of serum procalcitonin found to be very significant in results. When compared these serum procalcitonin results with the PRISM score, day 1 on PRISM score 3 are both of them have the similar results, but day 3 and day 7 have the very significant results when compared with day 1 and PRISM 3 score. Among all parameters, as I mentioned, day 1, day 3, and day 7 and PRISM scores, serum procalcitonin day 3 was the best predictor of mortality at a cutoff point of 3.2 nanograms per ml, with 92.80% chance of correctly predicting the mortality. And also with the increase in the serum procalcitonin on day 1, day 3, and day 7 and PRISM score, risk of mortality significantly increased with a significant hazard ratio. When come to conclusion of my study, serum procalcitonin found to be a good prognostic marker for all-cause mortality in critically ill patients admitted in PICU, and serum procalcitonin day 3 with a cutoff of 3.2 nanograms per ml is the best predictor of mortality with a 92.80% chance of correctly predicting the mortality among all of the patients. On comparing with PRISM score, serum procalcitonin day 3 and day 7 found to be superior, and also no significant association found between serum procalcitonin and different organ system involved. Thank you, sir.
Stop sharing your presentation, Sudhir.
Please, Mr. Rohit, please stop sharing the screen.
Yeah. Sudhir, good presentation. We always are looking for acute phase reactants whenever in pediatric ICU or neonatal ICU. So my question is, out of your PICU patients, around a lot of patients, 180 or so, how many of them had blood culture positives? That was, they had primary sepsis as a primary diagnosis. And how many of them were non-septic? And could you find a correlation of procalcitonin in septic patients or non-septic patients separately?
Sir, among 183, around 110 of the patients had culture positive sepsis, sir. When compared with non-sepsis patients, the serum procalcitonin value of the sepsis positive patients was relatively high, sir, but not that significantly high, sir.
So, non-septic patients who are admitted in pediatric ICU, you are saying that their procalcitonin levels were similar to patients with septic or blood culture positive with procalcitonin.
Sir,
so, how do you explain that?
Sir, not similar, sir, but the value of the septic patients, the procalcitonin value of the septic patients was very high when compared with the non-septic one, sir.
That's what exactly what we expect that septic patients are likely to have. So did you correlate separately septic patients versus non-septic patients?
Sir, but
I think that you should have done in your study.
Sir, actually, I didn't.
Dr. Deepak, would you like to ask some questions?
Thank you.
Dr. Deepak, any questions?
Was there any association of procalcitonin with patients with pneumonia?
Sir.
Exactly.
Sir, but as I told, sir, but there is specific organ system की involvement से इतना फर्क नहीं पड़ रहा है, sir, इसमें.
Okay. Single acute phase reactant is more prognostic of mortality, or if you can combine two or more acute phase reactants, that will give a better picture.
Sir, when combined with, it will give a better picture, sir.
I think in a government sector, it may not matter to you, but procalcitonin in 3 to 4 times more costlier than CRP. So if you could have done it with CRP and procalcitonin separately and shown which one is better, at least from a cost-effective point of view, it could have been a better idea. Thank you so much, Dr. Sudhir.
Thank you, Dr. Sudhir. Now we go on to the next case, Dr. Hema.
Yeah, so we now move to the next presentation by Dr. Sneha Mishra. I request Dr. Sneha Mishra to please start sharing the screen.
Dr. Sneha? Is she there? Dr. Sneha,
Dr.
are you
Sneha,
there?
please unmute yourself, Dr. Sneha.
Please unmute yourself.
Good afternoon, everyone. I'm Dr. Sneha. Am I audible?
Yeah.
You can speak a little louder.
You're not visible.
Sir, I'm sharing
Yeah,
the
yeah. Now
screen.
it's fine.
Yeah,
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 yeah, yeah. Now it's fine. Now it's fine.
yeah. Good afternoon, everyone. My poster topic is my thesis topic also. This is the correlation of healthcare associated infections in the neonatal intensive care unit with the environmental surveillance. So sepsis is basically one of the three most common causes of so just a second. Yeah, sepsis this is one of the three most common causes of neonatal mortality and morbidity worldwide, especially in the middle and low income countries. Sepsis is defined as a multi-system disorder with positive blood culture during the first month of life, and most of the authors describe healthcare associated infection, that is HAI, as equivalent to late onset sepsis, that is infection acquired after 72 hours of life. So, healthcare associated infections are of increasing concern in neonatal intensive care units due to the advancement in invasive therapeutic and diagnostic procedures, and also the increased survival of preterm babies. We have done on the basis of a study, cohort study done by Denise collaboration in the North Indian hospitals. The incidence of total sepsis was around 14.3%, from which culture positive sepsis was 6.2% in the NICU. And of the total sepsis, one third was late onset sepsis, that is after 72 hours. And the mortality rate associated was around 20 to 80%, depending upon the risk factors. So there is a wide variation in the bacteriological profile and the antibiogram of the microorganisms in the different NICUs, which is consistently changing with the time. So it warrants the need for timely surveillance of the HAI for quality and safe patient care. And there is positive in Indian studies and literature on this topic. So this study fills a substantial gap in understanding the factors associated with HAI and its correlation with environmental surveillance. And then we use the data for policy formulation, and so that we can preventively reduce the incidence of HAI and reduction of the associated disease burden on the healthcare infrastructure. The research question is same: microbes whether found in the neonatal sepsis to the neonates who are admitted in the NICU are same to the ones who are present in the environment of the NICU. So the primary objective of my study is to determine the correlation between the microbes causing the infection in the neonates in the NICU and the microbes which are present in the environment of NICU. And so I have two secondary objectives. One is to determine the demographic characteristics, risk factors, and the bacteriological profile of the healthcare associated infections in NICU, and then generate data for local policy formulation and managing the neonatal sepsis. It is a prospective observational cohort study, and the venue is the neonatal intensive care unit of Department of Pediatrics in VMMC and Safdarjung Hospital. Study population: all the newborn babies which are born in our labor rooms, and the sample size based on the incidence is 200. Neonates who develop the features which are suggestive of sepsis after 72 hours of life are screened by taking blood and CSF samples for sepsis screen and culture sensitivity after taking the written informed consent from the parents. Neonates with the major congenital anomalies were excluded from the study, and then the neonates were screened and classified into as culture positive sepsis, culture negative, or no sepsis at all. And simultaneously, the infection control sisters from our microbiology department took the samples from the surfaces of NICU, labor rooms, and also the hands of the healthcare staff, and sent to the microbiology department for characterization of microbes and sensitivities for the vaccine. Sorry. It's a sensitivity for antibiotics. And then the data collected were compared with both the data which were collected were compared to see whether the microbes are same in both the cases. And then we used univariate and multivariate regression analysis to identify the significant risk factors for healthcare associated infections. The result of my study was that 200 newborns who were investigated and treated for late onset sepsis were included in the study as group, excluding the babies with gross congenital anomalies, and 200 babies who showed the signs and symptoms of late onset sepsis but were culture negative were included as control group, and then both the groups were compatible and comparable, sorry, with respect to gender, mode of delivery, SGA babies, Apgar scores, and resuscitation methods used. And after applying the tests for significance, factors which were significant were fever within 7 days before the delivery, prolonged rupture of membranes, single unclear or more than three sterile examination, non-progression of labor, instrumental and cesarean delivery, gestation less than 32 weeks, meconium stained liquor, and IV fluids. These were the significant independent risk factors. And we also found that the enteral feeding was protective factor against the HAI. And the most common HAI was bloodstream, that was 73% of all. And gram-negative pathogens were the most common isolates, both in the as the for the environmental surveillance also. And they were resistant again. They showed resistance against all traditional antibiotics and sensitive only to reserve drug. The mortality in the culture proven cases with HAI was around 10.5%. And the primary objective was to find the correlation. So in my study, I found that the bacteriological profile of the healthcare associated infections in the NICU correlated very well with the environmental surveillance data. So I conclude that because there is a correlation with the HAI and the environmental surveillance data, there is a need of periodic surveillance, and then following asepsis practices, and then rational use of antibiotics. Thank you, everyone.
Thank you, Dr. Sneha.
Yeah, you can. So, Dr. Sneha, very relevant question: how to cut down healthcare-associated infection in an NICU, which is a very big challenge for all of us.
Yes, sir.
My question is that you did surveillance of the environment,
Yes,
in
sir.
which couple of things were done. You looked at the hands of the healthcare workers. I'm
Yes,
sure
sir.
you must have looked at the area around, like sinks and
Yes, sir.
incubators or
Yes,
warmers, everything. You said there's a correlation. So my question is, correlation was strongest with which one of them? Hands of healthcare workers or the sinks and other environments?
sir, it was
Which is the
the
strongest correlation?
strong. Yeah, yes, sir. It's strongly correlated with the hands only, sir, from the healthcare staff. The hands, the organisms which were taken from the hands of the staff.
So that re-emphasizes the point that hand washing remains the most important
Yes.
factor for cutting down healthcare-associated infection.
Yes, sir.
Second, very interesting observation which you have made is that the risk factor for HAI, onset sepsis, you have mentioned some of the factors which we normally take for early onset sepsis, like unclean examinations or prolonged leaking
Yes, sir.
PV or gestation. So how do you biologically explain that? Normally we say they are the risk factors for early onset sepsis
Yes,
and
sir.
not for the late onset. How do you explain that biologically?
So these factors are generally taken for early onset sepsis only, but since the child can acquire infection in that period and present late also, like after 72 hours. So I
So
have
you are
taken.
saying that
Yes, sir.
So you are
Yes.
saying that the first culture was negative. So when they had prolonged leaking PV, they came to an ICU, you did a culture that was negative. And then after
Yes, sir.
72 hours, they got
Yes,
illness and the culture was positive.
yes, sir. Yes,
That's
sir.
a very interesting finding which needs to be collaborated in more studies.
Yes,
Thank you
sir.
so much.
Thank you,
Dr.
sir.
Sneha, are
Yes.
mothers allowed in the NICU?
Mothers are allowed only for a certain period of time, sir. That is the feeding period, basically.
Okay. Did you take any samples from mothers also?
Yes, sir. Their hands, sir, samples were taken from their hands also, sir.
And were the residents and nurses and consultants were trained how to do proper hand washing
Yes, sir.
after the study?
Yes, sir. Yes, sir.
After the study, because still there's a big correlation. So,
Yes, sir.
because quality improvement, the idea of doing a study is to do a quality improvement.
Yes,
Because if
sir.
that problem still persists, then it's no use.
Yes, sir. After when results of my thesis came, when it correlated again, all the stuff, I had to take a small session on asepsis, maintaining asepsis, hand washing, hand hygiene, again for all the staff, sir.
Thank you.
Yes.
In view of time, can we just rush up? We have 3 more presentations, sir. So for the
can
next
we do one more presentation, Dr. Hema, and can we do the rest tomorrow because main sessions begin at 2 o'clock?
We'll just try to finish up 2 more, sir.
Right.
Yeah, we don't want to disturb the main
think,
conference.
Hema, we would be able to do 2. Kindly do 1 because they would be
So we just
testing.
have 5 minutes. We just take 5 minutes per presentation. So we'll
you
finish
do 1, but testing would start. Testing of the platform for YouTube would start at 1:50, 1:55. We are already 1:50.
We'll do 1. So then we do only 1
we'll do
today.
1 and then maybe
Exactly.
tomorrow we can start early tomorrow. Okay.
Yeah,
So
at
I just
1:30 we can keep it at 1:30 tomorrow.
Yes, sir. 12:30, sir. Okay.
12:30.
Okay.
12:30.
Yeah. So I just request Dr. Prajita Raghav to be to start with the presentation. Just a small introduction and then start with the presentation. Dr. Prajita Raghav.
Am I audible, ma'am? Good afternoon,
Yes,
everyone.
you are very well audible.
I'm Dr. Prajita, final year pediatric resident from Safdarjung Hospital. My topic of discussion is the role of serum inflammatory markers in predicting bacterial meningitis amongst neonates with sepsis. As we know, the incidence of meningitis varies from 0.3 to 3% in the late onset sepsis, and the late onset sepsis has been fairly associated with meningitis, with percentages ranging from 3 to 30%. And also the incidence of meningitis in a developing country like ours is 0.8 to 6.1 per 1,000 live births. Meningitis has long-term sequelae in the form of seizures, cognitive deficiencies, hearing problems, visual defects, and also the acute complications in the form of cerebral abscesses, hydrocephalus, subdural effusion. The clinical signs and symptoms of meningitis are subtle, non-specific, and are similar to that of neonatal sepsis and include lethargy, temperature instability, vomiting, respiratory distress, and apnea. So these non-specific signs and symptoms warrant a CSF examination via lumbar puncture to establish the diagnosis of meningitis and to identify the causative organism for the susceptibility testing. Now there are some of the factors like cardiorespiratory instability that may preclude the positioning of lumbar puncture, and there are considerable practice variations in various places which can complicate one's decision to perform lumbar puncture. Also, lumbar puncture is a procedure which has its own set of complications, causing spinal hematoma, abscess, herniation, and it can also be traumatic at times, which can cause a delay in diagnosis of the meningitis. And if such infants are exposed to empirical antibiotics, an alteration of the CSF results can occur. Also, parents can give a negative consent for this invasive procedure. So if we can predict meningitis based on the serum inflammatory markers that we routinely use to screen infants for sepsis, we can start the antibiotic therapy without waiting for the CSF results. So this was the aim of our study. We'll consider the 4 inflammatory markers, CRP, ESR, TLS, and ANC, to correlate with the bacterial meningitis. So our primary objective was to test whether there was a role of serum inflammatory markers to predict meningitis in units with sepsis, and if there is a role, then to determine the cutoff values of these markers to predict the occurrence of bacterial meningitis in units with sepsis. The study was a cross-section observation study conducted in Department of Pediatrics, Safdarjung Hospital. All the outborn neonates presenting with features of sepsis in whom LP is recommended as per the American Academy of Pediatric Guidelines, they were taken in the study. The sample size which was calculated was 234. So informed consent was taken from the parents and the neonates from the parents of the neonates who presented in our hospital with features of sepsis. Out of the 1,100 neonates who presented to our hospital, we took samples of 234 neonates, in whom the CRP values, ASR was more than 15 mm, WBC count was less than 4,000, and ANC was less than 1,800. They all were included in the study. Also, we had taken samples for CSF cyto, bio, culture, and sensitivity. And then CSF cyto, culture, and sensitivity, and we designated the infants as no meningitis, culture positive meningitis, and culture negative meningitis. So this was the basic outline of the study. After this, we made the ROC curves to correlate with the prediction of the to correlate whether ANC, WBC, CRP, or ESR, any of one, would be able to predict meningitis or not. It was found that there was no significant. It was found in a study based upon the ROC curves that there was no significant association of any of these markers with meningitis, with a p-value of more than 0.5. Out of these markers, the highest sensitivity was that of WBC, which had the sensitivity of 92.79% to detect meningitis, and the highest specificity was found with CRP to detect with a specificity of 76.92% to detect meningitis. So in conclusion, it was found that none of the 4 serum inflammatory markers which were used in our study have the discriminatory power to predict meningitis among neonates, and hence we cannot make any kind of values for these markers. To establish bacterial meningitis. So lumbar puncture has to be performed. There is no substitute for that to detect meningitis in infants. Thank you.
Thank you, Dr. Prajita.
Dr. Prajita, very interesting study, but I'm very happy with the results that what we have been saying that CSF examination is very important. My question is very simple. How did you classify meningitis? It was only CSF culture positive, or you also took those patients who are CSF culture negative, but biochemical or cytological expression of meningitis? What was your gold standard?
Sir, I have taken the culture positive meningitis also, and the patients who were positive based upon the CSF cyto and the bio.
So that means you have your gold standard is any meningitis, whether it is culture positive or it is culture negative, but cytological biochemical positive.
Yes, sir. In my study, I have included meningitis as the child who was culture positive, also who was cytobio positive.
So I will request you that if you can redo your analysis only for culture positive CSF examination against these markers, and maybe you bring out more number to give you better value of this study. Thank you.
Dr. Prajita, was procalcitonin levels done in these patients?
No, sir. Procalcitonin level was not done because, sir, in this study, I used those markers only which we routinely use for the neonatal sepsis screening, CRP and ASR and WBC, which was available in the hospital.
Because in another study from your institute, procalcitonin levels were done to predict the
So somehow pediatric ICUs procalcitonin used more, but NICUs we don't use much. That is.
Okay. Sir, actually, we wanted to do. No, sir. Actually, I wanted to do such a project so that neonates are not exposed to extra amount of blood samples. This was the rationale, because just unnecessarily for the sake of study.
Really, because once you take the sample, then you can do any number of tests.
Yes, sir. But sir, this was not done in my.
Okay.
Thank you, Prajita.
Thank you.
So, Dr. Deepa, do you want to ask a quick question?
One question, Dr. Prajita. Is there any role of LDH in assessing the severity of newborn condition also?
LDH.
Because there are studies going on which says that if we can do LDH early in the course of the disease, we can predict the severity of the neonatal disease.
I think LDH is a marker.
I don't have any information.
Okay.
Thank you, Dr. Prajita. So I think in the best interest of time, we can wind up today's session. Dr. Manish, Dr. Smita ma'am, I think we have to begin tomorrow early because we are left with many presentations. So if we can start tomorrow at 12 o'clock, it will be great.
Yes, I talked to
That's
Rohit
better,
and we'll
I
come
think.
back. So we'll come back and evening we have to do it, obviously, yes.
And there are some technical
Rohit?
glitches also, and so the resident who's presenting should not be disheartened. He should be able to present well and discuss.
Rohit?
Yes,
Are
ma'am.
you there? So what are your thoughts?
We have 10 more presentations, so I think we have to start up early tomorrow.
Yes.
Yes, ma'am.
Okay.
Okay.
So Rohit is in
Rohit, tell
charge.
us when you get us YouTube live.
Sir, within 5 minutes.
Okay.
Okay, Dr. Hema, I have one suggestion for that. So last time, could you hear, please?
Yeah. Please go ahead.
Please go ahead.
Sir, I have one suggestion because there is only poster and there is a small free paper presentation. So I have a request. So after one poster, there should be only one judge should ask. Otherwise, it will get prolonged. So we have to take it by rotation, like Dr. Pankaj with the first, Dr. Ajay with the second, Dr. Ankur with third. So that's where we can save the time. So last time we did like that only. That will save the time. Okay.
Yes, actually. So the people who were there today, we won't. We will give chance to the next team for tomorrow,
Yeah.
and we'll
So
restrict the questions.
Yeah,
we'll take
can,
rest tomorrow.
yeah, you can add the name of the judges along with the list, that name.
Good afternoon,
Yeah,
Samita
sure.
madam. Good afternoon,
Namaskar.
everyone.
So we can wind
welcome,
up the
sir.
session over here.
Good afternoon.
Welcome, sir.
Good So we are right in time.
Yeah.
Morning session was very nice. We really enjoyed it thoroughly. It was a great success, I must say. हेमा जी बहुत बढ़िया काम कर रहे हैं आप. Every one of you, they are really working very hard. And
Thank you,
so
sir.
happy.
They have done wonderful job. Actually, it was a really
Whole
they
team
were double
is
shooter
very-
for this poster session, of course.
Whole team is very cohesive, and you know all are willing to work. Just एक होता है इशारे की जरूरत होती है. I'm thankful to you, Pankaj. Thank you.
Thank you, sir. Thank you.
Thank you, Ajay. Thank you, Pankaj. Thank you. sir.
Thank you. Thank you very much.
Hello,
We
Dinesh.
are always
How are
with
you?
you.
Hello.
Welcome, 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 all of you.
Dr. Neeta has joined.
Dr. Shalini has joined.
Nee, Dr. Neeta Radhakrishnan.
Nata did
Yeah, that is.
Oh, Tapisha is taking care of everything. I think.
Tapisha is, she has called up most of the people and they are there. Only Vikas Chandra ka saath wo bhi connect ho rahe hain.
I have called Dr. Neeta also. She is going to join and I'm calling her again.
बस एक दो मिनट वेट करते हैं.
हाँ हाँ और चेयरपर्सन्स को भी बुला लिया है सबको.
ठीक है. Very nice, Prashant.
Yeah. Hello, Dr. Prashant.
हेलो.
डॉक्टर साहब आपका ना हाथ आ रहा है कैमरे के आगे. आप कैमरे को टर्न कर, फोन को टर्न कर लीजिए. टर्न कर लीजिए आप.
Hi, Tapisha.
Hi, ma'am.
Hello.
Hi, Dr. Prashant.
Hello.
Hello, Tapisha.
Hi, Dr. Prashant.
Hello.
Hello. Hello.
Good afternoon, everyone. Welcome.
Yeah.
Good afternoon.
Dr. Smita, शुरू
Good
करें.
afternoon.
Dr. Smita, please start.
Please start.
Okay. So, good afternoon, everyone. This is the third day of PCNI NIPID, and we are just over with the morning session. After that, the posters, and everything is going very smoothly, and only because of our IAP Delhi members as well as executive board member. I'm really thankful to all of you for this cooperation and coordination. I invite Dr. Ramesh now, our Honorable Delhi IAP President, to further take up the proceeding.
Okay, thank you so much, Dr. Samita. It was a wonderful, to have all of you here in front of me. I can see these are the luminaries of IIP Delhi who are working with us, and we are shaping it very well. For the last 2 days, both the programs, they have went off very well. In the morning, we had more than 200 delegates in the morning itself, morning time 8:30 to 9:30, and the talk on digital talk and talking about e-learning and talking about skill building through e-learning. That was a great talk given by Dr. Devrari and Dr. Sunita Maheshwari ji. And now we go over to the afternoon session and we start with it. I'll request scientific coordinators to go ahead with the proceedings. Dr. Tapisha, you can take over.
I'm starting the proceedings.
Okay.
So, welcome everyone on the third day of this grand event PCNI. And as Dr. Naab and Dr. Smita have been working so hard, so they are our big motivators for the whole event. And everyone is combining efforts to make it a success. And it has really been so. So, we start today's proceedings. And for the first talk, I invite Dr. Devinder Mishra, Dr. Dinesh Sahai, Dr. Ajay Kumar Gupta, and Dr. Amit Tyagi to chair the sessions for the talk by Dr. Neeta Radhakrishnan. Dr. Devinder Mishra needs no introduction. He is professor in pediatrics in MAMC. Dr. Dinesh Sahai also you all know well. Dr. Ajay Gupta is our old doyen and Dr. Tyagi is from BLK. So over to the chairpersons to hand over the next.
I request Dr. Dinesh Sai to please introduce the speaker.
Thank you, Dr. Ajay and Dr. Nav and Dr. Prashant for such a nice organization of this conference. Really wonderful for last 2 days going on. Today at this time, Dr. Neeta Radhakrishnan, Madam, is a very senior consultant of hematology and oncology in Super Specialty Hospital of and PG Institute of Noida in Sector 30. And she's a very renowned person in the hematology and oncology and immunology. And she has many papers on her credit, at least 42 papers and many chapters, 15 chapters in different books. So I invite Dr. Neeta Radhakrishnan for this very important and very interesting talk which she is going to give on immunodeficiencies. Madam Neeta Radhakrishnan.
Good afternoon. Good afternoon, sir. Thank you for the kind introduction. I'll share my slides. Can you see the slides?
Yeah,
Yes,
yeah.
very well.
Everything
Very
is fine. Yeah, everything is fine. Go ahead, Neeta.
Good afternoon, everyone. I thank IAP Delhi, the organizers of PCNI and NIPID for this kind invitation. And the topic given to me is this time is how have I missed an immune deficiency? Over the next few minutes, I think we'll go through some cases where immunodeficiency was not thought of initially, but came up as the final diagnosis. So I work in this institute, like Dr. Sahai just mentioned. So immune deficiencies initially were called primary immune deficiencies. Now the terminology has changed to human inborn errors of immunity, like inborn errors of metabolism. Now these are called inborn errors of immunity. And inborn errors of immunity. See, we need the immune system for fighting infections, for fighting malignancy, and for fighting autoimmunity. So if somebody has an autoimmune disease, that just means that their immune surveillance system is not working, or there are clones of cells which have escaped the immune surveillance in the body. So any child or a person with autoimmunity would essentially have something which is deficient in the immune system of that person. And there are new groups of disorders like immune dysregulation and autoinflammation, which have also come up in the recent years. When I say come up, these are all being recently diagnosed. So this is one favorite quote which I usually use, that the beginning and the end were always there before the beginning and after the end. So this is from T.S. Eliot. So that just means that there is a continuum, there is a continuous process. And when we see a patient, when we see a child admitted with us with a particular disease, that's just one part of that continuous process. So there might have been something which started off before, or their child might evolve into something later. And that is essentially what immune deficiency is all about. It's essentially identifying the pattern in which the child has come and seeing whether there's something more than what is actually meeting the eye right away. So currently, as per the International Union of Immune Deficiencies, more than 400 genetic defects have been classified, all of them monogenic disorders, and more than 400 phenotypes have been defined. So if a child presents like this is a particular phenotype, you have to suspect this. So that kind of definitions have come up, and all these have come up in the recent years because of the advent of next generation sequencing that is available to us for identifying these mutations. So before I start, a little bit of introduction on what the immune system is all about. So as we all know, immune system starts from the bone marrow. Bone marrow has myelogenesis, red cell, as well as platelet production occurs inside the bone marrow per se. A bit of lymphocytes are produced there, and finally lymphocytes mature into B lymphocytes in the bone marrow itself and secondary lymphoid organs. Whereas the T lymphocyte, after the initial development, it goes to the thymus and further development occurs in the thymus. So we can imagine all these, any disorder pertaining to these disorders. So whether it is like any hematological condition, any malignancy, a child with autoimmunity, all of them would have a direct link to immune system, and that is what is how these presentations of these disorders are also through the immune deficiency pattern. So this is the current classification. And for people who have been following immune deficiency would know that initially there were 6 groups of disorders, then they evolved and may become 8. And now they've included bone marrow failure disorders and something which is interesting called phenocopies also in the current classification system. So essentially, if you have B cell and T cell deficiency, that is called combined immune deficiency. So combined immune deficiency, if it is like a normal, a SCID-like phenotype, it comes in the first group, whereas a combined immunodeficiency with some syndromic like Dijot syndrome, etc., would come here. A patient would have predominantly B cell deficiency only, would be antibody deficiency. Then there are HLH-like conditions or immune dysregulations, phagocytic disorders, which would be essentially neutrophilic disorders and macrophage disorders, functional disorders there. Intrinsic and innate immune system disorders, again, new conditions which are coming up because of signaling pathways or cytokine disorders, and these are not rare at all. So the cases which I'm presenting today are only the ones which are difficult cases from 2019. So these are not rare at all, and this is all amongst us. Then immune autoinflammatory disorders, children who have repeated fevers and essentially would be seen by pediatricians, and when there are joint symptoms, they would go to rheumatologists for evaluation. Complement disorders, again, coming up with repeated infections or very early onset autoimmunity. Marrow failure comes to a hematologist, and phenocopies is a different condition where there are some acquired disorders which are going to present like primary immune disorders. The problem is that we fail to recognize as clinicians. It's not obvious always. There is nothing which is phenotypically evident immediately on presentation. So unless we think about it, it's not very clear. Even when we think about it, we don't know how to get these investigations done. It's quite difficult. It requires a lot of collaboration to get to a final diagnosis. Early diagnosis definitely helps us in saving life of the child, or saving, at least in the when I usually tell for parents to invest in that investigation, so that if it is an expensive investigation, for that at least this can be prevented in the next birth. And of course, if you identify early, you would save an organ, especially in many conditions, it is the lung. So by the time children come to us, they're already having chronic lung disease or chronic liver disease. And after that, there's no point really even doing anything, any definitive treatment, because even the child is already has an organ which is completely damaged. So these are the compartments of the immune systems. You have the innate immune system with which we are born with, which include the phagocytes and the complement system. Then the adaptive immune system, which includes the B and the T cells. So here we'll just briefly see, I'm not going into the approach part at all, but just to make a discussion interesting. So B cell disorders, you would they would generally present with recurrent bacterial infections, sometimes giardia, and sometimes exaggerated response to a viral infection like a enteroviral infection, especially meningitis or polio, paralytic polio, etc. These can be the presentation of B cell immunodeficiencies. And here again, just a plain CBC and an immunoglobulin profile, which is available in almost every town of our country. This can be done easily, and that can actually guide us towards further diagnosis. Why I'm saying this is many a times diagnosis is delayed by 5 years, 8 years. Then at that point, then there's no point in diagnosing it further for that particular child. And if we are suspecting a simple B cell enumeration by flow cytometry, again, flow cytometry is not difficult these days to get to a diagnosis. If we are suspecting a T cell disorder, T cell disorders usually present with, since T cells are kind of the overall controllers of the immune system. If you have a T cell defect, you can have bacterial, viral, fungal, protozoal, mycobacterial. Any of these infections are possible if these children who have very severe T cell deficiencies. That is why they're going to present very early. They at times present with severe viral infections. They present with cryptosporidia, almost like HIV, how HIV presents. Except that these are going to be very early in life, that just less than 6 months of age. And here again, CBC testing, very, very useful, because there will be lymphopenia, which is very obvious. And if we have absolute lymphocyte counts which are low, a subset analysis, which includes TB and NK, can be easily done. And this is again another presentation, how these babies, SCID babies, are going to come to us. And many of these babies would have failure to thrive as a definitive feature. Third is children who present with phagocytic disorders. This I said, which includes neutrophil, number and neutrophil function. So neutrophils are required for what all infections? They are required for bacteria and for fungi. So these are two things for which neutrophils are required in our body. So among bacterial infections, you could have these particular type of bacterial infections like Pseudomonas, Nocardia, Salmonella, etc., which are very, very specific through the neutrophil and the reactive oxygen species pathway, how these infections are handled in our body. And among fungi, we have Aspergillus also, which can cause these defects can also cause repeated aspergillosis. And these children, again, first thing you do is just to, in the CBC, look for a neutrophil count. If you have neutropenia, then go ahead along with the evaluation of neutropenia, like bone marrow evaluation further. If the neutrophils are normal to high, then again, two simple tests. One is nitroblue tetrasolium, which is a slide-based test, which can be done easily in the pathology lab. And DHR is a flow-based test. Again, not so difficult at least in the major cities. So these investigations can guide us to what is called CGD, chronic granulomatous disease, which is again a functional disorder. And finally, we have complement disorders. They present with bacterial infections like Neisseria meningitis. So any child who comes with Neisseria meningitis infection should have a complement levels tested. And some of these complement disorders, like the early complement disorders, can come with SLE. So early onset lupus, early onset autoimmunity, then also you suspect children with complement disorders. So what helps us in reaching a diagnosis is, of course, at the age of the onset. If the child is coming less than 6 months versus after 6 months or after 5 years of age, we do know how different parts of the immune system is going to present. Whether it is a boy or a girl, a gender and a family history has a lot of helps us in a lot, because many of these disorders are X-linked. Again, to narrow it down, it becomes easier. So, but what helps in practice is to see what is unusual in that case. So if you think that this is not a pneumonia which is normal, or this is not a child who is normal because after every diarrhea he's going to come back with another episode of diarrhea. So that kind of unusual pattern is what we should be looking out for. Any disease, so any specialty. So I do hemato-oncology. For me, a child who is leukemia on treatment not responding, or a child who is leukemia on treatment having a lot of infections, an ITP child having a lot of infections, a child with autoimmune hemolytic anemia with infection. So all of that is unusual for me. So similarly, a child with another autoimmunity, say you have a nephritis with a hemolytic anemia, or a nephritis with a leukoderma, vitiligo. So these are multiple autoimmunity, children with multiple optim. So all that kind of unusual pattern can be looked out for. And if possible, whether we can identify a particular compartment, like based on this pattern of infection, like if it is always aspergillosis, or if it is always mycobacteria, can we kind of point down to this is this, and then go ahead with further evaluation. So these are the only things that actually help us in practice, because phenotypically many of these children are going to look normal. There are no classical features that we look out for while examining these children. Age, I said, is helpful. There are particular disorders like SCID and some neutrophilic disorders, phagocytic disorders that come very early in life, because these are innate immune system that should be present at birth. And if it's not there, they're going to present with features immediately. After 6 months of age, most of the antibody deficiencies come up here, because maternal antibody is out of the system. The baby should have started producing antibodies by now, but that is not there. Then they start presenting. And after 5 years, some of the lesser severe disorders like specific antibody disorders or CVID, etc., can present. And like I said, gender helps in a lot of these genetic disorders. And always ask for family history of not only infection, but also ask autoimmunity and malignancy. You often have uncles who have malignancy, or maternal history as an X-linked history of disorders in the family, or other children who have had similar illness. Now we'll see case by case. So we are going to see few cases who presented with infection as the primary matter, and how the diagnosis was missed initially. So this is a 7-year-old boy. He's the 5th born in the family. So you can see that previously two male children have died, and there are 2 girls who have been okay. So very, very striking history from day one. A normal birth weight child, but he's been symptomatic since 9 months of age. And what are the infections that he has had? He has mainly had respiratory illnesses, which have started at 7 months of age, multiple respiratory infections. So many times, practice is that we give a lot of antibiotics initially. After a while, we know that the trigger, when they're going to have repeated infections, then many of them get labeled as asthma. And even having bronchodilators or something which is given constantly, inhale corticosteroids, etc., do help these children also. So many of these children already are diagnosed and branded as this diagnosis before they, as asthma, before they come to us. So he is, since the last 4 years, from 3 years of age, he's been having persistent of difficulty in sleeping, early morning wheezing, all that's going on. Only the dose of MDI has been tapered multiple times, as in modified multiple times. Other than this, what else does he have? He has recurrent ER discharge. Again, none of them has been cultured so far, always given antibiotics. And 3 hospital admissions till 2019. And there were ICU admissions as well in this. 1 episode of fever without focus was diagnosed as meningitis and treated, and another dengue episode, which was uneventful. At 7 years, finally, the pediatrician who referred found the child had a low IgG and was advised IVIG prophylaxis. But before 7 years, how many infections? Probably at least 1 infection every month or so. So this kind of presentation, such severe phenotype, right, living very close to a metro, even then not getting a diagnosis. And even though they were advised IVIG, they did not start at the time of presenting to our center. So if you can see height for a 7-year-old child, the child is not growing well, no phenotypic features. Child already has baseline tachypnea with saturation is 94% in room air with wheeze and no other organ involvement. And these are the basic investigations that you do. When you do CBC, you can see that the neutrophil count is slightly low, which is again not too low, as in it's for 9,800 in a child who is repeatedly infected. I would have probably expected it slightly high. But more importantly, the absolute lymphocyte count. The lymphocyte count is normal. The lymphocyte count is normal. For me, what is the clinical diagnosis? It would be B-cell antibody deficiency only, because it's presented late, because it is a child with recurrent cyanopulmonary infection. So that would, a B-cell defect is the phenotype that the child has come with. But there are some red herrings in this case. So anyway, so when you do a baseline CBC, absolute lymphocyte count is normal. And if you look at the immunoglobulin levels, your immunoglobulin A and G are low. IgM is on the higher side. So that is not a good thing. So if it was a B-cell antibody deficiency, plain and simple, explained A-gamma globulinemia, it should have had low IgM as well. Again, these are simple investigations you do in the morning, you'll get the report by afternoon. What about the next investigation? Lymphocyte subsets. And when you see lymphocyte subsets, this is not something I did. This test was done 2 years prior also, but at that time, no treatment was started. And so this lymphocyte subset, there was some B antibody deficiency, which was B as in B cells were on the lower side. And that's probably why he was advised IVIG later on when the child presented. But then again, not very low. In B antibody deficiency, this is usually less than 2%. So when you don't have severe B antibody deficiency, suspecting X-linked A-gamma globulinemia would be fallacious. So this is the condition. So this is the gap in diagnosis is, despite recurrent infections and the being labeled as moderate asthma, primary immune deficiency was not thought of at that point. And the child has had growth also affected and a strong X-linked history. Despite that, that was not done. And even when diagnosed, it was labeled as B-cell deficiency and looked further, because even despite having a B-cell enumeration, which was not very low. So final, when you get the genetic evaluation done, this is a combined antibody deficiency. And what difference does it make? What difference does it make whether it is X-linked A-gamma globulinemia or X-linked hyper IgM syndrome? There is a whole lot of difference. X-linked A-gamma globulinemia is a reasonably easy to manage condition where you can have IgG replacement will keep them okay, provided you start early, not after like chronic lung disease has set in. But generally these children do well. Whereas X-linked hyper IgM, the children, they require, in addition to, it's a T-cell disorder, it is not a B-cell antibody deficiency, and these children would require early BMT to get them through. And this was not done, and now he has actually passed the time is over, and now with the CLD in place, it would be very, very difficult for him to get to further evaluation. So this is how the B-cell antibody, B-cell development is. So early in the development, this is the mutation pies, this is the difference. So this is the difference. X-linked A-gamma globulinemia comes here, whereas hyper IgM comes a little later. And in hyper IgM, the primary defect is the conversation between a T-cell and a B-cell is defective. And that is why primarily it is called a T-cell defect. It's going to behave like a skid to us. Another case, a 2-year-old boy from Meerut. Again, the growth centiles itself show us that the child was born normally, but then he is falling off the charts. When you look at infections, pneumonia was treated as GER also initially. By 1.5 years, he has had fever, cervical lymph nodes, and lymph nodes aspirated Staphylococcus aureus, and he's out E. coli. Again, bacterial infections primarily, but multiple infections, and even as in 2 of these infections should have been good enough for a further evaluation. So finally, the last center where he was at, he was suspected to have SCID, and he was given IVIG, and then he was referred. He was febrile, again hypoxic in room air. By the time the child is presenting, it's already too late. It's hypoxic in room air, failing to thrive with oral candidiasis. This is a typical SCID phenotype. As in this is how children present with SCID. This is children who are failing to thrive, oral candidiasis, respiratory infection. We should be catching them before they have respiratory infections which cause hypoxia, which is usually PCP, CMV, or any of the other viral infections that cause interstitial lung disease. So this is the presentation, and this is the suspicion also. The final suspicion at 2 years of age is SCID, but there are some problems in the diagnosis. So if you see SCID, we should have had lymphopenia. Lymphopenia is not seen here. So here again, absolute lymphocyte count is not too low. Immunoglobulin levels, if you can see, immunoglobulin levels aren't low either. So if a SCID patient should have bang low, IgA low, IgM low, IgG low kind of presentation, but at 2 years, if his immunoglobulin levels is not low either. So when you evaluate, again, any evaluation of child with any primary immune deficiency would be investigations for infection, investigation for the disease per se. So infection investigations, again, many more bacteria came up, Klebsiella, Mycoplasma, E. coli. So unusual that a SCID baby who is going to come up with so many bacterial infection, nothing viral is coming up at all. Again, lymphocyte subset was normal. So the gap in diagnosis, of course, it's that there was recurrent infection and mislabeled as GER initially, not picked up by 2. As in 2 years is almost the maximum a SCID baby will live. No, otherwise they usually are, it's a fatal condition by 1 to 2 years of age. So it could have been picked up early, but somehow it probably they did not follow up also properly. So early missed diagnosis again, even when the child was failing to thrive. Second is lymphadenopathy. Lymph nodes are generally not seen in SCID and B cell deficiencies also. But here you had large lymph nodes, there some aspirated Staph aureus also. Despite that, did not think further. So it could, again, thought of as SCID, good, but there could have been something else which have been underlying. So here we had neutrophils which were a little on the higher side. Lymphocytes were normal. Lymphocyte subsets were also normal. So final diagnosis, just a plain simple NBT test will show you that NBT test shows 0% activity. It was chronic granulomatous disease. Again, a severe condition, presents very early in life, and X-linked disorder. And the only thing we can actually help the family is to prevent another birth because it's already too late. The second group of conditions I want to show you is highlight is autoimmunity. Autoimmunity presenting as a presenting feature of an immune deficiency is being increasingly diagnosed, and lot of conditions. So many of them is as in it's in parallel with rheumatology presentations as well. So I'll focus on some of the cytopenias that have come up. So this is a 17-year-old girl, repeated infections from 2 months of age. And at 17 years, you can see what is her weight and what is her height. And again, respiratory infections predominantly on a lot of inhalers, multiple life-threatening infections till 4 years of age. Finally, at 4 years of age, child was shown to a center in Delhi where she was diagnosed as SCID and started on treatment. And she's been on treatment since then. What happened later? At 7 to 8 years of age, she's had an episode of autoimmune hemolytic anemia. So not unusual for CVID to come up as AIHA. The only thing unusual is that CVID usually does not present less than 2 years of age. It is again an antibody deficiency, which is relatively easier to manage. But this is a very severe phenotype, which has come from 2 months and with so much of FTT. So this definitely is not a CVID, a classical CVID phenotype. So here again, AIHA, multiple centers have seen the child controlled on antibiotics, steroids and immune suppressants. And after like 8 to 8.5 years of age, this medicines were tapered and steroids were slowly taken off. And no further evaluation was advised for AIHA at that time. Later, since 10 years of age, like for the last 7 years, she's been having these kind of lesions in her leg. And this was variably diagnosed as cutaneous tuberculosis, multiple skin biopsies. Every time there is a granuloma, and some bacterial infections also keep getting cultured from here. This AFP was never seen any of this. None of the cultures showed AFP, none of the biopsies showed AFP, but still she's been on ATT for a very long time. And again, drug-induced hepatitis and a lot of ancillary problems along with the ATT. So if you see her, she has a little bit lower absolute lymphocyte count, not very low. Immunoglobulin A is low, M is low, and since she's on IgG replacement, you can't really interpret the IgG level. But pan, hypo, gamma, because all these three are low, and E is on the higher side. So E coming up high, only very few conditions in immunodeficiency have very high E, that is seen. And the subsets which were done earlier from the other center were shown low B and normal T cells. And so initial diagnosis, again, in this case, till 4 years of age, absolutely no diagnosis. And an AIHA also, which was there as a red herring, but then no further evaluation. And even when we are diagnosing a CVID, such severe FTT, such a normal ALC, not very low B cells, all of them were actually pointing against a CVID phenotype, and the fact that she's still getting infections despite being on IVIG prophylaxis. So these are conditions which tell you that this is not a straightforward CVID, and this actually was SCID. But why did a SCID survive more than 2 years of age? Because this was a SCID with a hypomorphic mutation, and these kind of babies are called Omen syndrome, and they present with lymphadenopathy, a lot of inflammatory features which come up along with SCID, infections with inflammation and hepatosplenomegaly, skin rash, all the very classically described in Omen syndrome. But the point is we are too late. At 17 years of age with so much of morbidity, there's hardly anything that can be done. If this baby was diagnosed, say, in infancy, probably some therapeutic intervention like BMT could have been done. Although she's an adopted child, I don't know how we could have gotten a donor, but an unrelated donor could have been a possibility. So that is why a correct diagnosis and a timely diagnosis is very important. I'm skipping the slides on approach to a SCID. I've just put it. I think the recording will be available later. A simple CBC tells us that there is lymphopenia in SCID, and SCID is something which is going to come through pediatricians only. It's not going to present with any other specialty. So immunoglobulin assay, if we are having repeatedly sick babies, immunoglobulin assay and a low lymphocyte count should be done. And if we are having low lymphocyte count, an immunophenotyping can be easily ordered, especially in the metros. And X-ray will help you. X-ray can show absent-thymus. It can show costochondral junction being prominent in certain variants of SCID. And genetic evaluation again can be done, not necessary for diagnosis, but it can be done easily. And another, so this Omen syndrome variant is going to come to us with this kind of skin rash, dry, scaly skin, and alopecia. So these are the differential diagnoses which are usually thought of early before SCID is actually atopic dermatitis or biotinidase deficiency. Atopy, especially because IgE is going to be high in these babies. So eosinophilia, raised IgE are all features suggestive of Omen syndrome, and a very difficult phenotype to treat. But if we pick them up early, they can be managed. So children who come with autoimmunity, if they are early onset, if they are persistent autoimmunity, if there are multiple systems involved, if they are refractory to treatment, or if you have autoimmunity with infection, like in this case, you have some AIHA going on, parallelly granulomas going on, parallelly respiratory infections. So then you think of there is something underlying. And finally,
Dr. Nita, you have last 3 minutes.
I'm just finishing it. So this is a child who was diagnosed as a standard risk ALL, and he has been started on. So this is an 8-year-old boy, previously well, but the infection profile while managing is horrendous. You have sepsis, fungal sepsis, multiple skin abscesses, pneumothorax, meningitis, this kind of presentation. So even though ALL per se could explain many of this, but it is not plain and simple ALL, and it turned out to be a marrow failure syndrome, which has autoimmunity called SAMDL9, one of the recently diagnosed marrow failure syndromes. And another one, GATA2, which was published also earlier. So this is a myeloid leukemia child with warts in his skin. It can mimic, PID can mimic multiple other conditions. So this is a recent child who was referred as JMML from another center with severe anemia, transfusion dependent state, finally turned out to be Mendelian susceptibility to mycobacterial disease. And another child referred as Hodgkin lymphoma, multiple lymphadenopathy, and biopsied also, but a simple investigation, that is a CBC, showed that it was severe neutropenia. bone marrow showed it is severe neutropenia with neutrophilic arrest suggestive of congenital neutropenia. So these are simple investigations that would tell us, and the child is absolutely well prophylaxis. They don't have another sibling for transplant. So this is my only take-home message there. So when we think, we are very comfortable with many diagnoses, but at times we have to look out of the box. When you hear hoofbeats, the thing that comes in your mind is horses, but start thinking about zebras also. Zebras also can present with hoof, they can also cause hoofbeats. So this is taken from the Immunodeficiency Foundation of North America. It is their logo. So this is probably the only take-home message from my side today. Thank you very much. I'll be happy to take questions.
Thank you, Dr. Neeta, for such a wonderful presentation. House is open for questions. Dr. Pankaj has asked one question. Should we do immunodeficiency screening in all culture positive patients in NICU and PICU?
So that depends on the type of culture positive. If it's a standard infection that we usually see in NICU PICU setting, definitely no. But if you have had children who had presented with infections earlier, if this is part of a long process of infection, like a child improved, went home, came back with a persistent pneumonia, that kind of presentation, definitely investigate. If you have an abnormal organism, like if you are getting chromobacterium violation, if you are getting nocardia, they have no business in a PICU setting unless there is an immunodeficiency. So there are fungi if they are coming up. Candida comes up very frequently, which is okay. But if you are getting aspergillus, if you are getting any other fungi, definitely immune system has to be looked into. So it's basically a combination of the type of infection and the history that we are getting.
Dr. Neeta, please stop slide sharing.
Oh, sorry.
I think best is to keep it in back of your mind whenever you see a child coming with repeated infections, especially severe kind of infections or unusual infections.
Yes, sir.
So, any other comments by our respectable chairpersons?
So yes, I just wanted to thank. We suspect it early and try to prevent the hand organ damage. So maybe by providing prophylaxis, antibiotic or immunoglobulin, and refer it early to the specialist.
I think a lot of end organ damage is correctly said. It's the most important thing. Like if we have, for example, nephrotic syndrome, if we have children who are not responding, then there is something else that should be looked into. HUS, TTP, all of them have underlying genetic mutations now. So this is that, and that unless you treat that, this child is never going to get better.
Thank you, Dr. Neeta.
So thank you all the chairpersons. And now we proceed to next two sessions that are dedicated to allergy. The first session is anaphylaxis at my clinic is by Dr. Vikas Taneja, and second is allergy testing by Dr. Neeraj Gupta. For these, I invite chairpersons, first Dr. G.S. Kochhar. He is a well-known figure in West Delhi, and he's the HOD of Agrasen Hospital, and otherwise a very jovial person. In our physical meetings, we always enjoy his company. So we are missing his company these days. Next is Dr. Shikha Mahajan, Dr. Shalini Goyal, and Shravan Gupta. Dr. Shalini Goyal is, of course, Secretary IAP North Delhi, everyone knows. Dr. Shravan, and she is Director and Senior Consultant at hospital. And Dr. Shravan Gupta, he is present EV member IAP Delhi and practicing in West Delhi for 28 years. And Dr. Shikha Mahajan, she is a Senior Consultant Pediatrician at BLK Super Specialty, and she is a National Facilitator for Adolescent Health and National PAS Instructor. So I take it over to chairpersons, please. Dr. Kochhar, please.
Introduce the speaker, Dr. Vikas Taneja. Rohit,
Dr.
can
Kochhar,
you see Vikas Taneja CV slide?
Yeah, it is there. Rohit shared Dr. Vikas Taneja's CV slide. Dr. Kochhar had joined. He was attending the previous talk.
He was here.
Hi, sir.
Dr. Kochar is not able to. Then we can introduce Dr. Vikas Taneja. Rohit, please put Dr. Vikas Taneja's slide, CV slide.
Actually, he is putting my presentation slide.
Dr. Prashant, you can introduce, as sir is already showing his, and everyone knows Dr. Taneja sir.
So,
We have learned so much, sir. You can
this
just
HOD pediatrics.
introduce and sir can start. Please,
Yeah,
Dr. Taneja sir, start please.
Okay, thank you very much for giving me this opportunity to speak in this session. I will not waste much time, and I will straight away go to my presentation. Is my screen visible to everyone?
Yes.
Yeah. Okay. Okay. After this nice talk on immunodeficiency, we'll come to a more easily a topic which is common to to pediatricians. So we'll be discussing anaphylaxis in OPD practice. So we all know anaphylaxis is a severe life-threatening systemic hypersensitivity reaction to an allergen occurring within 1 hour of exposure to an allergen, and it's usually IgE mediated, which leads to mast cell and basophils activation and degranulation. Now it produces a combination of symptoms involving the skin, the respiratory system, the cardiovascular system, the GI, as well as the neurological symptoms. Skin and respiratory symptoms are the most common, and especially if there is respiratory involvement, it may cause death by airway obstruction, or if there is a cardiovascular involvement, then it can lead to a cardiovascular collapse. So when we say anaphylaxis, we can term it as an allergy, but yes, when we see a hemodynamic collapse, that is anaphylactic shock, that becomes a more serious condition. Pediatricians, we encounter anaphylaxis in our clinics, but these are usually milder allergies. But anaphylactic shock, it's definitely a rare thing that we encounter in our practices. But yes, a child may arrive at a pediatrician's office remote from an event, or with active symptoms, or they may develop anaphylaxis in the clinic itself, particularly especially with the vaccinations which pediatricians we commonly do. So both pediatricians as well as parents, they need to be prepared to recognize and quickly treat anaphylaxis to prevent the potentially catastrophic outcomes. Now, coming on to the etiology, the most common reasons for anaphylaxis seen in children include foods like peanuts or legumes, particularly then eggs. Then it can be cow milk allergy, shell fish. Then other common group is medications, particularly antibiotics, then NSAIDs. So children can react to that. Then venoms, particularly fire ants or bees or wasp stings. And for pediatricians, the most commonly thing what we talk about is the vaccines. So these are the most common thing. Besides that, yes, there can be many other reasons for anaphylaxis, but these are the most common which we see in practice. Now, coming on to the pathophysiology, yes, anaphylaxis can be IgE mediated reaction, or it can be a non-allergic mechanism. IgE mediated usually is when the body gets exposed to an allergen, the mature B cells, they produce specific IgE antibodies to that allergen. So these IgE antibodies, they bind to the mast cells and the basophil receptors, and this is what we call as the sensitization of the mast cells. Now, on re-exposure, these allergens, they cross-link the two specific IgE receptors, creating a bridge, and this results in mast cell degranulation. So with degranulation, what happens is there is a release of preformed mediators like histamine and tryptase, and later on, more mediators are formed, particularly prostaglandins, leukotrienes, and thromboxanes A2, and they result in the clinical manifestations of this IgE mediated anaphylaxis. Now, coming on to the non-allergic mechanisms, so there can be a direct mast cell activation, particularly with we can see with the antibiotics like vancomycin, where we see a Redman syndrome, or with your radiographic contrast media, or there might be a mast cell independent mechanism because of which the allergic manifestations can happen. Now, a lot of thing is also dependent on the dose of allergen, the duration of contact, which is important, and all these factors we definitely need to look into. So this I have already covered. Why, as far as the management is concerned, IgE mediated or a non-immune type of allergic reaction, treatment wise, it remains the same. The difference, it helps in deciding the preventive strategies later on in terms of immunomodulation. Now, coming on to clinical manifestations, the signs and symptoms usually develop within 5 to 30 minutes of exposure to the offending allergen, but may not also develop for several hours. So we definitely need to have a good history. That would be important. Some patients with anaphylaxis experience biphasic reactions, which usually occur within 8 hours of the initial reaction. But yes, it can occur as late as even 24 to 72 hours after the exposure. So what is this biphasic reaction? So it's a second acute anaphylactic reaction occurring hours after the first exposure and without further exposure to the allergen. So which means that the allergen exposure has stopped. Patient has shown, our child has shown the first episode of anaphylaxis has been managed, and after a few hours shows a second reaction. So this is what we call as a biphasic response. Now, in terms of clinical manifestations, the most commonly we discuss the organs involved. One is the skin, then respiratory manifestations, which includes primarily the signs and symptoms of upper airway obstruction, which is present almost in 2/3 of the cases. Then cardiovascular involvement, which could be life-threatening hypotension, can occur in almost 40 to 45% of patients. Then GI and neurological involvement can also be there. So if we go by the system wise, yes, dermatology or the mucosal involvement is the most common. So we can see periorbital swelling, puffiness, conjunctival injection, tears. Then there can be angioedema of the tongue and lips. On the skin, we can see an urticarial rash or flushing with lot of pruritus, morbilliform rash, or we can have angioedema. In respiratory involvement, most common is the upper airway obstruction. So there can be sensation of throat constriction, a dry cough, or there can be stridor, difficulty in swallowing, then change in the voice, or you can see cyanosis and respiratory collapse. In lower airway obstruction, there can be severe bronchospasm with wheezing and coughing, a feeling of chest tightness, then respiratory distress, cyanosis, and respiratory collapse can occur. In cardiovascular involvement, early features include tachycardia, excessive sweating, delayed capillary refill time, and followed by hypotension. And in late stage, if not controlled properly, can lead to bradycardia, shock, or even T wave inversion and ST depression. GI involvement includes nausea, vomiting, diarrhea, and abdominal cramps. In neurological involvement, child can have throbbing headache, dizziness, lightheadedness, or even confusion, or even loss of consciousness. So these are the usual common manifestations which happen in response to an allergen. Now, coming on to this very important point is the criteria for diagnosis of anaphylaxis. Now, anaphylaxis is highly likely when one of the following three sets of criteria are fulfilled. So as per the guidelines given, so this is from Sampson et al, and this is the most frequently used guidelines followed across the world. So what they have done is they have given three sets of presentations. We have already discussed the most common symptoms or the organs involved are the skin, respiratory system, cardiovascular system, and GI or neurological system. So based on these, they have made three sets. So the first set is an acute onset of illness with involvement of the skin, mucosal tissue. So this is the first criteria, that if there is skin involvement plus at least one of the following, whether it is a respiratory compromise or a cardiovascular involvement. So one set is skin involvement plus either respiratory or cardiovascular. The second set is 2 or more of the following criteria which happens, organ involvement which happens. So one is the skin, second is the respiratory, third is cardiovascular, four is the GI involvement. So even if there are two organ systems involved, we can classify it as an anaphylaxis. And third category is that if you see hypotension, pure cardiovascular involvement, then that alone is criteria enough to take it as anaphylaxis, provided yes, there is a history that the patient was exposed to a particular allergen followed by hypotension. So as far as hypotension is concerned, for infants and children, we follow the PALS guidelines, which is defined as BP less than 70 millimeter of mercury in children less than 1 month to 1 year of age. Then for 1 to 10 years of age, we take the criteria as less than 70 millimeter of mercury plus age in years into 2. And for children more than 10 years, blood pressure less than 90 millimeter of mercury. Now, coming on to the management of anaphylaxis, the key steps of management include, the first and the most important step is prompt recognition. So a good history needs to be elicited. Yes, most of the time when children present, they would have some features like urticaria or itching or rhinorrhea or excessive sneezing. So a pediatrician can easily recognize, yes, there is some allergic manifestation has happened. But when we say prompt recognition is, we need to look at whether this patient is just having mild allergic symptoms or actually going into an anaphylactic shock type of a situation. So that is the most important step. In management, intramuscular epinephrine is the treatment of choice and should be given as early as possible. Besides this, we need to support the child's airway, breathing and circulation. So we would need oxygen. We might need a saline bolus. And along with this, we need adjunct therapies like H1 receptor antagonists, corticosteroids, and particularly if a child has a lot of wheezing or stridor, then we might need nebulized levosalbutamol or racemic epinephrine. Now, this is the algorithm for outpatient management of anaphylaxis. So I'll just spend a minute on this slide. So one is, once you see a child has gone into an anaphylaxis, especially in an outpatient setting, then at least have the patient lie down in recumbent position with lower extremities raised, and we would need to support the airway, breathing and circulation. So which means we would need to have oxygen at the clinic, and we should have the equipment to at least place an IV line. Then administer intramuscular epinephrine every 5 to 15 minutes until we see the appropriate response. So either we have the commercial auto-injector through which we can give the dose directly, or we need to have adrenaline ampoules available with us. The dose is 0.01 mg per kg of 1:1000 dilution of epinephrine, with a maximum dose of 0.3 milligram in children and 0.5 milligram in adults. Then we would need 100% oxygen with a non-rebreather mask. IV fluid administration might be required if the patient is hypotensive. So at least an IV cannula needs to be placed. So if there is initial poor response to the first dose of epinephrine, we continue with maintaining the airway, breathing, circulation, use a bolus of saline, and plus we can repeat epinephrine every 5 to 15 minutes until the upper airway obstruction or the hypotension is resolved. In adjunct therapies, we can consider giving IV histamine receptor antagonists. So just like we have intravenous Avil we can use, or if that is not available, at least we should have oral cetirizine or fexofenadine, which should be there, which can be immediately given to the child. And consider a single dose of intravenous, intramuscular or oral corticosteroids. So either of the three can be used because their bioavailability is almost similar, and we need to, so this can be used in the outpatient setting. So remember, if the patient has had anaphylaxis with significant respiratory or circulatory symptoms, then transport to a hospital would need to be arranged, because these patients would need to be under continuous therapy and monitoring for the next few hours or a day. So the equipment recommended for outpatient settings is commercially.
Vikas, you have last 2 minutes.
Yeah, sir, I am just finishing only.
Yes.
So commercially made epinephrine auto-injector should be there. Injectable histamine receptor antagonist if possible. Injectable or oral corticosteroid. Then intravenous start kit, particularly tourniquet, large bore catheters, then normal saline, oxygen setup, and appropriate age size blood pressure cuffs. So these would be important. So my take-home messages are pediatricians must be prepared to recognize and manage anaphylaxis in clinic practice. Prompt recognition of the anaphylactic reaction is the most important step. Intramuscular epinephrine plus appropriate management of airway, breathing, and circulation are crucial steps in the management of anaphylaxis. Volume replacement with normal saline is the treatment of hypotension that does not respond to epinephrine. And if a child develops significant respiratory or circulatory symptoms, the transport to a hospital must be arranged for continued therapy and monitoring. Thank you.
Thank you, Dr. Vikas. I'm sorry I could not introduce you. Dr. Vikas is a head of the department of pediatrics at Manipal Hospital, Dwarka. He's presented various papers in national and international conferences. He has been awarded James Flett Award for the social pediatrics, as well as award for pediatric critical care papers. He has presented this talk very nicely, and I must appreciate that each one of us must be prepared to manage anaphylaxis. My one comment is, every time in your clinic, must see that you have epinephrine which is not expired. Every time you want to, you will find it to be expired. Please be prepared to manage anaphylaxis. Every first of every month, check all the things needed to manage anaphylaxis in your clinic. This is a very important point. Last moment, you will not find either epinephrine or an injection or a syringe. So please be prepared to manage anaphylaxis in your clinic. Nobody will excuse you if a patient has a collapses in your clinic and you are not prepared for it.
Sir, IV epinephrine vials
can occur anywhere.
Sir, IV epinephrine, usually the expiry is only 3 to 6 months. That is one.
That is why.
But auto injectors which are there,
are they readily available in India?
So they are not readily available, but now they are available on Amazon, but they are very costly. So each auto injector costs somewhere around 5,000 to 7,000
feel that auto injectors should be made available everywhere.
Yeah.
Because all over the world, auto injectors are people keeping at home.
Yeah.
EpiPen injections for pediatrics, EpiPen for adults are being made available in all the practices. I think we should tell our pharmaceutical industry to make them more readily available.
Yeah.
And we should all be prepared to manage anaphylaxis in our clinic setting or even in periphery setting when Anganwadi workers go to give injections at home.
Yeah. And
thank you very much for a very nice presentation.
Yeah, particularly with vaccination, it becomes all the more important because a child can have an anaphylactic reaction anytime. That risk will always be there.
Thank you very much.
Thank you, sir.
Now I request Dr. Shikha Mahajan to introduce the next speaker.
Thank you, Dr. Prashant. Good afternoon, everyone. Hi to Dr. Vikas.
Hi.
It's good to see people here on the Zoom at least. Our next speaker is Dr. Neeraj Gupta. Dr. Neeraj Gupta is a well-known pediatric intensivist and allergy specialist. He's presently working as consultant in the Department of Pediatrics, Institute of Child Health, Sir Gangaram Hospital, New Delhi. Dr. Neeraj has been trained in pediatric critical care from Ghosh, UK, and he has done his IAP fellowship in critical care. He also holds a diploma in allergy and asthma from the reputed CMC Vellore. And today he's going to talk about allergy testing in the present scenario. Over to Dr. Neeraj.
Thank you, Dr. Shikha, and thank you to the organizers for giving me this opportunity to interact with the people. And after a very interactive and very good talk by Dr. Taneja, I will be talking another important aspect, that is allergy testing. Where are we today? So I will be speaking in brief about hypersensitivity reaction, the tests which are available, and the practical utility of all these tests. So first of all, the most important step towards allergy testing is clinical history. Most of the time, I will say more than 90% of the time, the allergy diagnosis is dependent upon a very good clinical history. Then there will be certain signs which might be available in physical examination, like for rhinitis, some allergic shiners might be there, or for asthma, some wheeze might be there. But absence of wheeze or absence of allergic shiners or any allergic manifestation in the physical examination doesn't rule out allergy. Then there could be certain supporting laboratories which are required only in special circumstances, but not in every case. And then once the patient comes to us and then they say that, okay, if I avoid this particular thing and my symptoms improve. So that also gives a very important clue in the history that probably that particular allergen avoidance has been responsible, or that allergen could be responsible for the allergy. And when that particular allergen was reintroduced, then at that time, the again symptoms came back. So that is an important clue. So there are different types of diagnostic tests which are available for allergic diseases. I will be focusing mainly on the IgE based test today, which are the total IgE or some specific IgE allergen panels which are available, or the skin test. So the first question is whom to test. If a child presents to me with one episode of sneezing or a wheezing type of episode, should I subject him for testing? Or another child who is presenting to us with repeated episodes, recurrent episodes, should we ask them to test? So any patient with recurrent or persistent symptoms should be tested in a way to make it simple, like as per the area guideline, any child who is having symptoms suggestive of rhinitis and falling in the category of moderate to severe intensity, or in persistent type of variety, then at that time they need to be tested. Similarly, in case of asthma, as per the GINA guideline, any child who is falling in moderate to severe or in persistent variety, they should be tested. The child who is having mild intermittent disease need not to be tested. And which allergen should be tested for? So should we subject them for a battery of allergens which are available, probably 80, 100, 150 allergens which are available as a panel which are there, or should we select them the number of allergens in that test? So less is more is the mantra. Try to narrow down the allergens by a very good history to less than 10. That is probably 6 to 8. The less you test, the more you will be in a better shape, better position to allow them or tell them that which allergen they are allergic to. So like for example, in allergic rhinitis or asthma, the most common allergen, especially in India, is house dust mite, which is like almost 70 to 80% of the people suffering from respiratory allergies are having house dust mite as the major allergen. The other common allergens are cockroach and then the pet denders. In the West, cats are more common, whereas dogs are more indoor in India. Then mold spores are there, which could be there. Then pollens from the relevant grasses, weeds, and trees. Here comes once again the history that from which region of India the patient belongs, and in that particular region, what is the pollination season, in which particular type of month the patient is having more symptoms, and which pollen is more important there. So that means that we have to really narrow down as per the allergen spectrum. And then the occupational history, especially as in case of medicos, many of us are latex allergic. So we have to really see that what are the manifestations and what we are dealing with. A person who is surgeon is likely to be having more chances of latex allergy as compared to a physician. Then suspected food items depending upon the history. Once again, allergic reaction, Dr. Vikas has already enumerated about the allergic reaction. The important point about highlight is that there are two types of IgE which are available. One is the free IgE molecule, which are immediately released by the mast cells, but they are yet to bound to the mast cell. They are immediately released by plasma cells and yet to bound to mast cell. And another IgE, which is actually bound on the mast cell available, which are just waiting for the re-exposure of allergen to happen. So the tests which are detecting the free IgE are the blood test. That is either the total IgE or the specific IgE. Whereas the tests which are really detecting the bound IgE, these are the in vivo tests like the skin prick test or the challenge test, in which we are re-challenging the patient with the re-exposure of the allergen, either in the form of the skin prick allergen or either in the form of the challenge test. So there are two types of tests as we just discussed. One is the bound IgE detection, skin prick, and the challenge test, and in vitro are the total IgE and the specific IgE. What is skin prick test? It basically detects the presence of allergen specific IgE, that is bound IgE, on the patient mast cell, and it is more clinically relevant. It is more near to the clinical picture. There are certain equipments which are required. The basic is that we are just taking the minute amount of the allergen, that is approximately 1 millimeter depth we are going for a 3 microliter allergen, and this allergen goes down. We are just inserting with a lancet only in the epidermis, which is bloodless, painless, because there is no blood vessel, there are no pain fibers in the epidermis. Then this allergen diffuses down as per the concentration gradient and ultimately get attached to the bound IgE, and where the mast cells degranulate and releases the histamine and other chemical mediators, producing wheel and flare reaction within 15 minutes. So this is the basic of skin prick test. It is considered as a gold standard test for allergen hypersensitivity. The size of the wheal will determine the positive predictive value. The more the size of wheal, so 3 millimeter more than 0 is considered to be positive, and more the size is considered to be more better positive predictive value. So this is having good positive predictive value and good sensitivity and specificity. But we cannot do a skin prick test if the skin is not healthy. There is diffuse atopic dermatitis, you cannot do it. Dr. Vikas has already told anaphylaxis. So in anaphylaxis, the histamine stores have already been exhausted. So you cannot do skin prick test once the histamine stores are exhausted. You have to wait for 3 to 4 weeks so that the histamine stores comes back. Or if the patient is on antihistamine, you cannot do it. Whereas if the patient is on short-term steroid, that is less than 10 days, or the patient is on topical tacrolimus, you can safely do the test. If the allergen extract for that particular thing is not available, especially for the food allergies, then we can use prick test. So we have to just prick that particular food item, and then we will just prick with the same lancet to the skin, and that will also have a good value. Another type of allergy test is intradermal testing, which is not routinely recommended for allergy testing, but yes, for antibiotic testing, sometimes it may be recommended, or even if there is a previous history of anaphylaxis for vaccination, after vaccination, then at that time we might use intradermal testing. So, but the skin test is having an advantage that it is more reliable as compared to any of the blood tests, and it detects the bound Ig detection. But the problem is that many times the standard allergens are not available for all the allergens, and then the test technique, it need to be mastered, and then unhealthy skin you cannot do, and there is a theoretical risk of anaphylaxis. Then the blood-based test or the in vitro test, which is total IgE. So total IgE can be raised in many other conditions apart from allergies, could be parasites, Epstein-Barr virus, HIV, rheumatological conditions, smoking, pollution. So it is having many false positives and false negatives. So truly speaking, total IgE is not the test for allergy testing. Neither high IgE, neither the normal IgE value doesn't prove or rule out allergies. So it is not useful in routine allergy management, can be used only when you are planning for anti-IgE therapy, like with omalizumab, special conditions like ABP. Then specific IgE, the technique available to us is ImmunoCap right now, and the commercial name, which is by the Thermo Fisher company, is Fadiato, which is commonly available. The good thing is the negative predictive value is quite high, but the positive predictive value is not that great. So this is having an inferior value as compared to the skin prick test. There are various panels which are available with various laboratories, and then the advantage is that it is convenient for the patient. There is no risk of any anaphylaxis. Objectivity is there, then you can tell that this much kilo units are available, and you can do it any skin condition. But the problem is the cost is too high. Panels usually cost more than 10,000. Blood sample is required. It usually takes almost 48 hours to report, and it only detects the free IgE, which is far away from the clinical reaction as compared to the bound IgE detection. So which one, if we want to choose, compare, so the skin test seems to be available, the results are available early. The second thing, when the wheal and flare is available and visible on the skin, then at that time the patient understands that, okay, this particular allergen he was inhaling for years together inside the airways. So how much swelling will be there if a small amount of allergen introduction in the skin has produced this much swelling? So how much swelling will be there in the airways? So understanding will become better, and they become more better compliant to the medications or the inhalers. The third thing is that if you are having a total IgE high, then at that time the specific IgE value could be falsely positive, whereas the skin prick test do not get interfered with the high total IgE value. And this is just a figure which is suggesting that the total IgE high value more than 300, there will be false positivity, high chances of false positivity for the blood specific IgE, whereas the skin prick test will be having a true value. The advanced test which is coming up and which will be available in India in another few years will be component resolved diagnostic. What is this test? Like for an example, if you need to test a peanut allergy or an apple allergy, then the specific IgE till now we are having is only the nut allergen or the apple allergen. But this is having many different type of molecular allergen components which could be specific to one particular allergen, or they could not be, they could be having a cross reactivity to another allergen and could be falsely positive. In component resolved diagnostic, you can really separate the allergens out, and then you can really test them in toto, that which is having like a true allergy and which is having a false allergy. So once this will be available, this is having a far better diagnostic value as compared to any of the blood test or the skin test. The other methods could be eosinophil count, but these are neither sensitive nor specific for any allergy testing, should not be recommended. Then oral allergen testing, this is the gold standard test for food allergies. So for aero allergen testing, the gold standard is skin prick test, and for food allergy testing, the oral allergen test is the gold standard test. Patch testing is basically used for type 4 hypersensitivity like contact dermatitis, and in which certain patches are available which are applied, can be applied. The results are available from 48 hours onwards up till 7 days. So why should one do is allergy testing? First, we can target the allergen, that which particular allergen that particular person need to avoid, and advise them accordingly. Then second thing is improve compliance with the medication. And third thing is we can always offer the allergen immunotherapy to the selected allergens. How we can target? So there are certain softwares which are available which can really tell us in real time that they are pollen predictors. They are like a weather predictor. So these are pollen predictors. They can really tell us that today or tomorrow what will be the grass pollen concentration or the tree pollen concentration or the mold concentration in the environment. And if they are high, and a particular person who is allergic to grass pollen, then they are advised to take special measures on those particular days and avoid going outdoors, especially from 10 o'clock to 2 p.m. in the afternoon, at which the grass pollen concentration is higher. So this is there. Then the cost effectiveness comparing between the two type of testing. So the skin prick test, we just spoke about that. The results are available much faster. Patient is more satisfied here. They are more clinically relevant. They are more economical as compared to any of the blood tests which are available. And in the case of total high IG high, this is like having a true value where this could be false positive. So the common aeroallergens which are there, especially in North India, are dust, house dust mite, and insect. Among the insect, cockroach is the main culprit. Whereas among the food allergens, less than 5 years, milk and egg are more common. Whereas more than 5 years, milk and nut allergies, especially the peanut allergies, are more common. So my talk was based upon where are we today. As we understand that this is an allergy.
Dr. Neeraj,
we are finishing in another 2 slides. We are finishing. So as we understand that this allergen, when it comes in contact with the antigen presenting cell, stimulating the Th2 pathway, ultimately releasing certain interleukins, stimulating the B cells and the plasma cells to produce and trigger the allergy cascade. So what we are doing today, we are just acting with certain antihistaminics, certain steroids, certain anti-IgE therapy. That could be skin allergy, that could be asthma, that could be rhinitis. So we are actually reacting to the situation. The damage has already happened. What we need to do is that we need to pick up the things here at this point, that is the allergen by the allergy testing, and then we need to advise for certain specific avoidance measures and change this Th2 pathway to Th1 pathway by immunotherapy. So we need to really change our approach from reactive to proactive. To summarize, history and geographical location of the patient is very important in delineating that which patient and which type of allergens need to be tested. Skin prick test versus the specific IgE, that will be patient to patient discussion. When, depending upon the recurrent or the persistent symptoms. Why? Because we can offer always allergen avoidance and immunotherapy. Thank you very much.
Thank you, Dr. Neeraj. It was a very nice and crisp, in fact, very short presentation. This skin prick test and IG level test are really helpful for us. And any questions from the audience?
There is a question.
Yeah, we have. Yes, we have one question from Dr. Pankaj Gar. Cost of skin prick test at your center?
So cost will depend upon the number of allergens. Like for an example, if a patient who is coming to us for only a single allergen, like specific milk specific IgE only, for an example, so we are even not charging that particular patient for a single allergen testing. But suppose if a patient who is coming to us for like a small panel, like 10 to 12 allergens, then the cost is coming out to be somewhere around 4,000 to 5,000. If we are doing a higher number of panels, like 60 or 70 allergens, then at that time the cost is coming somewhere around 10,000 or so.
Yeah,
thank you so much.
Thank you, Dr. Neeraj. It was an excellent presentation. The only thing I have seen over the years is that the cost of allergy testing has still not come down. So I think you people should work on that so that it is more accessible to everybody.
Yeah.
So, because it costs around 10 to 15,000 in certain centers, and which is a significant amount.
Ma'am, 10 to 15,000 will depend upon the number of allergens which you are testing.
Exactly.
But as I told that if your number of allergens are reducing, like for an example, if a patient who is coming to me in infancy, the most common allergen is only milk. There is no other allergen which I will expect. So even the milk allergen, we are doing free of cost. We are not charging anything. So that will depend upon that the number of allergens which you are choosing. If you are just going with a big panel, 60, 70 allergens, then the cost will come. That's why I told you that choose less than 10. Then the cost will reduce.
What is the cost of immunotherapy?
Sir, immunotherapy is not costing very much. The immunotherapy is of two types. We are practicing sublingual immunotherapy, and it is costing somewhere approximately 1,000 rupees per month. not more than that.
Oh, that's very good. Thank you.
That's good. Yeah.
Dr. Neeraj, I want to just know one thing. This allergic sensitivity test you have said for type 1 hypersensitivity, right?
Yes, sir.
What
Yes,
about the other mechanisms of allergy? What are you doing for those? This thing. This is only sufficient enough to rule out this allergic mechanism involved in various diseases like asthma and wheezing.
So, sir, whenever we are speaking about allergies, we usually want to talk about type 1 allergies.
What about type 2, type 3?
Yes, sir, I'm coming to that. So we usually speak about type 1 allergies and type 1 hypersensitivities. For type 1 hypersensitivity, these testing are good. For type 4 hypersensitivity, the contact dermatitis and all those, we can offer patch testing. We can offer patch testing. But for type 2 and type 3, there are no tests which are available. You cannot do any test, sir. And that is why in asthma, the pathophysiology is heterogeneous, sir. There are multiple etiologies which are there, multiple pathways are there. And that is why we say that immunotherapy is not very great, especially in case of asthma, but in allergic rhinitis, the immunotherapy results are best.
Dr. Neeraj, which one would you recommend as the first test, skin prick test or the specific IgE assay?
Skin prick test, sir. If we cannot do skin prick test because of some reason, then only we go for the specific IgE. Otherwise, in our center, we are going almost 90 to 95% times only skin prick test. We are even not asking for a total IgE. We have stopped doing total IgE and the specific IgE also.
Okay. Dr. Shraman, any comments by you? Any queries? Okay. Thank you. Thank you all the chairpersons and speakers, Dr. Vikas Taneja and Dr. Neeraj Gupta for this session. For next 2 sessions, we have panel discussions on tuberculosis and infectious diseases. And for that, I would hand over further to handle the proceedings to Dr. Tapisha Kumar.
Thanks, Dr. Prashant Seth. And I welcome all of you to this much awaited afternoon session, which is a question and answer session with our pediatric tuberculosis experts. Rohit, can you put the slide, please? Yeah, so this is a 1-hour Q&A session, and we have esteemed tuberculosis experts and panelists, so expect all your doubts to be clear. We have as our experts, Dr. Varinder Singh. Dr. Varinder Singh, yeah, sir really doesn't need an introduction. He's Director Professor of Pediatrics at Lady Hardinge Medical College and Kalavati Saran Children's Hospital, one of the top respiratory specialists of the country. Dr. Sangeeta Sharma, ma'am is Head Department of Pediatrics at National Institute of Tuberculosis and Respiratory Diseases, New Delhi, and in charge of National Center of Excellence for Pediatric TB and drug-resistant TB. And Dr. Ashwini Sood, sir is Professor and Head Pediatric Medicine at IGMC, Shimla. I welcome all the 3 esteemed panelists. Our moderator for the session is Dr. Ankit Parak, and I request Dr. Varinder to please introduce Dr. Ankit Parak. Thanks, Dr. Varinder Singh.
Thank you, Dr. Tapisha. I hope I'm audible.
Yes, I am.
You're not visible, sir.
Okay.
What about me? I'm okay? My voice?
Yes, everything
yes,
fine.
Sir.
Okay, okay.
So, it is indeed my pleasure to introduce Dr. Ankit Parak. He is a man who has many, feathers in his cap. So he's a TB specialist, he's a chest specialist, he's a sleep specialist, he's an allergic specialist, and has been trained at several. I think he's more known in UK than in India because he has trained in almost 3-4 organizations there. And I had the good opportunity to have worked with him when we were together in the same unit, and I very fondly remember those areas. And I think he's the new star in the sky to be watched. So I'm glad that he's moderating this session today.
Dr. Please screen share, Dr. Ankit.
So a very good afternoon to everyone, and thanks to the PCNI team for giving us the opportunity to deal with common questions on pediatric tuberculosis. So I have made a few questions which usually we are asked. So we will take up those questions in brief, and then we can take up any questions from the audience as well. So let's start with a case. So this is a 10-year-old girl who has fever, cough, anorexia, and weight loss. for the past few weeks. And X-ray, which is here, right? So we do a sputum smear examination. You find that the sputum smear is 3+. So the question is that, with the clinical background, fever and cough more than 2 weeks, a presumptive TB with weight loss, which is possibly significant, an X-ray, which you have in front of you, and a microbiology, which is positive. Do you need anything else to, start this child on ATT? So the first question is that, do you think any further investigations are required? So Dr. Singh will take up the question further. That do we need any further investigations? Is sir there?
He's there.
Dr. Vaninder?
He's not seen at the moment in this.
He's probably having some problem. You can ask questions to the next speaker.
Okay. So Dr. Sangeeta, do you think any further investigations are required, or we are done? We can put this child on ATT. You're not audible, ma'am. Please unmute yourself.
Yeah. So had it been, say, a few years back, I would have said start ATT. But that is not the scenario right now, because we have got such good rapid diagnostic tests available, which tell us about the sensitivity of the known index case. So we would like to go ahead with those tests and get the ATT as per the resistance pattern of the child. Because the child is sputum positive, so you don't need anything else except first and second line LPA. Because those tests, they are done when the sputum smear is positive, and they guide the further management. And the more efficient detection of MTB, that has led to detection of resistance upfront. And what we are offering now is universal DST. That means for any child who you start ATT, at least resistance to rifampicin, and in the future, probably to almost all the antitubercular drugs. So this is what you call as universal DST. Rather than starting ATT without getting tests done, you need to at least offer the child rifampicin resistance or sensitivity test that is available by first line LPA. And goals have now come near with all these tests available. The scenario and management of pediatric tuberculosis has changed over the years. Over.
So just to summarize here, that now we have a concept of a universal DST, which means that any child who is being diagnosed as tuberculosis is going to be tested. So one, you want to get Mycobacterium TB to confirm that yes, it is tuberculosis. And second, you want to get the resistance pattern, and the minimum is the resistance to rifampicin. So which means every child should be tested for rifampicin resistance. And Dr. Sangeeta will elaborate on what test we can use for getting this rifampicin resistance.
Yeah, the tests which are available, the tests which are available under the program and in our laboratories in our country are as follows. That is, we have NAT, that is nucleic acid amplification test. These are either it is cartridge based, that is called the CBNAT RIF. That means it would tell you just rifampicin resistance. In future, we are also expecting CBNAT XDR. That means in that same cartridge, not only for rifampicin, also further sensitivity to INH and fluoroquinolones and second line injectables will also be available. But that is a test which is already available in some countries, but not in our country because validation is occurring. The other is the TrueNat. TrueNat is the chip-based test. That is all NAT, it takes 2 hours. So the turnaround time is very important. Both CBNAT, RIF and TrueNat, they detect rifampicin resistance, and they can be done on paucipillary samples, on extrapulmonary TB and pulmonary TB samples. Now coming to the next, that is the molecular testing through the line probe assay. Line probe assay, there are two, that is first line drugs, that is rifampicin and INH, that is called first line LPA. Then the second line LPA is which detects the class resistance to second line injectables and the fluoroquinolones. And the results for this, they are available within 2 to 3 days. Maximum is 72 hours. The third in the pipeline is, especially for the smear negative patients, is the liquid culture. Now, the liquid culture has an advantage over the solid culture. Solid culture in ages, you must be remembering, it used to take 6 to 8 weeks and further 6 to 8 weeks for the sensitivity. But with liquid culture, the results they are available in 2 to 3 weeks as positive. But for a negative test, you need to wait for 6 weeks. So that is the reason 42 days is written as the upper limit, because you have to wait for a negative culture to be declared as negative for 42 days. So this is the order of preference of the test. And under the program, what if the patient is positive by any of the methods, the child is labeled as microbiologically confirmed. It is not bacteriologically confirmed because we are using molecular tests. So it is microbiologically confirmed. And under the program and in our country, we are offering, as we have already discussed, universal DST. That means for all patients, at least you need to know the resistance to rifampicin and in the future resistance to all the drugs. So presently, new patient, at least rifampicin, and for a patient who has had prior ATT, that is a presumptive DRTB patient, you need to get other tests for sensitivity to fluoroquinolones and second line injectables. So this is how these tests are there. I would just like to add a quick, there are 2 more tests because maybe the house must have heard about it. That is the LAMP. TB LAMP is a point of care test which is going to in future maybe replace smear, sputum smear. So it can be taken to the patient's house and the tests, they are available in less than 1 hour. And the other which is validated for HIV is urinary LAM. That is lipoaminomannan assay. That is for HIV, diagnosis of HIV patients. So these are all the tests which are available. Ankit, thanks.
So just to again summarize, this child was sputum positive. So this is the reason why ma'am said that you can do an LP upfront. I'll show you the new algorithm. So the gene expert or the CBNAT or the TrueNat is the usual test which you do as per the program. But yes, if a child or an adult is smear positive, you can put up an LPA, because CBNAT, the yield is something like 50 to 100 bacilli per around 100 bacilli per ml. If you're using a gene expert ultra, it comes down to even less than 20 bacilli per ml. Although the LPA is not as sensitive, and hence you do not do LPA if someone is smear negative.
Yeah, because LPA, it requires minimum 10,000 bacilli per ml, to be positive. So that is the cutoff for smear positivity. That is why we say get LPA done if the patient is smear positive.
So, Dr. Singh has joined back.
Yeah, there's one concern. The CBNet is available at most of the places.
Yeah.
If you come to the subdivision, so I think that should be the first message.
Yes, agreed.
It will depend upon the availability whether we have got LPA or CBNet. So because CBNet has now become a universal one. So yeah. First, as you discussed,
CBNet, even TrueNat is available.
Yeah.
And it's available free of cost to the patient under the initiatives. So even the private labs, they are, reimbursed through the government.
So Dr. Singh has joined back. So sir, can you take us through the new algorithm for pediatric tuberculosis?
Okay, thank you, Ankit. I had a connection failure, but I'm glad that I've been able to come back. So if you look at the current new algorithm, what's new? a disease which is so ancient and we have been treating for close to 100 years, what's going to be new in its management is something, is a question which often comes to our mind. What makes new is always either a new test, of which we heard from Dr. Sangeeta and Dr. Sood, but also is the fact that we learn from our mistakes, or we sharpen of what we understand of a disease. So what has come in the new algorithm is that earlier fever, cough, any chronic fever, cough, and the definition of chronic was left to individuals, and we did not know what was a weight loss at which the possibility of TB would increase. So the current guidelines have kind of characterized them a little better. They say persistent fever for more than 2 weeks without a known cause. So that whole description classifier is important. Unremitting cough for more than 2 weeks, 2 weeks or more. So it's an unremitting, not something which comes and goes like a reactive cough, is more likely to be TB. It's not that other presentations cannot happen, but less likely. Likewise, you have weight loss of 5% or no weight gain in past 3 months despite adequate nutrition. So it's not a nutritional failure or failure of a nutritional rehabilitation in a child with SAM. One has to think of infections, and one of the infections you think of is pediatric TB. This, if it happens in presence of a contact or exposure to pulmonary TB case or a chest TB case in past 2 years, it becomes more likely, because if you are exposed, you are more likely to be infected, and if you are a child, you are more likely to develop disease faster as compared to an adult after getting an infection. So that's where the role of contact comes. The classifier of the symptoms remain irrespective of there being a contact or not being a contact. In presence of contact, the possibility increases. So this is what we call as, earlier the terminology used was suspect TB with these. Now we do not use the word suspect, because suspect puts the burden on the victim as if they have committed a mistake. This is what we call as a presumptive case of TB, that you presume they may have TB. So once you have this presentation, then what is the next step to be done? If again we go back to the past, what would you commonly order? If you were working in a hospital like mine or Sangeeta's or Dr. Sood's, the resident would write GA for AFB into 2 days, tuberculin skin test, and a chest X-ray. One all together. Is that the right way to go about? TST, if there is time, we'll discuss, has lost its importance in current times with better tests available, very limited role. GA for AFB for yield was less than 10%. Getting a gastric aspirate was difficult. Most of our friends outside in the practice would not do it. Chest X-ray is what was required. So therefore, today we will do a chest X-ray first. But then if it is chest X-ray first, in the opening case, Dr. Ankit showed us a child who not only had a chest X-ray, also had a sputum. We were not happy with it. Then why is it this screening test says check chest X-ray first? We say that because here we are using chest X-ray as a screening test. And what do I mean by that screening test? I will elaborate as we unfold this algorithm little more. So on the chest X-ray, you could have X-ray findings. They can be highly suggestive. Highly suggestive being if you have a miliary TB, if you have hilar or paratracheal lymphadenopathy, or you have a chronic fibrocavitary disease. Chronic comes from history, and fibrocavitary comes from the picture that you have cavitation, you have some area of atelectobronchiectasis, that's fibrocavitary. And in this case, depending on the type of respiratory sputum which is specimen which is available to you, it could be a self-expectorated sputum. In a smaller child, because they will swallow, it could be a proxy specimen like gastric aspirate or gastric lavage, or it could be an induced sputum if this child is not coughing a lot, and you could induce by giving 3% hypertonic saline after priming with salbutamol and aspirate that, and use that for a molecular test. So in the past, we were doing AFB. Today we do not suggest AFB as your starting test, simply because knowing that it is MTB is not enough. Even there, these tests perform far better. If your average yield was about 10% with sputum, it will go up to about 30-35% with NAT. Higher in older children, higher in patients who have parenchymal lesions, maybe the yield will be much more. Now, the cost of a AFB and the ease of AFB made it easier to ask all of these together. But however, the cost of a NAT is huge. And therefore, studies have shown if you have a chest X-ray which is normal, and since you have not seen the chest X-ray, if you order the chest X-ray and gastric aspirate together to begin with, you do not know what proportion of these symptomatics would have a chest X-ray abnormality. And therefore, you would test and get close to about 5 or 6% positivity. But if you go, those who have chest X-ray abnormality, it goes up to about 40%. So that's a substantive increase. And that is why now chest X-ray is used as the screening test to direct where you should be focusing your energies to get a respiratory specimen, which in children sometimes is difficult. One has to go for a gastric aspirate or sometimes an induced sputum, and use a test called like NAT, which is nucleic acid amplification test. Again, 3 types of NAT are available to us. We heard about Gene Expert, often called as cartridge-based NAT, which takes about 2 hours, but then there are 4 cartridges which can be run together. So if you have large number of samples, machine takes 2 hours, but you may be in queue for 3 days or 5 days. So if you send unnecessary specimens, you will lose that advantage. The other test is TrueNAT, made in India. It's a chip-based test, 2-step. It works very well as the cartridge-based, but then it has requires some degree of manipulation. Cartridge-based test requires no manipulation. Once you have put in charge the cartridge, you put it into the machine, you get the results. The third test is LPA. LPA is much less sensitive. Advantages, you can get both INH and rifampicin together in a first-line LPA, but can only be used in a smear positive. So therefore, in a child, your first test will never be an LPA because you are starting with an X-ray or screening. If you have seen a sputum which is smear positive, then only you can use an LPA. And therefore, we push it for a drug-resistant suspect or presumptive case, as Sangeeta mentioned. And as Dr. Sood brought out very beautifully, that this is not routinely available, everywhere available, and the yield is less. What is available to you is a TrueNAT or a Gene Expert, and that works very well. So if you get the result from there, if it shows MTB detected, it's a microbiologically confirmed test. This NAT is a nested NAT. By nested NAT, we mean it gives you 2 information. It tells you that patient has whether the specimen has MTB, and it also tells you whether this MTB is RIF resistant or not, with a specificity of about 90-95%. That's a good amount of specificity. So if you get RIF resistant detected upfront, since it's a child who may not have any epidemiological factors to suggest that this child is at a higher risk of drug resistance. So what are those epidemiological factors? If this child was a relapse, if this child was a retreatment, or if this child was from a contact of or exposed to an MDR case, or this child had a family history of death due to TB, then that's a DRTB suspect. Then your single specimen showing the RIF resistance is good enough. But if it is a child who is primary case, if the MTB load is high, it's still RIF resistant detected is perhaps reliable. But if it is very low MTB load, then sometimes there is disparity, and therefore you have to repeat the specimen. If only it is confirmed by the second specimen, then only you will treat as RIF resistance. The other possibility is that you detect MTB, but you do not detect RIF resistance, and that means this is RIF sensitive, and we treat accordingly. Another important thing to remember in our country, isolated rifampicin resistance is very rare. It is almost a surrogate marker of MDR-TB, that is R and H, and that's why all cases where you get a RIF resistance, you would treat them as MDR. In fact, you would investigate for other second-line drugs to see that it's pure MDR and not an XDR or a pre-XDR. If this child is NAT negative, which would be in about 50%, 55%, or sometimes 60% of your cases, that means negative Gene Expert does not rule out TB. So remember that. That's an important carry home message. So you would still have a situation that NAT will come negative. In that situation, there could be need for repeating the specimen because the quality of specimen is very important. So you could repeat from a better quality specimen or an alternative specimen like bronchoalveolar lavage or aspirate, depending on the availability or feasibility. Or sometimes these children, up to 30% of pediatric pulmonary cases, may have a palpable lymph node in the axilla or in the deep in the neck if you are careful enough to palpate. And if you will do an FNAC from there, that may give you a diagnosis. So remember to look for these contiguous extrapulmonary sites which are often involved. It's another case when they have a disseminated TB, then you have anyway would have found other sites. But I'm saying even in pulmonary cases, you often have lymph node involvement. And this is where if you still do not have access to another specimen or your repeat NAT is negative, then depending on where you are, you may seek review from a higher center, and higher center means a center which has a better capacity than you to work it up further. So this is our first limb. Our second limb is if it comes NAT positive, it goes there. If it is NAT negative, you have to rule out all the possible alternative causes. Ankit, can you press the next, please? And once they are ruled out, this is a child who will be called clinically diagnosed probable TB case and will be treated as lymph sensitive. If the X-ray shadows are non-specific, that means they are neither biliary nor adenopathy nor fibrocavitary pneumonia or inhomogeneous, shadow or scarring or some nodules or some bands here and there, inhomogeneous opacities, then it's hard to sometimes say that these are not atypical atypical pneumonia or a pneumonia which has been partly treated with an ineffective antibiotic. So therefore, you would like to use a course of appropriate antibiotics. You will definitely not waste time for 7 to 10 days of antibiotics if the child has already received a good set of antibiotic course like with the comoxiclav and amoxicillin, and for 7 to 10 days an appropriate antibiotic in appropriate dose use. Then if it is persistent shadow with persistent symptoms, you will in that case also do a gastric aspirate and again follow the same circle. Remember, a NAT negative in a persistent shadow is a persistent pneumonia which has many other differentials and therefore goes into the complete algorithm of looking for a persistent pneumonia workup, and that is where the seeking review from a higher center will again come. The third situation may be that your screening X-ray is normal, but this is a child where symptoms were suggestive of TB. Then maybe it is extrapulmonary TB because systemic signs like persistent fever, weight loss could equally well be present with an extrapulmonary TB. So look for that. And then again, consider referral for a detailed investigation for an alternate cause or a TB, because remember, X-ray normal with same it just puts bracket 7 to a PU, and PU TB may be very common in our country, but is not the sole cause. So this is how this algorithm unfolds for our patients who have likely to have a pediatric intrathoracic TB. So major changes, you are starting as a screening with X-ray. Second important change is that we are going for a molecular diagnosis and we are repeating with a good quality specimen. We are priming with a course of antibiotic if it is a non-specific shadow. We are not wasting our time with antibiotics if it is a suggestive shadow. I have often seen patient with one month history, 3 weeks history, fibrocavitary pneumonia being pumped vancomycin, meropenem because there is high-grade fever or some neutrophilia. Don't do that. This is where you should have actually jumped to the fact that if this child is non-responsive, does not have any other pointers towards pyogenic infection, must be investigated for TB rather than just waiting another 2 weeks. So that's an important thing to carry home. All patients who are suspected of TB when diagnosed must also have an HIV test done. That's important. So this is what the current algorithm is. It comes with certain caveats, which I am sure the next slide will show. Dr. Ankit, please. So those caveats, I think we have omitted for in the interest of time, but most of them I had already addressed. Only thing which is relevant or missing is when we were doing smears, we were doing 2 specimens. When we are doing CB0, we are initially doing one single specimen, repeating if only you still suspect TB with a better quality specimen. You are not routinely asking for 2 specimens as you were doing for AFB. So that's an important change. Thank you, Dr. Ankit.
So, once we have diagnosed a child as TB, now, Dr. Sood, what regime, what drugs, and what doses would you use to treat this child?
As Dr. Birinder has highlighted that we have now three categories. One is this, if we talk about this particular patient, this is a new microbiological confirmed pulmonary TB. Another is at times extrapulmonary. And then another category will be new clinically diagnosed pulmonary as well as extrapulmonary. And at times we have patient where there is a recurrence who were lost to follow-up and the treatment after failure. But here one important thing is to understand that this patient, once we reinvestigate them, they should not be having evidence of resistance to rifampicin. Otherwise, the protocol will change. For all this, we all know we have this set of 4 drugs to begin with, 2 HRJD, and then for next month we are going to have 2 HRE. And why this HRE, this ethambutol came, we must remember that Dr. Singh has already highlighted that we are having a good number of rifampicin resistance. So just take care of that. The ethambutol has been made a part of now treatment regime.
So all drugs are daily, and we have added ethambutol to the continuation phase. So it is not alternate day as it used to be.
As per NTP, now it is a daily dosing, and another advantage is now we are having fixed dose combinations. And with these 3 are dispersible tablet, and issue with the ethambutol is that it can't be made a dispersible. So it is a separate tab, and we want to discuss with the parents for the treatment of their children. And another highlight of NTP 2000 is that there is some revision of the doses now, because there were earlier issue that especially with the rifampicin, the earlier doses being used in twice daily or twice weekly and thrice weekly regime, the patient exposure was to mycobacterium, the drug dosage was not effective. So that's the reason that now we have moved to rifampicin in the range of 10 to 20, isoniazid 7 to 15, farginamide 30 to 40, and ethambutol 15 to 25. And one more thing which we should right now know that this now algorithm is on weight band. Now it is not on age. And there's one more issue that it has been shown that those with the lean mass, probably they get less of, in those patients, mycobacterium get less of exposure to the rifampicin. So there are few issues which has been highlighted by the WHO over last 10-12 years, and that's basically the basis for moving on to weight band. And this is a table is very well, so we should be having this, that how we have to continue from the intensive as well as the continuation phase.
So these FDCs are available from the National TB Elimination Program. Now there's a public-private partnership as well. So for example, in our hospital at BLK, there would be one representative from the NTP or its associate like JIT, and they would help to register the patient and provide drugs as well. A usual question, Dr. Sood, which is asked is that we do not have these FDCs available in private practice, and there would be a lot of patients who would not prefer to go to an NTP approved center, and they would like to buy these medicine. Then what should we do?
Probably there are 2-3 riders. One thing, when we are dealing with this page, before we initiate on the therapy, one must remember that notification of this case is very important as we move on to further therapy, because that's very important. And that's the reason that our colleagues in the private practice, probably they are not going to keep these medicines. And I don't know what is happening, because in my state, all patients are referred to the healthcare facilities, and only a few second line drugs are available only with 1 or 2 selected chemists, because there are no number of riders for the chemist to keep all these. They need to keep a photocopy of prescription, name of prescribing physician and everything. So in my state, all patients are referred to the hospital or government institutions.
Yeah, I think in Delhi, if the other option is to use single drugs, still we have FDCs available in the market as well. If the child is being referred to an NTP approved center, then obviously they will get the drugs, right? So we have heard that there is a current recommendation of pyridoxine as well, Dr. Sood. So can you just elaborate on that?
Yeah, this is another highlight from the previous guidelines in the NTP. Actually, this is, we all know that when we use INH in these patients, it's a basically anti-metabolite of pyridoxine. So earlier, this was a recommendation was seen that you need to supplement only in the selected categories. Now there are two issues now. One, we have increased the dose of isoniazid to 10 to 15 milligrams. So probably that has also made more requirement of pyridoxine. So keeping in this view, and we have a good number of patients with malnutrition, or those may be having borderline. So just to otherwise it is going to unmask the presentation of pyridoxine deficiency. So now it is universally recommended to use isoniazid for all patients in children in all cases, 10 milligram for infants and 20 milligram for children for whole of the therapy. Yeah, and another important issue that is not a costly drug; it's very cheap.
Right. So we got a history in this child that the grandfather actually died with tuberculosis 6 months back. We did not have papers, but the grandfather was already on some injectables as well. So, Dr. Sangeeta, would your approach to this child change?
Yeah, the approach will change because now, though this patient is a new patient is any child who has not had prior ATT for more than 1 month. So it, any new patient without history of prior ATT of more than 1 month, if there is a history of tuberculosis in the family, or there is a death where you do not know the sensitivity pattern, or the child himself or herself is HIV positive, seropositive. So in those cases, you need to get further investigations done. Then also, if the child is already on treatment of more than 1 month and the child is not responding to the first line drugs, or there is a failure, that is what we call the failure, or his left treatment, that is lost to follow up, and the child comes back again to your facility, or there is a relapse, that is the child was declared cured initially, and but now the child has had a relapse of tuberculosis. So all these categories you need to work further. As you've already discussed, we need to get the CBNAT done. Now, if the CBNAT is positive, well and good. If it is negative, then we need to get the MGIT culture. MGIT culture is sent side by side for those who are NAT negative. Now, based on the NAT report, if the NAT shows RIF resistance, as Dr. Virinder has very rightly pointed out, that RIF resistance in a child, if you are sure that the sample is adequate in a new patient, then it is taken as RIF resistance. But for a patient who's already had prior ATT, even a single specimen positive is taken as RIF resistance, and the child is offered now not only second line LPA, but also first line LPA. I'll tell you why. So the first line LPA is because now the regimens they have defined as separate. You have a regimen for RIF resistance, which can either be a short regimen, short MDR-TB regimen, or a longer regimen. So to fit the child into a shorter MDR-TB regimen or a RIF resistance regimen, you need to have a child who is INH sensitive, and also the second line LPA will tell you about the fluoroquinolone and second line injectable sensitivity. So such a child can be offered the shorter regimen. And the second line LPA, if it shows that the child has fluoroquinolone and or second line injectable resistance, then there is a separate regimen. That child is labeled as pre-XDR or XDR, depending upon if it is either of the two, it is pre-XDR. If it is both together, that means fluoroquinolone resistance along with second line injectables, that is labeled as XDR. Now coming to, this was for a child who was diagnosed based on the NAT with RIF resistance. Now, if the NAT report shows RIF sensitive, now in the prior days, we were leaving it till there, but not now anymore. We move further. We get the, again, we need to get the first line and the second line LPA, because the child would be eligible for the regimen which Dr. Sood has discussed for a new patient, that is 2 RSZD, 4 RHE, if but a separate regimen exists for only INH resistance. And further, the second line LPA is done because the child with INH resistance may have polyresistance, that means may have added resistance. So that is the flow chart. So to cut short and to base on the memory would be, you need to get a CBNAT done first. Based on the report of the CBNAT, if the CBNAT is negative, simultaneously send the specimen of a negative for MTB culture, put the patient, then you have to wait for the CBNAT culture, and you can start your first line drugs if the child is a new patient, as we've already discussed. But if the NAT is positive, shows RIF resistance, then you, or RIF sensitive, in both the scenarios, you need to get first as well as second line LPA done. And liquid culture is preferred because in case your patient is not responding, that's another scenario. Liquid culture will guide you further. You can get a liquid DST for all the drugs, or after liquid culture, you can get a line probe assay on the culture. So this is how the regimen would flow now.
So as Dr. Sangeeta said that in few of these situations, you would classify a child as a presumed DRTB, as already mentioned. If that is the scenario, then you cannot decide on drugs like that. You have to further investigate. The first investigations upfront, which means before you start treatment, you have to get a NAT and an MGIT culture has to be sent. And then you further classify it as rifampicin resistant or rifampicin sensitive. And further, as Madam has said, we have to see whether the rest of the drugs would be sensitive or resistant to decide the regime. It is a bit complex, we do understand. I have specifically put this not to confuse people, but just to let people know that how we evaluate these children, because you will come across these sorts of children in your practice. If at that time you feel you're not comfortable investigating them, we would recommend that you can refer these children, but do not put them on ATT without further investigations. Right, so we'll go on. So Dr. Singh, can you briefly tell us that what are the new drug-resistant treatment regimes, just to let people know that something has changed here as well.
Thank you, Ankit. Before I go take you through this table, let's quickly understand the essence. Okay, the essence was, in the past, we were treating everyone as presumed drug sensitive. So there was a category 1, which was RHZD, to which an E was added in the continuation phase later on because there was increasing INH resistance in the country. So we had RHZD for 2 months, followed by 4 months of RHE, which was 10 months of RHE for intracranial. We also had a category 2, which got removed once E was added for 2 reasons. We realized that if you were presuming drug sensitive in every case first time, and because the facilities for drug resistance was not available, treat them with addition of streptomycin, we were actually amplifying resistance to rifampicin and other drugs, and that was harder to treat. In the meantime, these nucleic acid amplification tests came to the country, which made it easier. Earlier, we had solid cultures. It would require you 12 weeks to 24 weeks to get a culture. It was not easy. Even in the state of Delhi, there were just 2 labs which were doing it. So it was just not possible. We were doing everything empirically. And therefore, we were gradually increasing the MDR-TB in the country. With the result that we now have a change, and now we are looking at picking up any resistance early enough. So if you have identified RIF resistance, you presume R and H, and therefore thereafter you decide for MDR therapy. But the moment you decide that MDR therapy, you want to be equally sure that the drugs which you are replacing the initial regime with are effective. And therefore, there comes the role of first line and second line LPA to know what kind of resistance to INH is there, what kind of resistance to fluoroquinolone or second line injectable is there, so that you do not use the drugs if they are also resistant to these. In our country, deficiency of fluoroquinolone or deficiency of ceftriaxone in the body results in fever. I'll give you time for this joke to sink in, because that's how we treat most of our PUs. Every pyroxia of unknown origin is either treated with the ceftriaxone injection or oral fluoroquinolone or a cefixime. So we therefore have a high level of background resistance to these in MTB. So we therefore cannot again use standard MDR therapy without looking for these resistance, and molecular methods have made it possible for us. So with this background, let me take you to the regimens. Now, since there are many drugs available, initially we were using injectable therapy. Injectable therapy is 4 to 6 months of injection, not easy in a small child, even in an adult. Great risk of ototoxicity. So gradually now, with the availability of new drugs like delamanid or bedaquiline, we want to withdraw and go to all oral. However, age becomes a limitation. You cannot use, till now in our country, we are not authorized to use bedaquiline, which is a new oral drug, below 12 years, or delamanid below 6 years. Therefore, you have a regimen for below 6 years forced on you because there is no drug available which is non-injectable. The combination which is now available, which is recommended, is what is also called as short regime, or called as Bangladesh regime or Dhaka regime, because that's where it was first tested. Very often in our country, we call it a short regime, which has high dose moxifloxacin, kanamycin, ethinomide, clofazimine, and paracetamide with high dose INH. When we say high dose INH, we mean 15 milligram per kg minimum, and ethambutol. This is for 4 to 6 months, and then for next 5 months, you take off kanamycin and ethinomide and high dose INH. That you do not use, and rest continues. That's the idea. Imperative in this is that this patient should not be also harboring resistance to either fluoroquinolones or second line injectables or INH, which is both to CAT-G as well as INH-A. These are two different mechanisms by which INH resistance occurs, because when you have both CAT-G and INH-A, you will also lose ethinomide. So your regimen will become weak. So that is why these patients need to be further tested for first line and second line LPA. If it is a difficult to reach specimen, you must upfront send that for culture. Otherwise, once your gene expert shows RIF resistance, you ensure you send another sample, you treat with this, and as soon as you know about the presence of other resistance, you have to change. If this child, and this regimen is not recommended for a disseminated disease, intracranial or extrapulmonary like a spine. That's not where it is recommended, because it's too short a regime to be used in those situations. So it's not recommended there. So even if you are below 6 years, if you have any of those diseases, you will not get this. This is only if you are below 6 years and you have isolated EP like an abdominal or a lymph node, or you have a pulmonary or pleural effusion. That's it. If you are more than 6 years and you have not a disseminated disease, not a severe extrapulmonary disease, you can, instead of injectable, get delamanid or bedaquiline if you are more than 12 years. So injectables go. And here, what is also added is linezolid and clofazimine along with cycloserine. This regimen is about 18 months. Here in the continuation phase, you do not use delamanid. Rest of the drugs are continued as it is. It's just the dose of linezolid will go down because it is there is a risk of increased toxicity with prolonged high dose of linezolid. It can suppress bone marrow. It can sometimes cause ocular toxicity. However, if you have a disseminated or severe extrapulmonary disease, irrespective of what age you are, you can only go on the conventional regime because newer drugs have not been tested there. You cannot get on a shorter regime because they are too short. So you go on a conventional regime, which has an injectable, which has a class A drug like high dose moxiflox with linezolid, which is another class A drug, and class B drug as cycloserine and clofazimine, and ethanamide and amikacin come from class C. So there is a grading of the MDR therapy. More you see use from a higher class, better it is. You need at least 4 drugs from class A and B, and that's how we constitute this regimen for disseminated disease. This is at least for 24 to 28 months, which you will get. There is another fourth type of regimen, which is not for RIF resistance. The first 3 which I have talked to you so far were for RIF resistance with or without fluoroquinolone or the type of disease they had, or like pre-XDRs. But this is a regimen which is if you have INH resistance. Earlier we were saying if you have INH resistance, you could be managed with a combination of first-line drug. Now evidence suggests that's not true. They tend to relapse more often and or fail more often. Therefore, INH is replaced by a levofloxacin. This is where Dr. Sangeeta also mentioned that since you are replacing one levofloxacin, you know about rifampicin. Ethambutol is difficult to test, but you need to know about fluoroquinolone, pyrazinamide, that they are not compromised. So you will therefore also continue to test this patient where you have identified INH resistance, whether they are sensitive to fluoroquinolones and pyrazinamide. Otherwise, that patient will also go to a complicated regime like the earlier one. These will need replacement. There is a very detailed replacement chart which is available. I think you don't need to know that. That's to keep people like Sangeeta and me in business. No, that's not the only reason. That's also because it's a starting point. We do not want to give you so much of information that you get confused. Remember that there is a modification of these regimen which is required. Those charts are easily accessible online. You can do it yourself, or you can always seek help from experts available in your area. So these are the new initial drug-resistant regimens which are available to us, which we should be using.
Last 2 to 3 minutes.
The timer says 12 minutes, ma'am.
Yeah. So maybe some questions will come in the chat box.
Okay. So I'll just try and wind up in the next 3 to 5 minutes. So very rapid fire to the point answers. So if we believe that this child is drug sensitive, what are you going to do about the contacts, Dr. Sangeeta, please?
Yeah, now the context would be based upon the symptomatology. If the child has symptoms, then obviously you need to rule out active tuberculosis. If the child is asymptomatic, then if the child is less than 5 years, you start LTBI management. If the child is more than 5 years, in that case, you need to counsel the parents that the child requires IPT, and you can do testing for infectivity, that is IGRA or MONTU, whichever is available, and offer the child again IPT. Now the crux is that we want if we want to end tuberculosis globally, emphasis has to be on the prophylaxis therapy, because one of the pillars is that we need to put 30 million children and adults on IPT.
Okay, so there's a bit of change, as Madam has said, in the algorithm that now the Government of India and the IAP has also included children more than 5 years for chemoprophylaxis. And that goes by the recommendation of the WHO as well. Because the risk of having TB in close contacts, even in more than 5 years, is significantly high. So this is something which has been advocated, and yes, we are moving towards TB elimination. So, Dr. Sangeeta, is it mandatory to do a lot of investigations, or
no? Not really. Okay. Symptoms are fair enough. The only thing is that you need to rule out active disease if the child is having, the 4 symptomatology, that is fever, cough, the presumptive TB patient, which we had already discussed, or a child, a newborn, where the mother is sputum positive and you need to rule out active disease and put the child on prophylaxis only after being sure that the child is. The other is HIV. HIV, you need to rule out active disease, but irrespective of the CD4 count, you need to start the prophylaxis, or whether the child is on ART or not. Prophylaxis with IPT. Now the combination is available for HIV, where you have the drugs available. And the other thing is for any child who's to be put on immunosuppressive therapy. As in children, you have nephrotic syndrome, leukemia. In those children, all TST positive who are receiving immunosuppressive, you need to rule out active disease, obviously. And if the child is asymptomatic, put the child on PPT, that is prophylaxis therapy. And as I've already discussed, if the child is born to a mother, the most important is if the mother is sputum positive, she needs to continue breastfeeding, wearing a face mask. That needs to be really told to the mother. Put the child on INH prophylaxis and give BCG vaccination.
So Dr. Sood, this child
and
after
now,
starting...
there are two, this 6 months of INH would be in future replaced with a shorter regimen, which is going to be intermittent. But for that, the child age has to be more than 2 years. That is rifampicin and INH weekly. So total 12 doses, 3 months.
So Dr. Sood, very briefly, this child now develops vomitings after around 10 days, 2 weeks. So what would you do?
Same, we are dealing with the drug-induced liver injury. And we should remember this is just a presentation like as we see in the prodrome of viral hepatitis A. So this is important to understand, and definitely as you already shown, so we need to order for liver enzymes and liver profile, and it is shown that most of the time ALT is above 500 and the AST may not be so much rise, so that probably qualifies, and invariably there is associated bilirubin also, which is range beyond 2. So that's basically now the purpose is once we see this patient, then two things are very important. One, we need to stop all this regime which is there, because this is invariably seen during the first fortnight. Rarely a patient can present late also. So we take ALT 5 times or less than 3 times, and then if another rider is that if patient is sick, as you have already shown, then you need to start with 3 drugs like streptomycin, ethametol if patient is very sick, and if patient is stable, then we can wait for 7 days and repeat ALT after 7 days, and most of the time 99.9% it will start coming down, and then we need to introduce gradually drugs. Rifampicin after 3 days, do more assessment, then add on INH in full dose, and after 3 to 7 days do, and then add on pyrazinamide. But there's one rider. If ALT remains more than 5 times higher than upper limit, then one need to take care of pyrazinamide. Otherwise, the toxicity will be higher. So you need to modify the regime. And as Dr. Singh and Dr. Sangeeta sharing, you need to consult a person who is dealing with this sort of patients.
So with that, we end the questions which we have made, and I think we can take a few questions from the chat.
Yes, so there's one question in the chat box from Dr. Manish Gupta, that what is the current percentage of MDR TB amongst pediatric TB patients, if we have any data?
You see, the national average is for rifampicin or MDR is less than 5%. Okay, but if you go to pediatric, perhaps we have seen most of the studies where when we looked at gene expert positivities, it comes to about 7 or 8%. So there is a bias also there, because the children also get a lot of transmitted disease, and it's not just the background which comes from the initial resistance which is there in children, in adults. So possibly we're talking about 5% resistance here in terms of an MDR. There are pockets like Sikkim or Bombay which have very high resistance, up to the extent of 20 or even more percent there of MDR, primary MDR. So in our rest of the country, we are close to about 95% are RIP sensitive. INS resistance is to the tune of about 15 to 30%. It varies at different areas.
Even fluoroquinolone resistance. So that also gets us to the answer that we need to seriously not use fluoroquinolones for any infection which can easily be treated with amoxicillin or other drugs.
Rather, Dr. Sangeeta, they are not recommended fluoroquinolones. It's only the amoxicillin, you rightly said. And as Dr. Singh was saying, I just want to add on, ceftriaxone is now being misused for all patients with COVID. Yeah. This is the first shot they get in any facility when they enter, ceftriaxone.
One more question from Dr. Manish. You want to ask Dr. Manish, or shall I just read it out?
You can ask Dr. Tapisha.
So the question is it okay to follow the pediatric PD algorithm and not to do tuberculin skin test as availability of right strength is an issue?
You see, we struggled with tuberculin skin test because we don't have the right strength. We do not know what it tells us, and we have been chasing it for a long time. Having said that, it does still have a little role, and the role comes when your molecular test fail you, and you have a standardized test available. It will have a role. But currently, in today's time, if it is done, instead an IGRA is done and it comes positive, maybe you can use it. But then that's expensive. And in high burden, low resources country like ours, it hasn't been shown to be any good replacement of a tuberculin skin test. If COVID had not come, perhaps Serum Institute would have been in news for producing the Copenhagen new TB skin test called CTB, for which they have acquired the worldwide rights, because now they have become busy with the COVID vaccine that's taken a back seat. So in a similar session last year, we were saying we are around the corner to get CTB in India. We are 1 year down the line, it's nowhere in the picture because the company is not even today talking of it. So therefore, we have removed it from the current algorithm because we do not have a standardized test available. The utility remains more out of loyalty to an old partner rather than an actual value addition it brings.
But definitely in cases of LTBI, sometimes, it would help.
LTBI is a different thing. Yeah. LTBI, there is no other test.
So there's one more question from Dr. Shalini. Can quinolone containing regime be used for MDR TB with neurotuberculosis?
Yes, we are using high dose of levofloxacin or moxifloxacin. They cross and they are useful.
In fact, they are one of the first, as Dr. Virinder said, they belong to the group A drugs, and you need to include maximum group A and group B. Group A, that is bedaquiline, which we cannot use. So the crust comes on moxi or levoflox with linezolid, and group B is cycloserine and clofazimine. So these are the major crusts of the MDR TB regimen. They need to be included. The only thing is, as Dr. Virinder said, this child would not be eligible for a shorter MDR TB regimen. Same would be a child who is seropositive, that is HIV positive with any extrapulmonary TB is again ineligible. And if the child has had a prior history of ATT of more than 1 month, that is reserved drugs of more than 1 month, that child would also not be eligible for shorter MDR TB regimen.
Ma'am. One last question from Dr. Prashant Seth, which is, what is the role of linezolid in MDR or XDR tuberculosis? Is there a role?
I had shown in the regimens that linezolid is a class 1 drug and they are being used. It's just that the first regimen which I showed you, which we call as a short regimen, it has only been tested in that combination. As I said, it's a Bangladesh or Dhaka or short-term regimen. There no replacement is permissible. We do not replace any drug with any other because it has not been tested. So linezolid therefore doesn't find a place there because when that was tested, that regimen was tested, linezolid was not established as an anti-TB drug. It came little later. And that is used for with other combination. And as Dr. Sangeeta mentioned, that it's a class A drug and therefore recommended, strongly recommended.
Thank you, sir. And so over to Dr. Ankit for summarizing, and then we close the session.
Yeah, so I think we're running short of time. When we do a 2 days panel, even then the questions don't end. So it is a burning topic. I thank all the panelists, Dr. Singh, Dr. Sangeeta, and Dr. Sood for a very nice discussion. We thank the PCNI team for inviting us here. If you have any more questions, you're most welcome to ask any of us. So thank you and have a great day.
Thank you.
Thanks, Dr. Ankit, and thanks to the entire panel for such a lovely session. And can you please stop the screen share? And now we'll go on to the next session. And the next panel discussion. The next panel discussion is on molecular diagnostics in infectious disease, BioFire respiratory panel. And the panelists that we have with us, we have an array of excellent microbiologists and clinicians from the country. So we have Dr. Raman Sardana. Can we have the CV slide, please? Dr. Sardana is an independent consultant in clinical microbiology and infectious diseases and National Secretary of Hospital Infection Society, India. We have Dr. Joseph Matthew. Sir is professor in pediatric pulmonology at PGI MER Chandigarh. We have Dr. Vikram Gagnida. Sir is consultant pediatric intensivist at Manipal Hospital, Dwarka, Delhi. And we have Dr. Vikas Manchanda. Sir is associate professor microbiology and infection control officer at Maulana Azad and currently in charge COVID laboratory at Maulana Azad Medical College. The moderator for the panel discussion is Dr. Chand Vatul. And I will request Dr. Manchanda to kindly introduce Dr. Chand.
Yeah, good afternoon, everybody. It's my honor to introduce Dr. Vatal, who is a great microbiologist of our country, and he's currently heading the Department of Microbiology and Infectious Diseases at Gangaram Hospital. He has been part of many interministerial.
Can you please put the CV slide for Dr. Chand Vatal? Rohit? Slide for Dr. Vatal.
Am I audible now?
Yeah, you're audible, Dr. Manchanda.
Yeah. So it's my honor to introduce Dr. Chand Watan, who is head of microbiology and infectious disease department at Sir Gangaram Hospital. He has been the strong pillar for microbiology in our country and has been part of various policy drafts which have been produced by the ministry from time to time. He has been the role model for a lot of young microbiologists in our country, and everybody wants to become Chand Vatal actually. So that's a very, very brief introduction for sir. And with that, I think it's over to you back.
Thank you, Vikas, for cutting it short because we are anyway short of time. And I hope we are accommodated accordingly. We started at 4:15. So probably we have another 60 minutes to us, for which we will appreciate that if we can leave 5 or 7 minutes for the question answers or for the discussions. And I am very pleased to be with all of you. And the topic is very intriguing as on today. Though things have changed quite a bit. And can the slides be shared? Unless I do it myself.
Rohit, can you share the slide?
Otherwise, I can share it.
So you share it yourself. If it's not possible, then we'll ask Rohit.
Sir, we don't have it, the PPT.
You don't have it?
Yes, sir. We haven't
Okay.
received.
I have sent it. Anyway, I'll try and share.
Okay.
Can you see it?
Yes, yes.
So you have already been told about the topic that we have, and my colleagues, very knowledgeable colleagues from the country, are here with us. And let us get ball rolling as to what is the molecular diagnostics in infectious diseases. Ladies and gentlemen, when I got initiated into clinical microbiology or the medical microbiology, it was the Koch's postulate that was hammered down into us, that you need to actually isolate, culture, and that's the gold standard. But then as the days have passed by, all these 40 years, 35, 40 years, or even more, we know that more often than not, that kind of a gold standard probably may not be achievable, and we may be missing cases. And that would be very hard for the patient who is raised by the infectious diseases. So we had to shift the goalpost. So we have shifted the goalpost, and I'm very glad that we have a heading this time, that is the molecular diagnostic in infectious diseases. So this is where actually we need to arrive. And if we have to arrive over there, we need to discuss and carry our clinical colleagues along with us as to how do you see the utility of this, and how can you change the mortality and the morbidity when you are talking of infectious diseases, or the PUOs, how these are to be diagnosed. And we'll be primarily talking of the diagnostics as far as the molecular applications are concerned. I'm sure my colleagues are here, though I could not see them on the screen. Professor Matthews and Dr. Vikram, who are there, and this could be the first exposure to them as to how difficult is it to make a clinical diagnosis of pneumonia, whether it is viral or bacterial, in OPD, IPD, or ICU settings. Actually, under a WHO project, when we did the survey, the commonest thing of overuse of antibiotics, as was told to us by the general physicians, was that they cannot differentiate in various settings a diagnosis of a bacterial or a viral pneumonia. And that's the reason why they are using antibiotics right, left, and center. Professor Matthews, could you just start with your comments?
Okay, thank you, sir. I agree with you. Clinically, it is not possible in most settings to distinguish bacterial from viral pneumonia in the OPD. It's also probably not required to do that unless we are definitely clear that we will not treat if the child seems to have a viral pneumonia. The second point is there are some syndromes like bronchiolitis, which clearly are viral. In such settings, we don't even use antibiotics. So in that kind of a situation, even if we didn't have a molecular diagnosis for etiology, that would be fine. The problem comes with in-bed patients, whether it is in the ward or in the ICU. If they've been admitted for pneumonia and the children are deteriorating despite our best antibiotic therapy, that is where probably it would be useful to have a clear-cut molecular diagnosis, which unfortunately we don't have right now. That is my first take on this particular question. Thank you, sir.
Dr. Vikram, you want to add anything?
Good evening, everyone. I think as Dr. Joseph has said, it's very difficult to pinpoint even pneumonia on clinical examination and by taking good history. And most of the time, these symptoms and signs, especially fever, cough, and decreased oral intake, they are very non-specific. And only increased work of breathing only just let us point us towards that the child is suffering from pneumonia. So to differentiate between viral and bacteria is very difficult until patient has very specific feature of viral coryzia and the patient is general conditions looking fine. So then we can just wait and watch for a few days, and if he gets fine, it's most likely it was viral infection. And if the patient get admitted, then obviously we take the help of X-ray and our inflammatory marker, especially TLC, DLC, and to some extent CRP. They just tell us about what type of etiology can be. It can be viral or bacterial. And being an intensivist, it becomes very difficult for me to differentiate between viral and bacterial in ICU settings. Because in ICU setting, usually the patient get admitted in severe respiratory distress, and especially in face of any epidemic like the flu epidemic we had or present pan epidemic, we end up using empirical antibiotic till the patient we get all the cultures and all the get back from the lab, and which takes time. So I feel molecular diagnosis, especially in the ICU setting, it can help us at least to use our resources well, especially in time of epidemic, or otherwise we can curtail on the use of empirical antibiotic if we get these tests to us very fast. So definitely there is a role of molecular diagnosis, but we need to decide which patient we need to choose and which setting we need to do it.
And what? You see, we cannot forget that we are staying in our own ivory towers. You talk of a general physician or a practitioner on industry or outside metros as to how difficult it is for them actually to get into this kind of a diagnostics. So anyway, we take this forward, and there is a need, as has been said. So again, both of you, if given a choice, more often than not, most of the infectious diseases or the fevers, they come with a similar kind of presentation. And would you like to have a syndromic approach for diagnosis? Because as we said, that bacterial, viral, or even parasitic at times, or fungal, that you may find bundled in one. And a infective pathology for meningitis, for example, could be a case in point. So how would you actually, would you like to have a syndromic approach of diagnosis? Do you think it is beneficial, Professor Matthews?
Actually, no. Ideally, all children should be treated on an individual basis based on their clinical profile, the signs and symptoms, and what they are likely to be suffering from. The syndromic approach can be used in the event that we are not able to do that, which means we treat everybody who has got a certain set of signs and symptoms in a uniform way, as we currently do, until we have a clear-cut diagnosis or a clear-cut etiology. Now, the difference between pneumonia and meningitis should be understood upfront. Both could be bacterial or viral infections, but meningitis is a syndrome wherein you have a body fluid which is otherwise sterile, which means that anything you isolate there can be taken as a cause for the problem which the child is suffering from. The same is not true for pneumonia. We don't have a body fluid which is normally sterile. We can't get a sample from the lung. We have to rely on surrogate specimens from surrogate sites, which are usually not sterile and are also colonized with the same organisms in normal or healthy children. So the parallel does not exist between pneumonia and meningitis. So it won't be very easy to translocate or extrapolate the data from meningitis onto pneumonia. But in general, till we have better diagnostic tools, I think we'll have to rely on this syndroming approach. Thank you, sir.
Very well taken. Dr. Vikram, you have to add anything?
Sir, I think in our hospital, we prefer to use individualizer approach, as these tests are very costly. We want to be cost effective for the patient. To highlight this, just if I'm allowed, let me recall two cases which we have recently managed. So both are case of acute febrile encephalopathy. The first case presented with acute febrile encephalopathy with status epilepticus. And we got his MRI done, which showed feature of encephalitis, and there was some temporal lobe involvement. By the time we got his blood investigation, and those were suggestive of dengue infection. And the patient was started on empirically initially on ceftriaxone and acyclovir because there were temporal lobe involvement as well. But once the patient got stabilized and we did his CSF, so we individualized his approach. So instead of sending whole panel for CNS tropic viruses, we only sent for herpes, right? Because we already had dengue infection from the blood, and there was temporal lobe involvement in the MRI. So we just wanted to rule out herpes because the patient was started on acyclovir. So once we got the report within next 24 hours, his CSF herpes was negative, and we could easily discharge this patient within next 6 to 7 days, which otherwise would have been possible without getting these micromolecular diagnostic tests done. The second case, in this case, we use individualized approach. In second case, the patient was admitted with abnormal behavior, and he had a lot of psychiatric manifestation, and patient was referred from other hospital, and he has been extensively investigated, including his LP was done. So in this patient, when he came to us, he was running fever. So in this patient, we went for, because we had no clear-cut diagnosis, we went for CSF pantropic viral. So in my hospital, we prefer to use individualized approach. Even for it depends from patient to patient. If the patient has been thoroughly worked up in the past, then we go for syndromic approach. And if patient we have some clue of some etiology, then we go for a specific one-line test.
Okay, so that is a well said approach for the diagnosis of ID as it is. And again, in absence of this, what is the logarithm that we could be following in the various settings that you are usually faced with? Because OPDs is a different scenario, IPD and PICUs are a different scenario. So what is the logarithm that you would be recommending? Any one of you?
Okay.
Or Dr. Vikram?
Yeah. So usually in absence of these molecular tests, usually what we do is based on clinical history. If we are sitting in OPD setting, as Dr. Joseph was saying, the patient is looking well, we tend to wait and watch, right? In IPD setting, obviously we do some test and try to figure out is it viral or bacterial. And in PICU setting, we send usually the patient, if the patient is sick, usually start them on empiric antibacterial or antiviral pending all the reports. So this is usually logarithm for all the sick patient, be it any system get involved. But usually in pediatric age group, general condition, then taking the help of TLC differential, few biomarkers that tell us, that try us, get us some differentiation point between viral and bacterial.
Yes, sir. I think I would tend to agree. But the point is that we first have to make a clinical diagnosis. The problem with the many clinicians is that they start with investigations and treatment without putting a label as far as possible. So once we have a clinical diagnosis of certain conditions like say bronchiolitis or viral V's, such children don't require antibiotics. So we have sorted them out at the clinical level itself. The issue comes when the child is admitted in hospital, which means he's severe enough. There could be elements of viral which are super added with bacterial infection or otherwise. In all such situations, we would start with empiric treatment using antibiotic therapy to which organisms in our own individual hospital or setting are sensitive. And once we do that, we send off the biomarkers, whatever is available. We wait and look at the clinical response in 24 to 48 hours. And then we taper or tailor the therapy depending on what the child shows and also what the lab reports show. In the PICU setting, the ball game becomes slightly different because it is possible that the child is suffering from the primary infection that he started off with, or it could be something which the hospital has given. So knowledge of what the organisms are in the setting, what the sensitivity patterns are, will help to again start an empiric treatment, tailor it based on the culture sensitivities which are available, and then step down or step up as the need arises. Thank you, sir.
Hello.
Yeah, Dr. Vatan, I think you need to unmute yourself.
Was I muted till now?
Yes, you were muted, sir. I think you need to go to the fourth question, sir.
I did not mute myself somehow. Was I here?
Yes, you are audible, sir.
Okay. So now, both of you, have you been having the experience of molecular diagnostics in the infectious disease to take our discussion further?
Sir, if I go system-wise, we have been using these molecular tests. If I go system-wise, so for CNS, we have been doing CSF for herpes, entero, and JE for a long time now. Gene expert we are doing for TB, and in specific situation, we also get a panel for CSF panel for CNS tropic viruses. In respiratory system, flu swab, we have done a lot of flu swabs, especially during the pandemic of 2009 and 2010. Presently, we're doing coronavirus, and lately, even Gene Expert has also started in my hospital, which give a test within 1 to 1.5 hours. RSV, we have done in case of bronchiolitis, and in selected patient, immunocompromised patient, where we are not able to pinpoint any etiological diagnosis, we even gone for respiratory biofire. For liver, in selective patient, we have been using hepatitis C, B, or even HIV. Chikungunya, we have done when, like in the early phase, we need to make a diagnosis. Blood, for immunocompromised patient, we have done blood PCR as well. But usually, this is very costly test. But in some specific population, it helps us a lot, even in ruling out some MDR bugs. Stool, we are not doing stool PCRs because we feel those are not cost effective, and usually most of the diarrhea is in pediatric age who are self-limiting and they go away without any antibiotic treatment. So these are the few of the tests we have been doing in our hospital.
Professor Matthew, so this is the fifth question which he has already actually initiated with. If you could add what is being done at PGI?
Yeah, in addition, we rely for Bordetella pertussis. We rely on PCR for that because that is the more reliable test than just looking at the swab, and also for CMV. Now, CMV is a funny bug. It creates problems in immunocompromised patients usually, but even in immunocompetent. So we rely for the diagnosis on the PCR. Other than that, whatever Dr. Gagneja has listed are the same things that we use as well. But my main experience from these PCR panels comes from research-based studies on childhood pneumonia, wherein we've looked at nasopharyngeal aspirate swabs of thousands of children and understood their limitations and strengths, which we will discuss, I think, in the coming few minutes. So I will not speak about that now.
Yeah, that's very right. So that's very right. So now let us shift our things to the microbiologist friends. So both of you can address this one by one. That what are the various molecular diagnostics available, whether singleplex or multiplex or microarray based, that is in vogue currently and available now in India for the diagnosis of ID. Dr. Raman and then Vikas could give their comments. Dr. Raman Sardana. Am I audible?
Sir, namaste. Yes, namaste to everyone. Now, there are a plethora of tests which are available, and one tends to get confused. There are hybridization assays, there are amplification techniques. The amplification techniques can be simple PCRs, multiplex PCRs, broad range PCRs, or they can be microarrays combined. Also, there are post-amplification detection techniques which are used in combination with PCR, like PCR with hybridization, PCR with sequencing, PCR with Martitov, MS, and such like things. And obviously, there are non-nucleic acid-based techniques also, which are used like Martitov purely, but that is later on. So broadly speaking, these are the various molecular tests. And the most commonly used have been the PCRs, and that is multiplex PCR or broad range PCRs, including the hemi-nested ones. People would be aware with Mycobacterium tuberculosis, and now with other tests as well, HPV and such like things. So it also does give the hemi-nested assays. They also give an indication about drug resistance. Similarly, with microarray assays, they also give a good amount of presence of genes which code for resistance. And they give a combination. The microarray assays have, though they are expensive, but they have a huge variety of gamut of things in single assay. So one can get information about what all organisms one would be dealing with, and one has to obviously apply clinicals into it, including history and everything, the condition of the child, and what has been right from the where the patient has come from and how the disease has started. So all those things have to be applied, and then one can find a very good conclusion while using these microarrays and multiplex PCRs. Anything from Vikas add-on, please?
Yeah, Vikas.
Yes, sir. So before I elaborate further on what Dr. Sardana has said, I would just like to explain few things for the interest of the postgraduate students and the young pediatricians who are there. They need to understand that when we say molecular diagnosis, that means we are looking into the genetic material from the patient sample for a pathogen, right? So when we say single plex assay, that means we are detecting one particular pathogen we are targeting, we know clinically that, for example, it is Streptococcus pneumoniae or HSV, which we want to look into. So we have a specific set of genetic sequence for which we are targeting and diagnosing it. Multiplex is when we have more than one pathogen to identify it. And generally there is a limitation of the technology as far as multiplex is concerned. So in a single tube or single container in which we are testing, generally not more than 4, at the maximum 5 targets can be detected. So if we want to detect more than 4 and 5, either we use multiple set of tubes or we use what is known as microarrays. Microarrays are nothing but they are very, it's like a checkerboard, like a chessboard where each square is working as one tube and you have a specific target sequence for that. So this is how the molecular diagnosis actually works. Now, the whole of this molecular diagnosis and research started in late 1980s, and the commercial assays started appearing in early 2000 years. So that is the first diagnostic assay which was developed was ViroChip, as it was known as, and was launched in 2002. And this ViroChip actually could detect many number of targets, and it was instrumental in even characterizing the original SARS, novel SARS coronavirus, which was there in 2003 outbreak. After that, after 8 to 10 years down the line, the microarrays expanded, the technology improved, and then we have the Nimble technology platform which was there, and it could detect virus, bacteria, fungi all together from a clinical sample in one go. And slowly we got into those kind of platforms where they were detecting more than 60 or 70 resistance genes. So antimicrobial resistance you can detect and do it. But they remain into the laboratories or high-end research laboratories. They could not be catered to the general population. Then now the whatever assays which are available are being categorized based on the syndromes as which we have discussed it. So if you have a bloodstream infection, you use certain set of assays. If you have a respiratory tract infection, you use certain platforms and assays and so on. So blood sample per se is a very challenging sample, because when you brush your teeth or the child is there with certain cavities and all, so there are transient bacteremias which are happening. So presence or absence of genetic material for that particular pathogen in blood does not always necessarily mean that it is a incriminated bug. So that is why the bloodstream infections specifically have been restricted to the bacteremias or the bacterial sepsis diagnosis, and that too after the blood culture bottle has beeped. So we have platform like Verigene or film array assays which are available for bloodstream infection, but only after blood culture has been done. Then we have the respiratory pathogens which are there. In this, there are enormous number of commercial assays which are closed systems are available. That means the machine and the cartridge or the system has to be purchased by a single vendor. They are easy to use, but they are very costly, not affordable by all the population. On the other hand, you have the commercial kits which are being approved, which you can use on a general platform. And we all now know there is a real-time PCR machine and you can run any number of targets once you have the defined assay and standardized one. So that is available. So for respiratory infections and CNS infections, we have these kind of kits. So there are studies which have shown that even up to in normal real-time PCR, you can detect almost 30 to 35 different pathogens in single go. And the sensitivity of these PCR assays is also well established and generally range between, depending on the pathogen actually. So that we will take maybe a few time later. So these are the various platforms or the technologies which are available for molecular diagnosis as of date. Dr. Babu.
Yeah, that's very right. And probably as the days would pass by, these may come very closer to the patients, maybe not only in the big cities or the metros, and maybe in the even at the healthcare setting, at the primary healthcare settings. So, if we are talking of these kind of assays, finer, which are getting more finer and finer as the days are passing, uh, could you people just tell us as to what is the sensitivity and specificity of these kind of assays? You heard your pediatric colleagues telling you that they would actually filter out cases where they would like to do any kind of syndromic diagnosis or molecular diagnosis for their patients. And then, is there anything for them that we talk by way of the specificities and sensitivities that may make them to look at these kind of molecular applications when they are coming to a diagnosis? Will it change their morbidity and mortality? Dr. Raman?
I think Vikas had summarized very well, and sir, the whole situation has to be understood in one manner, and that is pertinent line which Vikas had said. Hello.
Yes. Yes. Hello.
Yeah. So what Vikas had said was, I think we have to focus on that line. And that particular line was that we are detecting the genetic component of the microorganisms. So that has to be kept in mind every time we bank upon molecular tests for diagnosis and for managing. So depending upon what test we are looking for, and a multiplex assay.
आपको देखना है क्या हो? हाँ, हमें कनेक्ट करना है ना? अरे करो ना, पर टाइम तो मेरा हो गया.
So any multiplex assay would have.
Is Dr. Raman audible?
Sir, I think I'm getting a lot of disturbances on.
Yeah, some speakers are on.
Yes. So,
anyway.
So the sensitivity can differ according to the assay what we are using. And,
no, in your experience, Dr. Raman, what we are trying to say, or Vikas, what we are trying to say is, in your experience, whatever you have used, what is the home take message as far as their specificity is concerned, which will be an issue we will be talking about. Sensitivity is concerned when they think that they can be helped for the diagnosis. That is the moot point of discussing this this situation and molecular diagnosis. In your experience, how do you see their sensitivity and specificity?
Sir, in situations dealing with meningitis, then I suppose that whatever we have seen has gone very well. Initially, sometimes it differs with the clinician's perspective or the treating consultant's perspective of what they were looking at, but finally, I have seen close to about, I don't even remember, in fact, that a single case where something like microarray, the BioFire systems or the multiplex systems, they have erred on the wrong side. So especially in specimens like CSF and even in respiratory tract, if one applies the clinical, right from the history and the examination and the condition of the patient, and also what has happened to the family, then one can get a good amount of the therapeutic management also from them, especially if like a Klebsiella which has grown would require say about 10 hours, 12 hours of further processing to get to the resistance markers by the automated machines. But with something like PCR of microarray systems or the microarray systems, one can get these resistance markers in barely about 1 hour or something, and much before. So one can correlate very well, think about whether they are secondary infectors or whether they are primary ones. Are they fitting into the to the X-rays and CT scans or not. So
okay.
Those things have to be. Now, I have told you about the CSF, where we have been almost 100% on dot, and we have been able to cut off. Now, in fact, if we give any report on CSF, finding a virus, then obviously, or even a bacterial except pneumonia, people don't even, they just go ahead, either they cut off the extra antimicrobials or they just, cut off the antimicrobials totally in case it is a viral infection. So that has been the faith in it, sir.
A request to the panelists to wind up in next 5 minutes so that we can have some time for discussion.
Yeah, there are around 10 minutes before we wind up. Yeah.
Yeah, sir.
Yeah,
I would just like to summarize in 2 lines that sensitivity and specificity of any assay depends on which pathogen we are talking of and what type of sample we are using at the timing of that sample. For example, in the viral illness, earlier early you do the sampling and do the testing, there is a higher chance of getting molecular diagnosis on a dot rather than lingering around, and after say 10 days, 15 days, as the disease progresses, the chance of detecting that particular virus specifically decreases. So the molecular diagnosis has to have a balance of type of sample, time of sample, and which target you are looking into.
Yeah. Okay. Now let me also be share some of our experiences that we have been doing at Gangaram Hospital. For example, this is a respiratory biofire. Around obviously the 2020 data is almost not there, so we have the data till 2019. 13 the 1373, and you can see that how variety of diagnostics were done, and we could find out that RSV and metapneumoviruses and rhinoviruses were causing the disease at during that time, and some of the difficult organisms also were picked up, like Bordetella parapertussis or Chlamydia pneumoniae, which ordinarily we would not be able to pick up, or Mycoplasma pneumoniae, which also could be picked up. Similarly, if you look at the pneumo panel, which is primarily for the ICU settings, you can see that you can find out that you very quickly pick up the Acetobacters and the Klebsiella pneumoniae and some of the very rarer organisms that you can talk of, the para-influenza, adeno, and all kind of these plethora of organisms one can pick up when the patients are in ICU settings. And similarly, if you talk of the meningitis panel, you can see that out of the positivity was 49 only out of 490. That was 10% only as it was, and only 2 had co-infections. And we would not be able to pick up these kind of viruses earlier, or CMV or varicella zoster or even enteroviruses earlier, before we had this multiplexing system. Similarly, the GI panel, we were surprised to pick up some of the very interesting cases of penitences, and even norovirus and Campylobacter and Cryptosporidium on these panel, and C. difficile including with that. And some of the transplant patients we picked up Salmonella in a reverse manner when they were not even febrile and developed febrile illness later on. These are some of the new respiratory panels in which the SARS-CoV has been added, and it has around 21 targets in it, and it does give you bacterial as well as the viral kind, and you can see the sensitivity and specificity by the manufacturer that is being given over here. And they also have the blood culture, which we are talking about. Ask any intensivist in the ICU as to how important the information to that person would be, whether this patient is raised with Klebsiella or Acetobacter or the other kinds of bugs like Staph aureus or VRE, along with this kind of a mechanism of resistance. He would love to have these kind of informations in treating his patients. So these are some of the value additions in microarray multiplexing systems. Now I will come back to my pediatric colleagues. Is that in your experience, what are the challenges you face in understanding and interpretation of these tests? Professor Matthews, you could go ahead, and then Dr. Vikram.
So I think, sir, there is no problem in understanding the test because Dr. Vikas clearly pointed out we're only looking at genetic material. The problem comes with interpretation because we're looking at a nucleic acid material amplified several thousand times. We will never know whether it is pathogenic or not. In other words, detecting the presence of footprints of an organism may be a casual association or it may be a causal association. And if you remember the slides which Professor Vattel has shown us previously, you'll see that many of the panels had multiple organisms coming out. So when an organism is, when there are 3 organisms per patient, you really can't make out which one was the cause and which one was a bystander, which one was a secondary infection. So I think these multiplex PCR panels raise a high noise to signal ratio, which means you get some information, but you really can't tell the clinician in many cases whether he has the confidence to stop treatment which he has been giving based on the results or to start a new line of therapy based exclusively on the results, except in fluids which are normally sterile, that is CSF, and to some extent blood as well. Thank you, sir.
I agree with you, and that's perfectly very well taken. And this is the noise actually, even in these microarrays. I didn't have the slide over here because of the paucity of time. It now also tells you as to the number of organisms that you you can detect, whether it is 10 raised to power 1 or 10 raised to power 5 or 10. In that scale, you can actually make an opinion in a pneumonia patient in an ICU setting as to what is actually more important to you. You would certainly not care for an epidermis staph if you have a Klebsiella pneumoniae that it is showing it's to 10 raised to power 8 or 10 raised to power 9 with the kind of detection of an endium. So you will have that information out of that background noise, but one has to learn over a period of time as to how to deal with this kind of a noise to be useful in particular settings that we are talking about. And I think Dr. Vikram also has an opinion. Dr. Vikram? Hello?
Dr. Vikram, please unmute yourself.
Okay, sorry. So in addition to what Dr. Joseph said, I think the other confusion we feel is when the reports are of like panel, you get different report, and on culture you have a different report. Then it becomes very difficult what to believe. And then cost is another big factor presently in our scenario, and especially if these tests are not done in-house, then the TAT time is more. Then it would totally lose whatever the benefit we are going to get with early turnaround of these tests. So I think I've highlighted one case over here, like if I can go on that.
I was trying to do that. It's slipping actually from here.
We are running short of time.
Yeah, so this case is of 3-year female child who was a case of myopathy and was on tracheostomy and home bypass treatment. And the child had presented to us with history of running nose followed by fever, and then child had repeated vomiting, decrease intake, and decrease urine output. And for these complaints, the child had to be admitted. And on initial workup, what she showed that all the biomarkers were negative, even the CRP, TLC differential were pointing toward viral infection. But after 40 hours, once the child was not improving, at the admission only we have sent the culture and the respiratory comprehensive panel, because this child was on this thing tracheostomy, and we thought this will help us in deciding his antibiotic therapy. So PCR was negative. Initially, we didn't start him on any antibiotic, and we just treated symptomatically. And when we got the report after 48 hours, the culture showed a pseudomonas with colony count of 10 raised to power 5, and the panel showed some different report. And panel was positive for one virus and 2 bacteria. So it become very difficult where to go about. So then we have to, like always, whatever we are test we're choosing, we just cannot decide in isolation. So we have to always club the clinical condition, how the child is responding, and then decide on that for the management. So we need to do diagnostic stewardship. In addition to antibiotic stewardship, we need to follow diagnostic stewardship so that we take the right test for the right patient. I think that is the addition.
That's very well accepted. We don't treat the reports, we treat the patient. That's what I believe in always. and that is the background noise that Dr. Joseph was also talking about. So this is there are some commercially available assays that we are talking about that are FDA approved and CE marked now in the platform. Vikas, can you very quickly sum it up so that we go to the final comments? Vikas?
Unmute yourself, Dr. Vikas.
Yeah, something else popped up actually. So, sir, the point of care test typically means that the result should be available within half an hour of the sampling. So, I gave you one example from influenza A virus. Currently, CDC, US CDC has approved 8 different platforms which can tell us about influenza A virus in half an hour. So the common ones which are available in India includes the this ID now, which is there from the Abbott. Then there is a Cepheid or the Gene Expert platform which is available, and BD platform also is available for this particular purpose. But they are again need to be looked into as per cost benefit analysis, and once you have tested it, what you are going to do with the result. So it is very important not only to diagnose, but it is also important if you know the diagnosis, what you are going to do with that diagnosis. So that is into the part of it. Besides it, almost 30 different other POCTs which are available in the market only for influenza A virus, along with or without RSV, as far as pediatric community is concerned, which they will be more interested in. So like this, we have many more which are available, like MRSA testing, we have the few, and even for VRE, if we are looking into vancomycin resistance, they are available. So both for viral and the bacterial resistance, we have point of care tests which are available as on date.
Thank you
Can
very
you
much.
go for final comments now?
Final comments from all my panelists. Dr. Joseph, what would be your home take message?
Oh, okay. So I think the important thing is clinician is asking a question, what is causing this child's problems? The biofire or the other microbiology panel is giving an answer. Nucleic acid of the following organisms is present in the biological sample that you have sent. Now, if we don't understand the gap between the question that is being asked and the answer that is being provided, we will never end up being able to use these panels in an effective and efficient way. That's first point. Second point is we talked a lot about sensitivity and specificity. These terms have no meaning unless we know what they're being compared against. And the gold standard for all microbiological or organism related thing is a culture, which is next to impossible for viruses. So when we say sensitivity of 97%, etc., it doesn't really mean much until we know that it has been compared against a culture. The third thing is many clinicians use these tests as a kind of crutch, that I'm thinking that this is probably RSV. So if the panel also says it is RSV, so I'm strengthened in my conclusion that the panel has supported me. Now this kind of leaning on each other reaches a level at which the clinician thinks the panel is supporting me, the microbiologists think that our panel is supporting the clinical judgment. So it really does not go anywhere. I think the summary is that these panels have to be used judiciously. Nucleic acid amplification tests have their limitations and also their strengths. We have to make a clinical diagnosis and identify a cohort of children which don't seem to respond to standard treatment, wherein judicious application of these panels may help further to aid in the diagnosis, and no diagnostic test which does not translate into some kind of a treatment decision, which means either to start a treatment or if the patient is on a given treatment to stop or change that treatment. If the diagnostic test panel does not give us this information, then such kind of a test is of limited use for the clinical scenario.
Yeah, I broadly agree with you, Dr. Vikram.
I feel way we are using antibody stewardship to our best of effect. I think we need to use diagnostic stewardship when we're using these tests.
Yeah.
And not do all the tests for like doing a syndromic approach in every case won't be a cost-effective way. And other point I want to add is we always need to, as you said, always need to treat the patient, not the test. So we need to always collaborate these tests with the clinical condition and then decide on the
That's right. That's what Dr. Joseph also said. Dr. Raman, last words.
Sir, history is important. And we do appreciate that many of the difficult patients can be managed with the help of molecular tests when nothing is forthcoming. But it has to be initiated early. Now, once we have decided on a molecular test and we think that it is going to be a costly affair, one should also look at the money which has to be spent on length of stay of the patient, or in other investigations, or when the whole family is engaged, leaving aside their businesses and professional life, and just engaged on the child's recovery. So all those things need to be taken into account. Obviously, I agree with the clinical colleague, the pediatricians here, that it has to be a collaborative effort, beginning from the history. Brucella can be picked up only when you think that there is a firm history of exposure. Of something in Rajasthan or in Haryana where the patient has been in contact with animals. So those type of things need to be put in, and obviously if we find lymphadenopathy and other things, that has to be correlated well. So it has to be a collaborative approach. That is what my take.
Vikas?
Yeah, I think the conclusion is that molecular diagnosis do help in diagnosing and treatment of the patient. Only thing is a diagnostic stewardship, which is required to have a right sample at the right time for the right panel, Yeah.
And the sterile site.
Yeah.
And
so we need to
sterile sites.
Yes. So more so from the sterile sites and lesser from the where we have a gamut of organisms already present, which can be misleading.
Thank you very much. Thank you
There's
very
a
much.
question in the chat box. Can I ask, sir?
Yeah, please go ahead.
Question is from Dr. Shyam Kukreja. He says, any experience in North India regarding tropical fever panel, which is being used currently in Mumbai, which is also a biofire panel?
Yeah. Vikas, you want to take this?
Yes, sir. So tropical fever panel typically depends on the epidemiology of disease in that particular area, and also has the impact on the seasonality of the disease. So if you have a tropical fever panel being used in a hospital setting which is very near by to say slum area or resettlemental colony, or where poor water supply is, you will have bulk of salmonella coming in. Whereas when you are into the season of, say, dengue and chikungunya, more of dengue and chikungunya will be coming in. Similarly, if you are in the sub-Himalayan belt, it will be rickettsia which will be coming in. So it all depends in which area you are and what disease you are looking into.
Vikas, I wanted to know was, because what I wanted to know was experience, because it picks up leptospirosis, it picks up scrub typhus. So it is very important in a rare case where we are really struck for the diagnosis. In those situations, have you any experience of using it?
Sir, to our experience, I think leptospirosis in our region has not come up not to that extent. Even the, I would say, sporadic cases, it is not there. As far as rickettsia is concerned, definitely yes, it do help in diagnosis, but the cheaper diagnosis in terms of, for example, serology here for this particular disease is more useful than going for a panel testing for rickettsia.
Actually, the panel that should be for India is not really forthcoming. We do have gaps in those kind of panels that are available as on today. The things that you are talking about are not on the panel.
Sir, it contains dengue, chikungunya, leptospirosis, scrub typhus, everything in India.
Japanese encephalitis is not there. Then scrub has now come up. It was otherwise JE was not there. It's still not there. And chikungunya, I think, has now been added. And there are a few more that are not there. Salmonella is not there. So there are a few which are not in the panel that should be suited in Indian settings.
Right, sir. Thank you, sir. Thanks to everyone for an excellent eye-opening.
One question, one small question I would like to ask.
Yes,
Sir,
Dr.
what is the cost of this biofire technology in India so far? Like, and is all FDA approved or only for the point of care use?
These are all FDA approved. All biofires are FDA approved. The only now the one that they had emergency approved was for SARS-CoV biofire, but that has now been withdrawn and has been included as FDA approved in their revised pneumo panel, in which SARS-CoV-19 has been now added. Regarding the costs, yes, these are costly. They are varying between, it varies from place to place. Varies from 8,000 to 11,000 as a panel.
All right, sir. Thank you, sir. Thanks, Dr. Vatal. Any last comment, Dr. Vatal, sir? Your last word on this?
No, it was very well taken from my clinical colleagues from the pediatrics that they would certainly like to treat the patient and not the report, and that is what the spirit should be. One has not to get lost in the maze of investigations. These maze of investigations will help you only if you correlate them clinically. And the background noise that Dr. Joseph was trying to say was absolutely well taken. And you learn actually over a period of time. You do a few thousand tests and then in the each area, and you do realize that primarily you grade them in, because some of my colleagues love some of the multiplexes. For example, in the ICU settings, as I said earlier, in the bloodstream infections, for example, a blood culture bottle comes positive and the same, that is say overnight 18 hours or 16 hours, and within another maybe 50 minutes you are able to tell him whether this patient is raging with Acinetobacter or Klebsiella, that is death knell to his patient, or Pseudomonas, which is, or E. coli, that is amenable to actually treatment. And similarly, if you can detect an MRSA right away or a VRE right away, or even Candida that is raging. So these are very important things that one can pick up from bloodstream infections that can limit morbidity and mortality. And similarly, with detecting Streptococcus pneumoniae very promptly in CSF also does actually help in the morbidity of those patients who are to be treated, and if they are detected as penicillin resistant or sensitive. So these are some of the highlights of these molecular assays.
Thanks for the entire panel discussion, sir. We'll be wrapping up this session now. Let's look forward to the day when we have SARS-CoV-2 as a commensal in our biofire respiratory panels. And with that, we'll close the session. And now I'll invite my colleague, Dr. Rajiv Gupta, to take over as a scientific coordinator for the next session. Dr. Rajiv.
Thank you very much. Thank you very much for the opportunity.
Thank you.
Thank you, Dr. Tapisha. After interesting session on molecular diagnostic, now we move on to another interesting topic in neonatology. What not to miss in first clinical evaluation of a unit in office practice by Dr. Jai Kishore. Yeah. So
you have to stop screen share. Yeah.
So chairperson for this session are Dr. Anirudh Ghai. Rohit. Topic is what not to miss in first clinical evaluation of a unit in office practice. Speaker is Dr. Jai Kishore. And the chairperson for this session are Dr. Anirudh Ghai. He is a senior consultant, Department of Pediatrics and Neonatology at Jaipur Golden Hospital. Dr. Sushma Nagia. She is a senior. She is a director and professor of head department in neonatology at Lady Hardinge Medical College, Kalavati Children's Hospital. Dr. S.S. Bist is a consultant pediatrician and in charge NICU at Swami Dayanand Hospital, Dilshad Garden. And Dr. Piyush Khanna. He is a consultant pediatrician and chairman, Gaudium Women Hospital, New Delhi. Over to you, chairpersons, to introduce our speaker for the day. Dr. Anirudh Ghai.
Okay. The speaker, can I have the CV of the speaker on the?
Yeah.
Yes.
This is a CV.
Well, the speaker is Dr. Jai Kishore. He is senior consultant and NICU in charge at Max Super Specialty Hospital, Padganj. He has got more than 15 publications, and well, he is going to talk about what not to miss on the first examination of a neonate in your office practice. I'll now invite Dr. Jai Kishore to please start the.
Thank you, sir, for your kind introduction. So I think my slides are visible.
Yes.
So first of all, I would like to thank organizing committee for giving me this opportunity. What not to miss in the first clinical evaluation of a unit in office practice? It's difficult to cover it in 15 minutes, but still I will focus on areas where we miss. So my entire focus will be on that aspect. So this is how we examine newborn, the vitals followed by anthropometry. Then if we are dealing with a preterm baby, or where we have a doubt that whether the baby is a preterm baby or term baby, then we do gestational assessment, then general examination, which is an exhaustive examination from head to toe, and systemic examination. But as I told you that my focus will be only on those areas which we usually miss while examining. So vitals, we all know that these are the things which are monitored, but what we forget. And here I would like to say that one important screening test, that is pulse oximeter screening test, while assessing vitals, we have to undertake in all the babies who are being discharged. So if it has not been discharged, and if that baby is coming to in your office practice, then we need to undertake the pulse oximeter screening test. Why? Because we know that the congenital heart disease is the most common congenital malformation in newborns. And out of all the congenital heart disease, 1/3 of the congenital heart disease is critical congenital heart disease. And these diseases can be detected at an early stage, and studies have shown it that if you detect these things at an early stage, then the prognosis, the outcome of the treatment is going to be better. And it has got a sensitivity of 75% and a very good, a very high specificity. So this is how this test is done. For that, we need pulse oximeter, although a bit difficult to have it in office practice. But I think in a situation where baby hasn't undergone pulse oximeter screening test before discharge, we need to check it. And if we have got pulse oximeter, then we can see the saturation in the right hand and in the foot. And if we find that the saturation is below 89%, below 90%, then that baby requires urgent evaluation. And if the saturation is falling in the range of 90 to 94%, or if the difference in the right hand and in foot is more than 4 or more than 4%, then that baby requires reevaluation. But if the saturation is 90%, 95% or more, or the saturation difference is 3% or less, then that baby is a normal baby, and that baby doesn't require further evaluation. But if in the second scenario where the saturation is 90 to 94%, or the difference is 4% or more, that baby requires to be evaluated after 1 hour. If after 1 hour we have similar results, then we have to repeat it again. So we need to repeat that test 3 times, and even after 3rd time we have got similar results, then in that case that baby also requires evaluation. So this one more screening test. Then another group, anthropometry, and we all know that we do anthropometry regularly, so there's no need to focus much on that. Now come to the general examination. I'm just skipping that gestation age assessment, because mostly we come across in office practice term babies, or in some term babies wherever there is confusion, we can undertake that gestation age assessment. So in the general examination, the first thing that we do is appearance of the skin. Here, I just want to go into the scheme of how the examination should be undertaken. It's very important that in neonatal examination in office practice, the first thing that we do is a good observation. I think good observation is more productive instead of doing the clinical examination. So have a good clinical, have a good keen observation of a baby. Have a look on the baby. You can have an idea of the posture. You can have an idea of the tone. You can have an idea of the activity, the movement of the limbs. You can know about whether the baby is having breathing difficulty, or even you can have an idea of color. So these things can be we can know just by a keen observation. So as far as the appearance of the skin is concerned, different colors, jaundice, pallor, cyanosis, mottling, these things, these are the different colors. And besides that, there are transient skin conditions that we commonly come across, and we all are aware of it. We know that this is melia, doesn't require any treatment. This is a shaman patch, which usually abates on its own. Again, this is erythema toxicum, doesn't require any treatment. The Mongolian blue spot, we all know. This is transient neutral pustular melanosis. This condition further develops hyperpigmented patch, doesn't require any treatment. This is miliaria crystallina. If you keep the baby in warm environment, baby develops this sort of vesicular region, which is also a transient condition. This is a condition which appears later, and this condition appears after 2 weeks, and this is called neonatal acne or cephalic pustular melanosis. So this condition also doesn't require any treatment. But here, the caveat is that these are the different conditions, but in a condition like this, where there is erythematous rash, vesicular region, and affecting palms and soles, this could be a condition of, this is a condition of congenital candidiasis. Likewise here, this is a herpetic lesion, the vesicular lesion. So these are the things, besides normal things, we can also come across some abnormal findings of the skin. So skull examination, we all know. So these are the things that we require to see: size, microcephaly, macrocephaly, the shape. Because of craniosynostosis, there could be abnormal shape, swellings, we know, caput, cephal hematoma, subgallial hemorrhage. Don't forget to examine the sutures, look for sutural diastasis or look for craniosynostosis. Anterofontanal examination is important. And besides that, if we are suspecting subdural effusion, subdural lymphoma, or even hydranencephaly, then we do transillumination test. So it's important. Size of the head, if it is below 3 standard deviation, and we have got a very good WHO chart up to the 5 years of age where we have got 1 centile. If it is below 1 centile, then it is below 3 standard deviation, and that baby is having microcephaly, and that baby should be investigated, and we should look for primary or secondary causes. Likewise, if it is more than 2 standard deviation, which will correspond to the WHO growth chart of more than 95th centile. If it is more, 97th centile. If it is more than 97th centile, it means the head circumference is more than 2 standard deviation, and that baby also requires to be evaluated. Now, eye examination, I don't want to go into details of it. The only thing that we missed, my focus will be on that, red reflex. We usually forget to undertake red reflex test, and we should do it. It's a simple test. The only thing that we need to have is direct ophthalmoscope. And for that, this test can be done in a dark room. And we can stand 1.5 feet away from the child and look through direct ophthalmoscope. How does a normal red reflex look like? It will be red reflex from both the eyes, and it will be symmetrical in character. If you find dark spots in red reflex, markedly diminished reflex, or presence of white reflex, then that baby should be referred to ophthalmologist immediately, and the causes could be cataract, causes could be retinoblastoma, vitreous subnormality, or persistent hyperplastic primary vitreous. So we must do it. Just in this picture, you can see that in the right eye there is white reflex, while in the left eye there is a red glow. So this asymmetry is there, and this baby should be referred to it. Here a point I don't think that that appears to be relevant, but it is very relevant, because ROP screening, that is something where we land into medical legal hassle. And here, as far as the recommendation is concerned, it is for birth weight. It is for the babies whose weight is less than 1,000 grams. So even if you have got a baby who is a term baby, 37-week gestation, 38-week gestation, but if the weight is less than 2,000 grams, then that baby should undergo ROP evaluation, because as per the recommendation, if the baby's weight, irrespective of gestational age, if weight is less than 2,000 grams, that baby should undergo ROP screening. This is how we, in the face and neck examination, we have to do. Here, one important thing that I would like to add is hypoplasia of depressor anglioris. If you find that finding, then don't forget to look for congenital heart disease. Likewise, neck examination we have to do in detail, and the clavicle, while you are doing neck examination, don't forget to palpate clavicle, because it can be absent in cleidocranial dysostosis. Likewise, ear examination. Here, one thing that I would like to lay stress is don't forget to do universal hearing screening. And in high-risk cases, for example, if baby has got significant jaundice or meningitis, do BERA, because in that case we won't be able to pick up deafness if it is central, or if it is neural auditory dyssynchrony. Likewise, this nose and mouth should also be examined, and the chest, umbilicus and anal opening should also be examined. As far as umbilical examination is concerned, single umbilical artery is a finding that we can come across in about 0.2 to 0.6% cases, And in that case, there could be association with other malformations like genitourinary malformation, imperforate anus or tracheoesophageal fistula, or it could be sometimes a part of syndrome also. So we mustn't forget to look for other congenital malformation. And if you find anal opening, the location of anal opening is important. And if you find there is imperforate anus, then don't forget to look for other associations like vectoral, vertebral, anal, cardiac, tracheoesophageal fistula, renal, and limb anomaly. Now, one very important thing that we forget in our busy practice, that is genitalia examination. So just don't forget just to have a look over the genitalia and what are the situations when baby should be subjected or where we should suspect DSD and that baby should require DSD evaluation. So in a male baby, if there is bilateral cryptorchidism, if there is unilateral cryptorchidism with hypospadias, or even if testes are descended, even it is without microphallus, but if the hypospadias is a severe one, like penoscrotal, scrotal, and perineal hypospadias, in that case, that baby should be evaluated for DSD. Likewise, microphallus, if penis length is less than 2.5 centimeter in a term baby, that baby should also be investigated for that. Likewise, in females, if it is apparently female genitalia with glycoromegaly, with or without inguinal hernia or palpable gonad, if there is asymmetry in size, pigmentation, rugation of labioscrotal folds, if there is posterior level fusion, then these are the cases where that baby should be evaluated for DSD. Here, one important thing that we know that while examining back, we often treat it as back and we don't bother to say it. So give respect to the back. And if you find any stigmata, then decide about imaging. So what are the conditions where we need to do imaging? If there is lipoma, if there is acrocordon, if there is pseudotel, aplasia cutis, infantile hemangioma more than 2.5 centimeter or more than 2 cutaneous stigmata, these are high-risk babies. There could be underlying neural tube defect, and these babies should undergo MRI. If there is intermediate risk, for example, if there is atypical dimple more than 5 mm deep or 2.5 centimeter away from anal verge, or infantile hemangioma less than 2.5 centimeter, or hypertrichosis, the tuft of hair. In that case, this group belongs to intermediate risk, and these babies should undergo ultrasound imaging in the first 6 months if it is detected. Otherwise, if it's small dimple, less than 5 centimeter, within 2.5 centimeter from anal verge, hyper or hypopigmentation, or other conditions like melanocytic nevi, teratoma, port wine stain, there is no need to any imaging. So that's very important. These are the conditions you can identify. There is hemangioma, there is dermal sinus, there is pseudotel, lipoma, and there is tuft of hair. These babies should undergo evaluation with MRI. Likewise, we should examine extremities and birth injuries. We know that most of the birth injuries recover as palsy, weight. The babies usually start to show signs of improvement after 2 weeks, but wait for 3 months for undergoing other extensive investigations. The respiratory examination we should do in detail. We are all familiar with that. Cardiovascular system here, we will emphasize that we should see all the peripheral arteries, and the palpation of femoral artery is important. If it is weak, then we should have a suspicion of coarctation of aorta or interrupted aortic arch. Likewise, abdominal examination, we should do the palpation and see any other masses. Most of the masses which are palpable are usually renal in origin. And now another scenario, which murmur should be investigated? That is very important, because most of the time, in many cases, we come across an innocent murmur. Does it require further evaluation? Does it require echocardiography? So if it is a soft murmur, if there are no audible clicks, if the pulses are normal, if the vital signs are normal and the clinical examination is normal, there is no need to undertake further investigation. But if the murmur is hemodynamic, which murmur is hemodynamically significant? If it is pansystolic murmur, if it is loud, if it is of grade 3 or more than that, harsh quality, if it is heard in the upper left sternal edge, and if the second heart sound is abnormal, and femoral pulses are difficult to feel, or other abnormalities of vital instability are there, then that is the situation when we should evaluate further for doing that. CNS examination doesn't require in office practice. If a baby is taking feed properly, is having good posture with flexed upper limb and flexed lower limb, and is having good generalized movement, there's no need to undertake this arduous CNS examination. Now, at last, although Shakira's popular song go like hips don't lie, but hips and newborns, they speak lies. And initially, when you do the hip examination, they could be unstable, but later it could get stable after a month. So after a month, if you examine, then those hips get stable. So here, the point that I would like to emphasize is that if you do physical examination, if it is positive, refer to orthopedician, but if it is inconclusive, repeat the examination after 2 weeks. If it is inconclusive, then in that case, do ultrasound. What is the right time to do ultrasound to detect this developmental dysplasia of hip? The right time is after 1 month. So from 1 month to 5 months, ultrasound is a good test to do that. But when to do X-ray? Most of the time you come across a baby when on clinical examination, you have a suspicion and you jump to the X-ray. X-ray, as we all know, that femoral head hasn't got ossified. So right time to do X-ray is after 4 months. But if the examination is negative, then do we need to do imaging? So one situation in a brief presentation in a girl. Okay, so I've almost completed. This is how you do Ortolani maneuver and Barlow. One is to test dislocatability and another is for the disloc. This is how we can summarize the examination of newborn. Single picture. Thank you for your patient hearing. Thank you.
So any comment from our chairpersons?
Yeah, so Jai Kishore, thank you very much for comprehensively covering the newborn examination in office practice, because when you say office practice, this is a baby coming to you in your office, maybe at the time of first immunization, or maybe if the mother finds something abnormal, which is abnormal to her, but which may be a physiological variation. So very comprehensively covered in 15 minutes, which is a tough job. And I would just like to add that in all such situations, when you are handling the newborn, please be gentle with the baby. One thing. Second is hand hygiene must never be forgotten, even if it is an office practice. So that needs to be done. And he has beautifully covered that hip and spine, both which are generally not looked at. They should be looked at. And he's put nice tags on that to say hips don't lie and the back should not be ignored. So I think all in all, very well covered. Thank you, Jai Kishore. And I think we can move on to the next talk, which is by...
One question regarding CTEV detection at birth and when to refer to an orthopedician.
So I think we are anticipating questions to come in the chat box as the speakers speak, and the chairpersons can take them with the speakers if there are any questions in the chat box. Although you have said a question, and Jai Kishore, please go ahead and take up this question.
Hello. Yes, sir. Sorry, I couldn't get it.
CTEV.
TTV.
CTEV, sir. Telepus equinovirus.
CTEV. Telepus equinovirus. You know, as we know that telepus equinovirus, the management should begin immediately after birth. So it depends what degree it is. If it is of mild variant, then gentle manipulation can work. Otherwise, the cast application. And so here we don't have to delay the management of congenital telepus equinovirus. So it should start immediately on the very first day when it is detected.
Thank you, sir. I think now we move on to another topic. Please, Chairperson.
Yeah. So we will now have Dr. Ankur Jindal speak to us on something which is not the most familiar kind of a topic for us, which is speaking on the biologicals, and he will tell us about biologicals, case-based indication. A pediatrician, what should he know? So biologicals obviously are the ones which are, prepared from either humans or plants or microbes, and they are used for curing some diseases in humans or for preventing certain aspects or for treating some of the aspects. And this will be enlightened by Ankur for all of us. So we look forward to you, Ankur. Floor is yours.
Thank you, ma'am. So I'll start sharing my screen now. Can you see my screen, ma'am?
Yes, sir.
Okay,
yes, sir.
Fine. So I'll start my presentation. Ma'am, thank you very much for the introduction. And as you rightly said, this is not one of the common topics that is often talked about in any pediatric conference. And even in any pediatric curriculum, we don't often talk about biologicals unless you go to a specialty and start using these drugs. So that kind of makes my job tougher, but I'll try to simplify and make sure that whoever is listening to this talk will go away with the take-home message and will understand these drugs better. So I have nothing to disclose.
Ankur, you have a very naive audience, and we are all here to learn from you.
Thank you, ma'am. So that's what I said, ma'am. I'll try my best to make it very, very simple and make sure that everyone understand everything. So I'll begin with the case. So this is a classical case of systemic juvenile idiopathic arthritis. An 8-year-old boy presents with fever, evanescent rash, arthritis, has hepatomegaly, and investigations are showing anemia, neutrophilic leukocytosis, thrombocytosis, elevated ESR and CRP. He was, as usual, he was initiated on oral prednisolone, followed by methotrexate because he had arthritis. He showed brisk response to the treatment, and the prednisolone was gradually tapered. Soon after tapering the steroids, he started having flares of the disease, which is not very unusual. Approximately 30 to 40% of these patients tend to have flares once you reduce the steroids. So the prednisolone was increased, thalidomide was added, and he continued to have flares of disease whenever you decrease his steroids. And he started developing features of steroid toxicity, as you can see on this photograph. So we decided to give tocilizumab to this child, and he remains well after this. So this brings several questions to a mind of a pediatrician, whoever is listening to this talk. So some of these questions I have enlisted here, and I'm sure you will have many more questions which I'll be happy to answer after this talk. So what is the rationale for use of biologicals? Why do we want to use biologicals? What are these biologicals? What is the basic mechanism or what is the basics behind these biological drugs? What is the classification and availability of these biological drugs in India? So I'll talk a little bit about this. And my major focus would be how does one decide which biological drug to be used and when? And this will be mainly based on some case-based scenario. And because I'm a rheumatologist, so I'll talk mostly about use of biologics in pediatric rheumatology. However, it is very commonly being used in hematology, gastroenterology, neurology, for example, in autoimmune encephalitis, nephrology, for example, in nephrotic syndrome, people use rituximab. So there are indications beyond rheumatology also, but I'll be focusing main on pediatric rheumatology. And then we forget sometimes that most of the drugs that we use are not the original biological molecule; they are biosimilars. So I'll briefly describe what these biosimilar drugs are. So I'll cover the rationale for use of biologicals in this slide only. So now the current concept about management of many of these autoimmune diseases is to give a specific targeted therapy. So for example, if you use steroids, it affects almost every part of your immune system. It suppresses almost every part of your immune system. So that is not the kind of treatment that you want to give to your patients. You want to know which molecule is overactive. So whether it is interleukin 6, interleukin 1, TNF alpha in a particular disease, and that is the kind of molecule that you want to suppress by giving a specific immunomodulator in the form of biologicals. So these are coming up in a very big way in the management of several autoimmune diseases nowadays. So, so biologicals, basically they are all monoclonal antibodies except a few ones. So you can see they just look like a monoclonal antibody, just like an antibody, the Y shape with a constant region and a variable region, short arm, long arm, and they are produced by biological processes, as the name suggests. These are monospecific antibodies made by identical immune cells, and they are clones of a unique parent cell. So they have affinity for one particular antigen, and even on an antigen, a particular epitope. So you don't have to go into these very difficult terms. So you can just understand that a particular biological molecule will attack a particular molecule and even a very particular part of that particular molecule. So how complex these molecules are, you can understand these figures. So on the right hand, you see this is the molecule of aspirin. And on the left hand figure, you see this is the molecule of adalimumab, the 3D structure. And you can understand how complex it is to create this molecule, and even a slight test of the change in this molecule will lead to changes in the efficacy and changes in the profile of side effects and everything. So it's very, very difficult to synthesize these molecules, and they have very complex interaction in the human beings. So just a little bit about the historical aspect. So it started way back in 1890. However, the real story started in 1975 when these two gentlemen created a monoclonal antibody. And how is it to be done? So you take one cell that has the capacity to produce antibodies, a plasma cell, and you fuse it with a cell that has a capacity to proliferate. So that is how these molecules are produced. So one cell which has the capacity to produce antibodies, you club it with a cell that has a capacity to produce, to proliferate and multiply several times. So that is how you get a lot of antibodies of the same type. So that is the technique that they developed in 1975, and they got a Nobel Prize for this. And since then, several such molecules have been produced. So depending on how much of the component of antibody or monoclonal antibody is human and how much is mouse, so you name them accordingly. So mouse antibody are nowadays not available. However, if you have 67% human component, and it is known as chimeric. If you have 90 to 95% human component in the antibody, then it is known as humanized. However, if it is 100% human component, then it is human. And as you see in this figure, the higher the component of the human element, the lower is the immunogenicity. So that doesn't mean that the efficacy reduces, but that means that the side effect profile that you see with use of these antibodies decreases as you increase the component of the human in the antibody. So murine antibodies are nowadays not available. Chimeric will have more side effects as compared to humanized, as compared to fully human monoclonal antibodies. So so how do we name these antibodies? So I'll take few examples. So you can see this infliximab, adalimumab, and tocilizumab. So there is a prefix in this antibody. So inf here, ada here, and TOC here. So that doesn't mean anything. It is the preference of the manufacturer to give these names. However, after this, there is a substem A. So for example, Li here. So Li suggests that this is an immunomodulating molecule. So if you have heard of anakinra, there you see Ki, so it's an interleukin. So that is how the substem A is decided. Some substem B suggests the origin of these antibodies. So for example, most of these nowadays are human. So you see U in these. So for example, adalimumab, if it is humanized, then you see ZU. So just like in tocilizumab. And if it is chimeric, then you see XI. So that is how the substem B is decided. And the suffix is MAV for most of these antibodies. If it is receptor, then it is CEP. But as a general rule, if the most of the biologicals that we use are monoclonal antibodies, and their suffix will end with MAP. So as you see from adalimumab, so this is an immunomodulating molecule. It's completely human, and it's a monoclonal antibody. But from the name of this drug, you cannot make out whether it affects TNF alpha, or it affects IL-1, or it affects IL-6. That you have to remember. So these are the common biological drugs that are in use for various autoimmune diseases. There is no need to go into all of these, but the common ones that we use and that are available in India, I have highlighted them in red. So the anti-TNF alpha agents like infliximab, adalimumab, etanercept, interleukin 6, tocilizumab. This is in very common use these days because of this COVID, and many patients with COVID-induced hyperinflammatory state are getting tocilizumab. Rituximab is a commonly used biological, and it's easily available in India, and it's being used in several specialties. JAK inhibitor, tofacitinib, this is another biological molecule which is easily available in India nowadays. Anakinra inhibits interleukin 1, and that's not easily available in India. However, with some difficulty, it can be imported from other countries. So this is the classification of various biological drugs. So whether it inhibits cytokines, it inhibits B cells, inhibits co-stimulatory molecules, or it inhibits Janus kinase molecules. So that is how it is to be classified. However, I'll be talking about the ones that I have highlighted in red, which are available in India, and the ones that we are using in various autoimmune diseases. So just the case that we discussed in the beginning, this is the case of systemic GIA, and we treated this child with tocilizumab. So by now, I think you can understand what tocilizumab is. So it's a humanized, because you see here ZU. So it's a humanized with most approximately 67% component of human and remaining mouse. And So you can see it inhibits interleukin 6 as well. And major problem with the use of these biological drugs is the infection, and you have to be careful with that. And when you inhibit interleukin 6, so these patients are predisposed to develop staphylococcus infections. And one more important thing that you can remember is whenever you inhibit interleukin 6 for any particular disease, you will not be able to monitor CRP and ESR. So it inhibits the production of CRP, and CRP becomes negligible soon after initiation of tocilizumab. So that is how tocilizumab works. And there are several indications other than systemic juvenile idiopathic arthritis in some form of polyarticular GIA, in some uveitis, macrophage activation syndrome. And as I said, recently with COVID-19 associated hyperinflammatory syndrome, tocilizumab is a very commonly used drug. So for this condition, it is used as a single dose. However, in many of these disorders, it is to be given every 2 to 4 weeks infusion. I'll move on to the next case. So this is a 13-year-old boy, has a very long story. He was admitted with us in June 2020. He presented with fever for 2 weeks, vomiting, pain, abdomen, jaundice, and pruritus. He was admitted at a nearby healthcare facility, where he was found to have some abnormalities in the liver, some CNS abnormalities with grade 1 papilloedema, and he was also noted to have a rash and arthritis. So he was investigated, and you see he has anemia, thrombocytosis, neutrophilic leukocytosis, high ESR, and high CRP, and hypoalbuminemia. He underwent several investigations to find out an infection, but nothing was isolated, and his infection profile was negative. So on day 28 of illness, he started developing peeling of the skin, and this is what he had. He was having Kawasaki disease, and by the time it was recognized, he already had the disease had already done its damage, and you can see the giant coronary artery aneurysm. So you can see the right coronary artery has a giant coronary artery aneurysm, and this is also depicted in this CT angio film. This is another case, a 1-year-old boy, a relatively younger child with fever, rash, and irritability, red eyes, red lips, hepatomegaly. Investigation showing anemia, neutrophilic leukocytosis, thrombocytosis, high ESR and CRP. And you can see he has developed skin peeling in the periangle region, and the echo is showing coronary artery dilatation. So how do you treat these patients? We all know that the management of this disease is IVIG and aspirin. However, in first case, there was a marked delay in diagnosis, and we decided to treat aggressively this patient. So we gave infliximab, prednisolone, cyclosporin, and several drugs. Case 2 had a mild coronary artery aneurysm, and he was given IVIG and aspirin only. However, he continued to have fever, so IVIG resistance, possibility of IVIG resistance was considered, and he was then treated with 5 mg per kg of infliximab. Now you must be wondering why infliximab for Kawasaki disease. So it's based on some studies where it has been found that TNF alpha molecule, which this drug inhibits, is elevated in these patients in the blood as well as in the coronary arteries. And there are several studies that have found suggesting the use of infliximab for patients with coronary artery abnormalities as well as patients who fail to respond to intravenous immunoglobulin. So a little bit about this drug. It's you can understand this is the chimeric human murine. So XI, so it's a chimeric, and it has major 60 to 67% component is human and remaining is mouse. And it has a very high immunogenicity with a lot of side effects associated with this drug because of major component of mouse antigen in this. So whenever there are several indications for the use of infliximab. Kawasaki disease is one of the common indications. And when do we use infliximab in Kawasaki disease? Wherever you see IVIG resistance, so if the patient fails to respond to single dose of IVIG, infliximab is one of the commonly used drugs. And if the patient is having coronary artery abnormalities, especially the giant coronary artery aneurysms, that is one indication for giving infliximab to these patients. And in patients with Kawasaki disease, it is usually a single dose, and there is no need for TB screening. However, if you are using infliximab for a longer period of time in all of these indications like GIA associated uveitis, psoriasis, ankylosing spondylitis, or Crohn's disease, there you have to screen tuberculosis first, the latent or the active tuberculosis. If it is active tuberculosis, you have to treat first, and then you have to start infliximab. If it is latent tuberculosis, then you can start on isoniazid prophylaxis and then give infliximab. So let's move on to the another case. So this is a 6-year-old girl, comes from Ambala, and she presented with additive inflammatory arthritis of both large and small joints of upper and lower limb. So there are several deformities that she has developed. She is rheumatoid factor positive, and you can see deformities here, upper limb as well as in the lower limb. She was, as usual, she was initiated on methotrexate and prednisolone. However, there was minimal improvement noted in 6 months. So what do you do now? So if you see the joints in patient with inflammatory arthritis, you see there are several inflammatory mediators that are causing damage. So TNF alpha is the central molecule that causes damage in these patients. And based on these, TNF alpha, anti-TNF alpha agents have been tried in patients with several forms of JIA and have been found to be very, very useful. So you can remember there are 3 main molecules, anti-TNF alpha agents, adalimumab, etanercept, and infliximab, that are in common use. So this patient, based on the guidelines also, anti-TNF alpha therapy is a very good drug if patients fail to respond to methotrexate. The polyarticular forms of JIA responds very well to anti-TNF alpha therapy. This is another case, 6-year-old girl, resident of Panchula. She presented with monoarthritis of the left knee, and this responded very well to the treatment. She is ANA positive as well. However, when she was being followed up routinely and a routine screening for uveitis were done, she was found to have anterior uveitis in the bilateral eye. She was initiated on topical steroids and injection methotrexate. Partial improvement was noted at 6 months, and she was also noted to have steroid toxicity in the form of increased intraocular pressure. So she is having bilateral anterior uveitis and is responding partially to methotrexate, but is having a steroid toxicity. So what should we do now? So again, we look at some of the additional treatment for these patients, and biologicals have a great role to play in these conditions. So this is based on the fact that the fluids of these patients that have been examined have been found to have very high levels of TNF alpha, and that is how several trials have been carried out with the use of anti-TNF alpha agents in patients with uveitis. And this is one trial from UK where they found adalimumab in patients with uveitis associated with GIA. There is remarkable improvement. The another anti-TNF agent, which is etanercept, so that is something that should not be used in uveitis based on several studies that have found that it actually tends to flare uveitis if used for prolonged period. So amongst adalimumab and infliximab, which is the preference? So infliximab, as I said, it has a lot of mouse components, so it has a lot of immunogenicity and has several side effects. So adalimumab is now the preferred anti-TNF alpha agent for the treatment of uveitis as well as for the treatment of arthritis. So when you use infliximab, there are chances of failure, and if you use adalimumab after using infliximab, the efficacy is relatively less. And adalimumab is easy to administer; it can be used subcutaneous. However, infliximab is to be given IV. So adalimumab nowadays is preferred biological drug as anti-TNF alpha agent as compared to infliximab. So when does one consider using biologics in patient with uveitis? So intolerance to methotrexate, steroid dependence, and refractory or resistant to methotrexate or other dermals. So these are some of the indications for use of biologics in patient with uveitis. And you must always remember that methotrexate should always be given in combination with adalimumab or any anti-TNF alpha agent. You must have seen all patients who are using anti-TNF alpha agents are also receiving methotrexate. So this is to reduce the production of antibodies against these biological products. So methotrexate is to be used in all patients. So this increases the efficacy of anti-TNF alpha agents. So I'll briefly summarize 2 cases that shows that whenever you establish a definite diagnosis beyond arthritis in these patients, that becomes an indication to use adalimumab or any anti-TNF alpha agents or any other biologic therapy. So you should sometimes think beyond arthritis. So this is a girl who first presented to us at the age of 3. And she comes from Jharkhand, and she presented with just like any other polyarthritis. However, over a period of time, she developed bilateral uveitis at the age of around 14 years. And later on, she started developing hepatitis and was found to have granulomas in the kidney, liver, and spleen. So at that time, we thought that this is probably some form of granulomatous illness, and we'll be did the genetics, it was found to be Blau syndrome. This is an autoinflammatory syndrome. Her uveitis was refractory before that, and when we got this diagnosis, she was initiated straight away on anti-TNF alpha agents, and she is doing very well after that. So she is on adalimumab now. This is another case. This girl, 10-year-old, who came with very deforming arthritis of the upper limb, lower limbs, and you can see she has retrognathia, so TM joint involvement as well. And you can see, so this looks like any other case of polyarthritis, but look at her father as well. He also has polyarthritis involving upper limbs, and we also found that her brother had arthritis at a very young age. And this is the CT findings of the child and her father, and you can see the changes of interstitial lung disease. So this is another autoinflammatory disorder which is presenting like arthritis, and this is sting-associated vasculopathy of, with onset in infancy, also known as SAVI, and this becomes an indication for using JAK inhibitors, which is a biological product. So establishing these diagnoses early is important, because you know that the patients are not going to respond to other immunomodulators like steroids or any other drug, and you have to use a biological product. So this is my last case. This is an 11-year-old girl, definite case of juvenile dermatomyositis. She was treated with several drugs, IVIG, steroids, cyclophosphamide, methotrexate, mycophenolate, mofetil, very, very stormy course. She responded, however, 2 years later, she's presented with skin and muscle relapse, and she was reinitiated on corticosteroids. So what should you do now? You don't have any other option but to use biologics in these patients. And I'll talk briefly about rituximab that we use in these patients. So it inhibits CD20, and you can see how CD20 is expressed on B cell lineage, and you can see it is there except the stem cells and the plasma cell, it is everywhere. So whenever you use rituximab, it depletes all parts of the B cell except the stem cell and the plasma cells. And at times, B cells are reduced remarkably, and then and many of these patients develop low immunoglobulins as well. And sometimes it just fails to recover several years later also. So there are several indications of the use of rituximab: systemic lupus erythematosus, autoimmune encephalitis. Neurologists very often use this. JDM is an indication, ANCA vasculitis, systemic scleroderma, refractory autoimmune cytopenia. So hematologists quite often use this drug for refractory autoimmune cytopenias. And steroid-resistant nephrotic syndrome is a common indication nowadays. Nephrologists are using this drug very often. So I'll give a brief description about biosimilars. So by definition, they are similar biologics. So a biological product that is highly similar but not identical to the licensed originator biological medicine, and shows no clinically meaningful difference in terms of quality, safety, and efficacy. So you can understand from this photograph, so these two gentlemen look similar, but they are not the same. So they look to have same quality, they look to have same safety and same efficacy, but they are not the same. So the reason why biosimilars are produced, so for example, if I take the responsibility of developing one molecule, and if I take the patent, so 10 years later, the patent of that company would be gone, and any other company can produce a similar molecule that would be known as biosimilar. It leads to remarkable.
1 more minute, sir.
Yeah.
1 more.
Yeah, sure. It dramatically leads to a reduction in the cost. However, you must understand that most of the molecules that we are using nowadays in India are biosimilars, and the side effect profile of these drugs, the efficacy, we don't really know how these drugs are going to behave in future. So they are highly similar but interchangeable. So these are the biosimilars available in India. So other than tocilizumab, most of the biological drugs that we use, so etanercept, infliximab, adalimumab, rituximab, and tofacitinib, so biosimilars are available for all of these. So this is my concluding slide. I'll just briefly describe. So most biological drugs are complex monoclonal antibodies produced using recombinant technology. There are several indications in several specialties of pediatrics. One point you should remember is that there is a tendency and there is a desire to use these biological drugs because of its very good efficacy, but it should not be used upfront for the management of many of these diseases, but it should be used reserved for refractory and non-responsive disease. So there are several reasons for that. One is cost, and second is that it is very easy to initiate these drugs, but it's very, very difficult when do you actually discontinue these drugs, and there are chances that once you discontinue, the disease may come up again. And as I said, biosimilars are highly similar but not identical to the licensed originator of biological medicine, and they may behave differently. Thank you very much.
Thank you, Ankur. And it was a pleasure attending your PID workshop, which you did from PGI 3 months back, I think. And it
Yes.
was a pleasure listening and learning from that workshop. And today, actually, you taught us something about biologicals. As a pediatrician, since when I joined neonatology after 2010 or so, before that I was doing general practice, and I had few patients of GIA, which I was working upon systemic GIA, and GIA is one with deformities occurring very early in 2 to 3 years. And obviously the rheumatologist had started etanercept in that, and I was supposed to give it. So, and I was giving it for many years because it was so simple. For as a general pediatrician, I can tell everybody that it is easy to give these medicines because they are not very difficult to give. You have to just give them subcutaneously. So given two times in a week or 3 times in a week subcutaneous, the child was coming to me, and yes, the symptoms were lesser and lesser. But the last slide which you said was when to discontinue, because it was a costly affair for kind of a slum dweller kind of a person. He was a shopkeeper in a slum. So he could afford a 10,000 injection, 10,000 or 70,000 injection in a week or so, something like he was affording. But for how long? That was important. And though its symptoms did appear, improved, but when to stop this? And another child was just could not survive because they could not afford anything beyond methotrexate, which we were giving. So as a general pediatrician, I would ask that there is a market now, there is availability, and probably there are new and newer molecules, biologicals, which are available, and we shouldn't be scared by the difficult names they have, which deciphered by you now. So I think Ankur is there to help you all the time. I think with this, I think we can move on to the next one, Dr. Piyush. The questions will be in the end, Dr. Sushma.
Piyush, any
Madam,
comment?
questions we can answer in the chat box by our esteemed speaker. For the time part, any comments we can take, then we can move on to next session, please.
Yeah, Dr. Manish, you're absolutely right. They can be answered in the chat box, or at the end we have time, we can take them.
Thank you, ma'am. Thank you.
So next we move on to another topic, fever and seizure. Is this a syndrome? By Dr. Rekha Mittal. So chairpersons, please introduce Dr. Rekha Mittal. Dr. Piyush.
Yeah. Welcome everyone, and good evening. It's a little late, but I want to say before I introduce ma'am that it's an honor to chair a session which is being taken by my teacher. Whatever little neuro that I know was taught to her when I was a PG. So I am totally indebted to her, and it's a wonderful thing that today I'm chairing a session which she will be taking. She is now an additional director in pediatric neurology at Madhukar Rainbow Children's Hospital in New Delhi, and she is the president of Association of Child Neurology. And I can't say much about ma'am. It's an honor to have you around. So I won't take much time. Please. Live.
Can everybody see the slides?
Yes, ma'am.
So, good evening, everybody. I thank the organizers for inviting me to answer this very complex question. Seizures with fever, is it a syndrome? And I will try to make it as simple as is possible in the short time that is given to me. So I would go through the terminology, what are the causes of fever are, and basis a few case scenarios, syndromic and non-syndromic seizures with fever, and the syndromes associated with febrile seizures. I will not touch upon the investigations and management. So to start with definitions, we all know that the brain consists of many neuronal electrical discharges, But sometimes these can become abnormal, excessive, paroxysmal, and hypersynchronous, and they give rise to clinical manifestations which are called seizures. Now, these discharges may occur and produce different manifestations such as impairment or loss of consciousness, abnormal motor activity, behavioral abnormality, some sensory disturbances, anatomic dysfunction, and others. So, seizures can occur during the course of an acute or intermittent illness, such as metabolic events, CNS infections, drugs, hypoxia, head injury, and also febrile seizures. But sometimes these seizures can occur without an immediate precipitating cause, and then they are called unprovoked seizures. And if these seizures occur again and again, that is, they are recurrent, then it is called epilepsy. Now, this has been formally defined by the International League Against Epilepsy as a disease of the brain in which there are at least 2 unprovoked or reflex seizures occurring more than 24 hours apart. Or if there is a one unprovoked seizure, then on the basis of investigations, we find that the risk of recurrence of febrile seizures is at least 60%. That is the same as after 2 unprovoked seizures, and this recurrence could occur anytime over a period of 10 years, or at any point in time where you diagnose an epilepsy syndrome. Then we would call it an epilepsy. So, what is an epilepsy syndrome then? It is a syndrome where epilepsy is the predominant symptom, and it has a typical age of seizure onset, defined seizure types, and EEG characteristics. And on the basis of all of these three, the specific epilepsy syndrome is diagnosed. So, why is it so important to get a syndrome? This is because it provides information on the etiologies, and it also helps us to decide which anti-seizure medication would be the best. And lastly, it helps in prognostication. Out of these, the second point is most important, because if a wrong drug is given in the syndrome, there might be aggravation of the seizures in certain cases, and this can be avoided if the syndrome is picked up earlier. So the epilepsy syndromes are not actually random. This is a very recognized group, and these are organized according to age. And all attempts should be made to identify them. So if we see, as far as fever and seizures are concerned, the most important syndromes are the ones that occur in neonatal and early infancy, and these are called the myoclonic, the Dravet syndrome, and the febrile seizures plus, and the genetic epilepsy with febrile seizures plus. The others are a long list of syndromes that occur in childhood and adolescence. So fever with seizures is a very common neurological presentation in children, especially under the age of 5. And in this hospital-based study conducted in the infamous city of Wuhan, where they took children from 1 month to 14 years of age, 200 children were admitted with seizures, and of these 182 had seizures with fever, and even out of that 175 were febrile seizures. And this is another diagram representing the same thing. If we take it age-wise, it will be seen that in children who are 1 month to 1 year of age and 3 to 5 years of age, symptomatic seizures are more common, whereas in the 1 to 3 years age, it is the febrile seizures that are the commonest. So what are the causes of seizures with fever? So if there is an underlying cause of fever, it could be CNS infections, metabolic or electrolyte disturbance, systemic infections with hyperpyrexia, and these would all be non-syndromic. So I will not touch upon them anymore, because there is a well-defined and precipitating cause, and therefore once this cause has been taken care of, the seizures will not occur until and unless some brain damage has occurred. All the rest I put into 3 groups. The first group is the group in which there are febrile seizures plus, and genetic epilepsy with febrile seizures plus, and most often these have a genetic basis. The second group is the fever-provoked seizures, where there is a pre-existing neurological deficit, or pre-existing epilepsy or epilepsy syndrome, or the syndrome has not yet involved, and these could either have a genetic basis, or these could be symptomatic epilepsies such as following some neurological insults. And the third is the syndrome of febrile infection related epilepsy syndrome, which is also called FIRES, and it has got an autoimmune basis. So these are the groups in which are syndromic or associated with some syndromes. So now I will move on to illustrative case discussions. The first is the febrile seizures, FS, FS plus, and the GEFS plus group. Here the febrile seizures can occur independently, or they may be interrelated with the other two. So how do we define this, and what do these terms actually mean? So if a child has febrile seizures which are either simple or complex, and they remit by 5 years of age, and they never develop any other seizure type, then these will be called febrile seizures only. But if the febrile seizures, that is seizures with fever, continue beyond the age of 5 years, or they develop other seizure types, then they are called febrile seizures plus. And in febrile seizures plus, if there is a history of the GEFS plus spectrum of seizures in at least 2 family members, then we call it genetic epilepsy with febrile seizures plus, or GEFS plus for short. So what is this GEFS plus spectrum? So GEFS plus spectrum is the different types of seizures that are seen in families with seizures in multiple family members. The most common would be febrile seizures and the febrile seizures plus. And in between are these whole lot of different kinds of epilepsies that occur in different family members. And the most severe of these is the Dravet syndrome here, and epilepsy with myoclonic atonic seizures. And the family tree would look something like this. So every generation has different seizure types and different epilepsy types. Thus, febrile seizures by themselves are not described as a syndrome and in literature and common usage. Febrile seizures by themselves are not classified as any kind of a recognized epilepsy syndrome. However, they do form part of the spectrum of epilepsy syndromes, which are known as febrile seizures plus, genetic epilepsy with febrile seizures plus, and other epilepsies on the GEFS plus spectrum. So I will try to explain this concept on the basis of a tale of two sisters. And these are the two sisters who themselves did not have any family history of either seizures, febrile seizures, or any epilepsy. The elder sister gets married to a man who also does not have any family history of seizures or epilepsy. The younger sister marries a man who has a history of febrile seizures, and his younger brother and younger sister also have a history of febrile seizures in their childhood. So now let's see what happens to the next generation. So this is case 1. This is the girl who is now 9 years old. At the age of 9 months, she had fever with respiratory symptoms, and 3 hours after the fever, she had a generalized seizure, but she was awake and alert within 10 minutes. She was developmentally normal, and there was a history of seizures with fever in the father, the uncle, that is Chachaji, and the Buaji. So this child was admitted and observed for 24 hours, remained neurologically okay, and the discharge diagnosis was simple febrile seizures with an upper respiratory infection. Home seizure management was advised on follow-up. So what are febrile seizures? The definition has been given by the American Academy of Pediatrics and is very clear. These are febrile seizures which occur in the age, these are seizures occurring in children from the age of 6 months to 5 years in association with fever more than 38 degrees, and they should not have any evidence of any intracranial cause such as infection, trauma, or epilepsy, or any other cause of fever such as electrolyte imbalance, hypoglycemia, or drug withdrawal, and no history of an afebrile seizure should be there in the past. The earlier age limit was 3 months in 1980, and 1993 it was 1 month. This is going to be revised, but ILAE still considers it as 1 month. But most of us, for practical purposes, take it as 6 months. So now going back to the case, this girl had seizures at 1.5 and 3 years with fever and no seizures after that. She remained developmentally normal. So the final diagnosis is recurrent simple febrile seizures. Now we move on to the case 2, which is her cousin. This is the daughter of the younger brother of this sister's husband. So this girl is now 14 years old. At the age of 1.5 years, she had simple febrile seizures, so no treatment was given. At 2 years and 3 years, she had multiple seizures with fever, which were more prolonged, but she recovered neurologically at all times. She remained developmentally normal. The MRI, brain and EEG were both normal. So she was diagnosed as complex febrile seizures and advised intermittent benzodiazepine prophylaxis, and home seizure management was advised. So what is the difference between simple and complex febrile seizures? The simple febrile seizures are brief, less than 15 minutes, have no focal features, and only one attack in one febrile episode or within 24 hours. Complex febrile seizures are less frequent, seen in only 30% of the cases, and the duration is more prolonged, more than 15 minutes. Focal features may be present either at onset, throughout, or at the end, as indicated by Todd's paralysis, or more than one attack can occur during one febrile episode. But remember that the seizure duration may be difficult to identify if treatment is given in the form of nasal midazolam after 5 minutes, or the parent's perception of the duration may be inaccurate in times of stress. So to continue with the case, this child continued to have seizures with fever till 12 years of age. After 12 years, no further seizures occurred. There were also no afebrile seizures. She remained developmentally normal, and therefore the diagnosis is that she has the epilepsy syndrome of febrile seizures plus. However, now she also has a family history of febrile seizures. The father, the uncle, the aunt, and one cousin have febrile seizures, and therefore, in view of the family history, she would be taken as genetic epilepsy with febrile seizures plus, also known as GEFS plus. So let's take the case of the other sister. She had a son, and who is now 7 years old. Now, this child started having febrile seizures at 1 year. They were recurrent. Some were simple, some were complex. The birth history was uneventful. But this child has a family history of febrile seizures in just one cousin, and she is developmentally normal. Few behavioral problems are there. The MRI and EEG are normal. So at 3 years, she started having generalized tonic-clonic seizures without fever. The MRI was normal. EEG showed intermittent generalized spike wave discharges. But since these are afebrile seizures, she is now said to have developed epilepsy. She was given valproate for 2 years, and she has been seizure-free now till the age of 7 years. So her diagnosis becomes generalized epilepsy, and the epilepsy syndrome would be febrile seizures plus. But since she has no significant family history, we do not call it GEFS plus. So significant family history means that at least 2 family members have to be affected. 2 blood relations have to be affected. And she has only 1 blood relation here, this cousin, who has febrile seizures. So we just leave it at febrile seizures plus. So to reiterate, febrile seizures plus are febrile seizures that may continue past the usual age where the seizures are expected to resolve, and or are accompanied by afebrile seizures that may be generalized or focal. And GEFS plus is nothing but a familial epilepsy syndrome in which the child has febrile seizures plus a history of family members with epilepsy phenotype of GEFS plus spectrum in at least 2 family members. So just a brief overview. These are syndromes characterized by prominent febrile seizures, with seizures starting between the age of 6 months and 6 years. The seizures are often multiple and evolve to febrile seizures plus. It's equal in both sexes. The birth history is unremarkable. Development, examination are normal. They may show generalized spike wave discharges on EG. MRI is normal, and the prognosis is good because there is these resolve spontaneously usually by puberty. Then let's take the fourth case. This is the child of the younger sister of this man. At the age of 6 months, he started having recurrent febrile seizures. Though the family was not really concerned because febrile seizures are very common in multiple family members. At 6 months, because they were complex febrile seizures, the EEG and MRI were done, but they were both normal. Developmentally, at this time, this child was normal. But since the child was having frequent complex febrile seizures, he was started on valproate. But suddenly, at the age of 11 months, this child had afebrile seizures and status epilepticus. Now, this started concerning the family, and by the time the child was 1.5 years old, he started having myoclonic jerks. He started falling behind in his milestones, and the EEG also started showing polyspike and wave discharges. Levetiracetam was added, clobazam was added, ketogenic diet was added, but the seizures did not respond. And now this child is being diagnosed as Dravet syndrome, which is confirmed genetically as having an SCN1A mutation. And this is one of the most severe epilepsy syndromes on the GEFS plus spectrum. Final diagnosis was made as the disease involved, and the initial presentation was with febrile seizures only. So the Dravet syndrome is one of the most severe epilepsy syndromes associated with febrile seizures. It's a rare condition. Both sexes are affected. Etiology is nothing significant in the birth and the neonatal history. But the genetics is very characteristic. Two main types of mutation have been identified. The SCN1A and the PCDH19 genes have been found to be involved. 90% of the cases are de novo, but 5% are inherited. And the family history may have unaffected carrier, they may have febrile seizures or GEFS plus. The seizures start around 6 months of age, but in some they might be later. The first seizure is a febrile seizures, but not all patients start with febrile seizures, and immunization may trigger the first seizure in some cases. And therefore, whenever you give a vaccination, it's important to see to make sure that the child is followed up for occurrence of febrile seizures and evolution to Dravet syndrome. The sensitivity of the seizures to fever may persist throughout life. The seizures are usually, when they start, they are hemiclonic and sometimes generalized tonic-clonic seizures, but later other types of seizures may appear. They eventually develop, initially their cognition is normal, but they eventually plateau out and have regression. Examination is normal initially, but over time, ataxia and pyramidal signs may develop. The EEG, as everything else, is normal in the first year, but subsequently becomes abnormal. Imaging also is normal initially, but later on there is generalized atrophy and hippocampal sclerosis. So thus this is a syndrome which evolves from febrile seizures to become full-fledged severe epilepsy syndrome, in which there is the epilepsy itself causes compromise in the development. So what is the pathophysiology and genetics of febrile seizures? It remains largely unknown, as basically a combination of factors, which could be risk factors and triggering factors. The risk factors are younger age, because there is a higher susceptibility of seizures in a younger age, and there is a genetic susceptibility. And recently, iron deficiency, anemia, and some electrolyte and metabolic abnormalities have also been implicated, but not definitely associated or causative. The triggering factors could be fever, which causes hyperventilation, and alkalosis, which can precipitate seizures. And infection also releases certain cytokines, such as interleukin 1b, and especially interleukin 1-6 has been implicated in precipitating seizures in genetically predisposed persons. So in just febrile seizures, it is genetically very complex, and there is no single mode of inheritance, but it may be autosomal dominant or polygenic with multifactorial transmission. 10 febrile seizures loci have been identified. Many of them, the number is actually increasing, and some of these patients actually have a higher predisposition to the interleukin 6 gene. So causative gene has not been identified in most cases with febrile seizures. But in the febrile seizures plus and the GEFS plus, the many genes have been identified, specifically the SCN1A, SCN2A, and SCN1B, and the GABAG and GABAD and PCDH19. So then we come to the second group, in which the seizures can be provoked in either a child with a pre-existing neurological deficit or epilepsy, or the syndrome has not yet evolved. These could be genetic or symptomatic epilepsies. A 15-month-old baby who's a follow-up of prematurity and HIE has a global developmental delay with generalized spasticity and recurrent right-sided seizures, sometimes generalized tonic-clonic seizures with fever. There are no afebrile seizures. The MRI shows periventricular and EEG with multifocal and generalized spike wave discharges. So these would be fever-provoked seizures in a pre-existing neurological deficit. We know that the neurons in these cases are damaged and therefore predisposed to seizures. The second case would be a 7-month baby with brief generalized seizures with fever and becomes normal in 4 to 5 minutes. There is a history of 2 seizures without fever at 5 months, 2 weeks apart in this child, and this child was already on phenobarbital. The birth history and development was normal. This child had a family history of an older sibling and father with seizures in the first year, and they had both been treated with anti-epileptic drugs for 1 year. Developmentally normal, clinically normal, EEG normal, MRI normal. So this child has an epilepsy syndrome which is well defined. This is benign familial infantile epilepsy, and this is an autosomal dominant syndrome. And this child, when he had fever, he had seizures, and these would be called fever-provoked seizures in a pre-existing known epilepsy syndrome. The third child is a 2-year girl child with brief generalized seizures with fever, normal within 10 to 15 minutes, no past history of seizures. Everything else was normal, no family history, no nothing. Initially, then the diagnosis was simple febrile seizures. But as she was followed up, she developed seizures during sleep with a throaty sound, tightness of right side of the body, drooling for 3 to 4 minutes. MRI was normal, but the EEG showed bilateral centrotemporal spikes. So this child had benign self-limited epilepsy with centrotemporal spikes, and this is an epilepsy syndrome that evolved later. So we should know that the risk of epilepsy following febrile seizures is 2 to 5%, which is double that of the general population. And approximately 15 to 20% of the children who have epilepsy have previously had febrile seizures. And the risk for developing epilepsy in a case of febrile seizures is if the febrile seizures are complex, there is a family history of epilepsy, or developmental neurological abnormalities before the first syndrome. I will skip the syndrome. Basically, this febrile infection-related epilepsy syndrome is an autoimmune entity. It's very rare and very refractory to treatment. So I will summarize now with the salient point. Seizures with fever are the commonest neurological presentation in children. They may be symptoms of an acute neurological illness and would not be called a syndrome. Seizures with fever without an underlying cause may be febrile seizures, either simple or complex, and not an epilepsy syndrome by themselves. Febrile seizures, but if associated with febrile seizures, GEFS plus and GEFS plus spectrum, they may be called an epilepsy syndrome. Seizures can be provoked by fever in a pre-existing neurological deficit. They may be provoked by fever in a known epileptic syndrome, may evolve into an epilepsy syndrome later, or be fires. Most syndromes are not diagnosed at the onset of the febrile seizures, but it becomes evident on follow-up. Thank you for a patient listening. That is if you are not on WhatsApp.
Thank you, ma'am. Thank you, ma'am, for an excellent presentation. I think we are already...
It was a wonderful presentation, as lucid as your teaching in the college work. There's only one thing that I would like to add in this. What I could gather, the take-home message is it's very important to take a detailed past and family history in any child who's coming to our OPD with the history of fever with seizures. Right, ma'am?
Yeah, absolutely. The family history is very important, and it's also important to make sure in every child who comes in the first year of life that there was no associated fever, because very often the seizures occur and the fever comes later. And when you take the history and you say, did the child have fever, the parents will say no, there was no fever at the time, but they may be having some minor respiratory problems, and the fever may be detected only later on, maybe say 1 or 2 hours later even. That may also happen because the core temperature, we don't usually ask for the core temperature. The mother often just places the hand on the forehead and says ki, no, 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 there was no fever. So it's important to take a history of these two things, would be really very important.
And one small again, ma'am, how often do we see fires? I know you did not touch on that in our setup.
Yeah, we have seen. It's not very common, but if you see it, it is hell. Because these seizures just don't respond. You go on trying everything. They have super refractory status. You try steroids, IVIG, ketamine, ketogenic diet, everything you can try, but they just don't respond, and the prognosis is really very bad. So if you see it, it's really hellfires.
Okay. Thank you, ma'am. It was a 100% back to Dr. Rajiv. I think.
Thank you, sir. Thank you, ma'am. And thank you, thank you, chairpersons, for excellent presentation. Now we move on to the last session of the day. This is on for.
Thank you. Thank you. Thank you, Rajiv.
Thank you very
everyone.
much. It was
Thank
wonderful.
you, everyone.
Thanks,
And
ma'am.
thank you, Dr. Rekha. A wonderful
Wonderful.
presentation. Dr. Sushma, Dr. Piyush, Dr. Vish, Dr. Anirudh गई कहाँ गए हो गया सर ने कुछ बोला नहीं. So it was Dr. Jaikishore. Very well done session.
Any question and answer we can take in the chat box only.
Sure.
Because as we are already running 45 minutes late. So now we move on to the last session of the day. That is really interesting. Issues in interpretation of culture reports by Dr. Tanu Singhal. And the chairperson for this session are Dr. Pankaj Garg. Dr. Pankaj Garg is a Senior Consultant, Department of Neonatology, Sir Gangaram Hospital, New Delhi. Dr. Tapisha, she's a very senior consultant at Max Patpagan Hospital, and a very and the third chairperson is Dr. Rekha. She is a senior consultant and in charge pediatric critical care at BLK Super Special Hospital, New Delhi. Over to you, chairpersons.
Dr. Rachna Sharma.
Rachna Sharma, sorry.
Rachna Sharma.
Yeah, Rachna Sharma. So over to you, Dr. Chairperson, Dr. Pankaj. Please introduce the speaker for the day.
Yeah, thank you, Dr. Rajiv, for this session. Though last, but it is one of the very important sessions because as an intensivist, we always say you need to believe the cultures which you send, and who better than Dr. Tanu Singhal to dwell on this point. Dr. Tanu is a very senior consultant intensivist at Kokilaben Hospital, Mumbai, and in this COVID times, I'm sure all of us have listened to her talks on COVID, but today is a different day. So we are going to listen to her on the topic of blood culture. So it's over to you, Dr. Singhal.
Thank you. Thank you. And I would like to thank Dr. Shyam Kukreja for inviting me to make this presentation. And I hope I will try and wind up early because, we are already, so I'll try and finish in time. But I thought that going through it systematically is important to make people understand the nuances of, culture and sensitivity testing. So we all know that culture and sensitivity. Can you see me and hear me?
Yes, we can.
Fine, ma'am.
Yeah.
Please go ahead.
Yeah. Yeah, my video is not on, sorry.
Now we can see you.
Yeah. So we know that culture and sensitivity is the gold standard for microbiologic diagnosis, and importantly, it gives us the susceptibility info. And therefore, it is important to know about conventional culture methods, about new methods and techniques, and also know about when to send cultures, when not to send cultures, how to interpret in light of the patient's condition. And in today's presentation, we will mainly discuss analysis of smear because the AFB or the gram stain has important bearing in diagnosis, and it is part of the culture report. We will analyze bacterial cultures in today's presentation, not fungal and mycobacterial cultures. And we will spend quite a bit of time on antibiotic susceptibility analysis because that is particularly important for intensivists, I think, which, and you know, there are many in this audience. So before I go to the culture and sensitivity, I just want to tell you what is the usual workflow in the microbiology lab. So what happens is that when blood cultures are sent, we have to send at least one set, and we have to inoculate it into both the aerobic and anaerobic bottle. And people will ask why anaerobic cultures, because we're not routinely suspecting anaerobic organisms, but it is because some of the streptococci and some of the gram-negative bacteria grow better in anaerobic medium because they are actually facultative anaerobes. That is why you should send both. And we should send about 1% of the circulating blood volume, which would approximately be maybe 10 ml in a 5 to 6 ml in a 10 kg child. And this is inoculated into blood culture bottles. Now, when you have pus, CSF, or other body fluids like pleural fluid, peritoneal fluid, etc., you can inoculate it directly into the blood culture bottles, and that is important because that increases the sensitivity of these infections in these areas. And at the same time, you will also subject it to various kind of smear testing like gram stain, AFB stain, KOH mount for fungi, wet mount in case it's a urine specimen or a fluid specimen, and India ink if it is the CSF where you want to pick up cryptococcus. And apart from that, you will also inoculate these into the solid media. And when you have swabs, urine, sputum, then you will directly inoculate it into solid media. You will not be injecting them into the blood culture bottles. And you can also subject the sputum to all these stains. Of course, swabs you can't subject to the stain, and that is why swab is not a good method or a good specimen for microbiologic diagnosis because you can't do a gram stain and you can't inoculate it into a culture bottle, and the amount of material which you have is very little. Now, what happens is nowadays all these blood culture systems are automated systems in which the bottle goes into a machine, and the machine is constantly detecting the growth in the bottles. And whenever there is some growth which happens in the bottle, it flags positive. So what the lab technician will do is, where there is a 24-hour technician available, they will take a little bit of the sample from the bottle and make a smear. And that is how, they will tell you that your patient is growing GNB or your patient is growing GPC. And now what they do is that they inoculate this material into the solid media because you need to re-inoculate it into solid media to come to know what pathogen and what is its susceptibility. Then the colonies appear in 24 hours, and then you will pick up these colonies. And earlier, like, used to identify organisms by doing various kinds of biochemical tests, and you would do susceptibility testing by this diffusion. Nowadays, all these things go into Vitek systems. These are automated systems where you just put the colony inside, and soon you'll know what the ID is and what is the susceptibility. And also, you must remember that if you have the facilities from the bottle itself, you can run certain molecular panels, like you have the BCID panel from bioMérieux, which will give you a quick identification of what bacteria or fungus it is. And similarly, you can also do these molecular panels from colonies, and you can also take up material from the colonies and do a quick identification through MALDI-TOF, because that takes only about an hour. Whereas if you actually do it through the Vitek, it takes longer time. But you must understand that through MALDI-TOF, you know the identification of the organism, but you don't know the susceptibility of the organism. So this is just to tell you how things flow in the microbiology lab. And though you say that the culture reports come to you after 48 hours, if you are having good dialogue with your microbiology colleague, then every few hours you can get an update about your sample to know what is it growing and what is the progress. Now, the first thing which you need to look at when you see a culture report or when you have sent a specimen is the gram stain. And it is something which can give a diagnosis in 20 minutes if it is representative. So first thing which you need to do is look at the number of pus cells and epithelial cells. So suppose, there's a specimen, a sputum you have sent, and they say that pus cells are less than 10 per hypa field and epithelial cells are 25. You know that this is a salivary specimen and this is not a proper lower respiratory tract specimen, and you will not believe the report. Look if there are organisms present on the gram stain. So many times it will say pus cells seen and gram-negative bacilli seen. So the moment you start seeing organisms on the gram stain, it tells you that the bacterial load is high. That means more than 10,000 per mil. And the likelihood of what is grown is a pathogen and not a colonizer. So because only when an organism is present in large quantities, you get a gram stain positive. So the presence of organisms tells you what bacteria it is, at least initially, and it will also help you distinguish between a colonizer and a pathogen. And which kind of gram stain reports are useful in clinical practice? For example, gram stain of CSF and other fluids. If you see gram positive diplococci, you could be dealing with pneumococcus. Expectorated sputum in a child, not an antimicrobial therapy, where it will tell you what is the cause of community-acquired pneumonia. This is more possible in children who have bronchiectasis or older children. Gram stain of freshly centrifuged urine for bacteria, and studies indicate that a positive gram stain has very high sensitivity and specificity for diagnosis of a UTI, and gram stain of pus or biopsy samples. And you can start empiric therapy on the basis of the gram stain also, because the final report will come after 24 to 48 hours. Now, let me just discuss a few cases with you. So this is a female who had osteopetrosis, and she underwent dental extraction, and she had multiple sinuses which were discharging pus. And these pus was foul smelling, it was non-healing, she had received multiple antibiotics. And if you look at the gram stain here, you see these gram-positive bacilli, which you can see because these are gram-positive because they are purple in color and they are bacilli. So actually this was a case of cervicofacial actinomycosis, and the diagnosis was made on the gram stain because we tried to culture the specimen in anaerobic media, but we couldn't because this is a fastidious organism, doesn't grow well on culture. And because of the gram stain, we were able to, make a diagnosis and treat the patient with antibiotics, which she needed obviously for a period of 12 months. So here, the gram stain gave us a diagnosis, whereas the culture could not. Now, the other thing is about the AFB stain. Now remember, it is a protocol in many labs or most of the labs to stain all pus body fluids for acid-fast bacilli, even when TB is not suspected. So in our lab, for example, and in many other labs like Hinduja, even though you will ask for a gram stain, the lab will do an acid-fast stain free of cost, because they have realized that in many instances in India, you actually have TB as a possible cause. And it is very rewarding. And when you see acid-fast bacilli, remember that they are not always MTB. They can be Mycobacterium bovis, they can be non-tuberculous mycobacteria, or they can even be nocardia. Now, let us look at this patient. This was a child who undergoes a laparoscopic appendicectomy. 3 weeks later, the patient has pus discharge from the port site, and the pus gram stain is negative, but because there was a protocol in the lab to look for AFB smear, Zeal-Nelson's was done, and the AFB smear was positive. And the patient was actually started on anti-TB treatment. Now, which kind of tuberculosis is going to present with pus discharge from an abdominal surgery site? That is because everybody thinks that if you find acid-fast bacilli, it is MTB. But this could actually be a case of non-tuberculous mycobacterial infection, because that you can get these infections following use of laparoscopes because of inadequate sterilization. And the one way to differentiate is to ask the lab what are the acid fast bacilli looking like. So if they are short and stocky, it is NTM. If they are long and beaded, it is Mycobacterium tuberculosis. Now in this patient, the expert was negative, and the MTB cultures, they showed non-tuberculous mycobacteria, and it was identified finally by line probe assay as M. kiloni and treated appropriately, and the child got well. So just think of whether if this patient would not have undergone an AFB smear of the pus, we would have missed the diagnosis. And that is why it is very important that you have to keep your mind open, and labs should do AFB smear also on all pus samples. Now, so that was, I discussed two cases where we could make the diagnosis by gram stain and AFB stain. Now, once once the report tells you about the organism, you have to remember that a positive culture is, though it's a gold standard, these organisms which you grow on culture can actually be true pathogens. They may be contaminants or they may be colonizers. And it is important that these are interchangeable. So what is true pathogen in one setting can become colonizer in another. And we will discuss these things as we go along with some cases. Now, in blood cultures, what are the organisms which you grow in the blood culture are usually true pathogens. So all gram-negative bacteria, suppose you grow E. coli, you grow Klebsiella, you grow Acinetobacter, or you grow pneumococcus, you grow Hib, or you grow Staph aureus, these are true pathogens. And another important property of a true pathogen is that it will fit with the clinical condition. Can I please request the other people to mute themselves?
Dr. Gaba, please mute yourself.
Rohit,
Dr. Gaba,
Rohit, please mute everyone except ma'am. Rohit, please do that.
Okay, so that is an important property. So you grow what you have been expecting to grow. Whereas contaminants are those organisms like coagulase, negative staph, diphtheroids. They grow after 48 hours, and a single bottle is positive. And that is why, it's always important to send a set of blood cultures, because if you grow it in one bottle and you don't grow it in another, it could be a contaminant. And also what you grow does not fit in the clinical spectrum. And then finally, you can have colonizers. For example, in blood cultures, colonizers can come if you have taken a sample from the central line, because many times the central line will be colonized with pathogens, but they will not be the actual culprits for the patient's clinical condition. So let us discuss one case. So this is a 10-year-old who comes with high fever of 10 days duration with abdominal pain and some diarrhea. And it is looking like enteric because the white cell count is low. The polys are predominant, platelets are a little low, CRP is high, malaria is negative, blood culture is sent, and this patient is admitted and IV ceftriaxone is started. And 48 hours later, the blood culture grows Burkholderia cepacia. So again, this is not what you were expecting, because Burkholderia cepacia is a widely distributed organism which mainly causes nosocomial infections. People who have been in the ICU for a long time on multiple antibiotics, it causes Burkholderia cepacia is the cause. But and also sometimes it is reported as Pseudomonas species. So, when you have a report from the lab in the blood culture saying that it is Pseudomonas species and it is not Pseudomonas aeruginosa, you have to be careful, because what that Pseudomonas species may be is actually it's a contaminant. And in this case, the setting is of enteric fever, Burkholderia does not fit in. So probably this has come because of some contamination during collection of the specimen or in the lab. And these organisms, they don't have great nutrition requirements, so they grow in all these betadine and other bottles. So if you use a contaminated bottle to clean the skin before collecting the blood culture, you will grow these pathogens. So in this situation, you are reasonably confident that you're dealing with enteric. You can dismiss the report, and you wouldn't repeat the sample, but at the same time you'll try and find out why this happened. Is there some problem in the way the cultures are being collected in your hospital or in the lab, and you will try and take care of those things so that such kind of contamination does not happen. And this is also the case if a lot of cultures you are sending are growing cons, coagulase negative staphylococcus. You know that there is some problem in the way the specimens are being collected and you have to tighten it up. Now, what if the blood grew Burkholderia pseudobacteria? So this is a different pathogen. You may think Burkholderia, but Burkholderia pseudomallei is basically causes melioidosis, which is a disease associated with multiple abscesses. And it is not common in children. How it's quite common in diabetic adults and alcoholic adults. But remember that when you have when you get a report which shows a rare organism which you haven't heard, you should not dismiss it. But you should always get in touch with your microbiology colleague, and you should also do a Google search to try and find out what this pathogen is and what could be the significance in this particular patient. Now, another point which I wanted to talk about is that contaminants and true pathogens are interchangeable, something which I talked about earlier also. So, for example, a child with fever for 3 to 4 days has a single peripheral line blood culture glowing corns. You know it's a contaminant. A child who has aseptic meningitis, you do a CSF and the lab after 48 hours tells you it's growing corns. You know it has come, it is a contaminant. But what if you have a very low birth weight baby in the NICU with sepsis, and in whom you send 2 sets of cultures and 2 out of 4 cultures grow corns? Then you can't dismiss it, because we know that corns or coagulase negative staph or staph epidermidis can be a pathogen in low birth weight babies in the NICU. Similarly, if there is a child who has a prosthetic heart valve and has endocarditis, if he grows corns in 2 sets of cultures, you know that here this is not a contaminant, but it's a true pathogen. Similarly, if you have a child with a VP shunt and you do a shunt tap and it shows a shunt infection and it grows corns, you know that this is not a contaminant, but it's a true pathogen. So that is why you can't label any pathogen, any bacteria as a contaminant. It is basically the setting in which you find that bacteria which tells you whether it's a contaminant or a true pathogen. So corns, which is normally dismissed as a contaminant, can also be a true pathogen. Now, let us look at other specimens like urine cultures. So you have a 2-year-old with high fever. The CBC shows a white cell count of 20,000. The CRP is high, so obviously you're thinking of a bacterial infection. The urine routine has been collected by a bag specimen, which is okay to collect a urine routine which shows 40 pus cells per hypafil. So you know you're dealing with a UTI. You admit the child and you start the child on IV ceftriaxone. But because you couldn't collect a clean cat specimen before starting antibiotics and you were in a hurry to start antibiotics, you actually send the urine after 24 hours. And the urine grows Enterococcus fecalis. Now the child is better, but this Enterococcus is resistant to ceftriaxone. So, I mean, is the Enterococcus fecalis causing this patient's UTI? Unlikely, because it's not a common cause of UTI in normal children. So probably what has happened is that you must always collect cultures before starting antibiotics. And if you have a urgency to start antibiotics in a toxic child, you can easily collect this culture by putting in a catheter sample. Now, what has happened here is that the Enterococcus has been selected out as it is inherently resistant to ceftriaxone. So, the E. coli has gone away, and therefore this is not a culprit. So remember that whenever you collect a whenever you have a culture report on a patient who has been already on antibiotics, you could be growing colonizers and not the true pathogen. Now, let us come to a little different case, which was actually very surprising. This is a case of a meningitis. So this was a 9-month-old baby who was previously healthy, had fever, irritability, and vomiting for 3 to 4 days. The patient was admitted, had a bulging fontanelle, and the count was normal, but the CSF was done because obviously meningitis was suspected, and the CSF had 11,000 cells with 90% neutrophils, high protein, and low sugar. So obviously, you know that you're dealing with bacterial meningitis, and this case came in 3-4 years ago, where the empiric therapy for bacterial meningitis was ceftriaxone. So the patient was started on IV ceftriaxone, the fever goes down, and 48 hours later, the lab tells you that the CSF is growing this organism, Stenotrophomonas maltophilia, and this is not susceptible to ceftriaxone. Now, Stenotrophomonas maltophilia is also like a organism like Burkholderia cepacia, which usually comes in hospital-acquired infections, and this is not a cause of community-acquired infections. So, it is okay to dismiss this as a contaminant. But ceftriaxone was continued, but the patient did not improve. The patient's fever persisted. You do a repeat CSF, the CSF is much better. From 11,000, your cells have gone down to 500. And it has become from predominant polys to predominant lymphos. This protein has gone down. The sugar has improved. So you feel that this patient has got partially better, but clinically the fever is still persisting. So you again send the culture, this time again to a reference lab. And again, it grows Stenotrophomonas multifilia with same sensitivity. So then in this case, the treatment is changed appropriately and the patient improves. So what are the learning points in this, from this case? The learning point is that sometimes you will, very, very rarely though, because you will encounter pathogens which initially seem like contaminants. You don't believe them because they are not known to cause the problem which your patient has come to you with. But if your patient does not improve with standard therapy, then the test should be repeated. And if you isolate the same organism again from a reference lab, then you know that this is a true pathogen and you have to treat it as such. And this case which you are seeing is a medical oddity and maybe the case needs to be reported. So very, very rarely you will find this happening, that what you think of is a contaminant actually is the true pathogen. We had one such case, 1-year-old who came with prolonged fever and meningitis, and we thought it was TBM, and we did a CSF, it grew Candida albicans, and we kept thinking that this Candida albicans is a contaminant. We repeated it again, it grew Candida albicans. So that is when we knew that this is actually the culprit and we need to treat it. So whenever you are in doubt, always repeat the test. So there are other instances, when your cultures are misleading and they don't help you in treatment. For example, you have a patient who has fever, sore throat, you start amoxicillin, the patient doesn't get better, you send a throat swab. And then it grows Klebsiella or Pseudomonas. So these are just colonizers because they don't cause sore throat. So they don't have to be treated. Similarly, you have a patient with acute suppurative otitis media who's discharging pus from the ear. 10 times out of 10, if you send a culture from this pus now, it will grow Pseudomonas. It doesn't mean that this is Pseudomonas or otitis media. It is just that it's a colonizer. Because Pseudomonas is a very, very common colonizer because the organism doesn't really need any nutrients for its growth. It can actually grow in water as well. So that is why in lots of places where you have open wounds or you have open swabs and all you send, you commonly find Pseudomonas over there. It is just a colonizer. Similarly, you have a child with diarrhea who's not improving and you send a stool culture and it will either show you Candida or it will show you ESBL pathogen. And these are misleading because these pathogens are not causing the diarrhea of the patient. The true pathogen, whatever it was, went away with the antibiotics and now you're left with colonizers. Similarly, if you send a urine culture of a patient who's on antibiotics, you grow yeast, but that is not the culprit. Similarly, if your ICU is sending ET cultures in ventilated children and it's growing MDR or XDR pathogens, then these are also not the real culprits. And swab cultures from open wounds, drain cultures, so the pleural drain has been there for 3-4 days, and then you send a culture from that pleural drain, it is going to only give you colonizers. And similarly, Foley catheter tip and endotracheal tip culture should never be sent. So remember that when you find an organism, you have to interpret the organism in light of the clinical situation, and you have to differentiate between true pathogens, contaminants, and colonizers. So moving to the last part of the talk, which is interpretation of the antibiotic sensitivity, which is the biggest part of the talk. And we have, all of us who have read Panikkar in second MBBS have been told about the disc diffusion method or the Kirby-Bowl method, in which, you have a Petri dish with a media, you inoculate the media with the organism and you put the antibiotic coated discs. And then basically there will be a zone of inhibition which will form around the disc. And if the zone of inhibition is large, it means that the organism is sensitive. And if it is small, it means it's resistant. Of course, you will have to compare it to breakpoints, which I will discuss later. But now these disc diffusion methods have been largely given up, and now you have these automated methods for sensitivity testing, which is, automated systems you have like Vitec, etc., where you have the machine itself in which you just load a card with the pathogen and it will tell you, because it will use the minimum inhibitory concentration technique. That means what happens is that minimum inhibitory concentration is the minimum concentration of the drug required to inhibit the growth of the organism. And then you have the gradient diffusion or the E-strip methods, in which you have a E-strip which is coated with the antibiotic in increasing concentrations, and you put it in the Petri dish, and you will find that there is a zone of inhibition which is shaped like an ellipse, and where the zone of inhibition intersects with the strip, you have the actual MIC. So the advantage between of gradient diffusion or E-strip over the dilution methods is that this gives you the exact MIC, whereas this just tells you whether the MIC is lower than the cutoff or not. And of course, you have molecular methods based on detection of resistant genes also, but I will not be discussing that today. So the principle of antibiotic sensitivity testing is to pronounce organisms as sensitive, resistant, or intermediate. And how do you pronounce them as these? By comparing either the zone of inhibition or the MIC to various kinds of breakpoints. So you have a susceptibility breakpoint and you have a resistance breakpoint, and these breakpoints differ for different antibiotics, organism, and various types of societies. Like CLSI from the US, UCAST is from Europe, BSAC is from Britain. India, we don't have our own breakpoints, but most of us in India follow the US breakpoints, which are CLSI. And another thing which you must remember is that if your pathogen is sensitive to that antibiotic, your chances of therapeutic success is high. But if it is resistant, the chances of therapeutic success are low but not zero. And that is the reason why often you find that you have used an antibiotic, the patient has got better, but then finally you get the report, it shows that it is resistant. Because when the societies set up these breakpoints, they try to be very conservative. So they don't want any resistant isolate to be pronounced sensitive. So that is why they keep their cutoffs like that, while you can pronounce a sensitive isolate as resistant, you can't pronounce a resistant isolate as sensitive. And what if it is intermediate? It means that you can achieve therapeutic success by giving higher doses. So this is just an example, like for example, if you use this diffusion, then for E. coli and for the antibiotic ceftriaxone, your sensitivity breakpoint is 28 mm and your resistance breakpoint is 23 mm. So suppose your isolate has shown a diameter of 18 mm, it means that it is resistant because it is lower than the resistance breakpoint. That means the zone of inhibition is smaller. Whereas when you look at the MIC, that is on your Vitek, etc. So these are just some examples. For example, for E. coli and ceftriaxone, your sensitivity breakpoint is 1 and resistance is 2. So if your isolate value is 8, means it is resistant. It is higher than the resistance breakpoint. And so also, I just wanted to show you the difference between the various societies. So for example, if you take E. coli and you take piperacillin tazobactam, and if you look at the CLSI breakpoints, this is 16 and this is 128. So that means if your isolate has a MIC of 16, the CLSI will pronounce it as sensitive. But if you have UCAST, if you're applying UCAST breakpoints, then it will pronounce it as intermediate. So that is why, as we will discuss later in this talk, it is important not just to see the result of the sensitivity report, but to actually look at the MIC so that you don't make this mistake of confusing between the two different societies. And this is also true for meropenem by CLSI and UCAST. So for example, here it is ulta. That means the CLSI breakpoints will say anything less than 1 is sensitive, but anything more than 4 is resistant. Whereas the UCAST will have a higher cutoff. So that means if the isolate has a value of 2, the CLSI will pronounce it intermediate susceptible, but UCAST will say it is sensitive. So for those people who are treating critically ill patients, not for everybody, it is very important to know the breakpoints and the MIC. And this is just a good app, I've saved some screenshots. So you can go to Google Play Store and you can, it's called, the name of the app is Breakpoint MIC. You can download it. It's a free app. You can choose the English version. So you just have to put the bacterium and the antibiotic. So you put the bacterium is Enterobacteriaceae antibiotic is ceftriaxone. So it will tell you what is the sensitivity breakpoint and what is the resistance breakpoint. But remember that this app only tells you about the UCAST cutoffs. It does not tell you about the CLSI. And for those who are really interested in knowing the breakpoints, they can ask their lab to give them the printout of the CLSI or the UCAST for you to look at the various breakpoints. And something which we should also understand is that it is not enough for us to see whether it is sensitive or resistant, but also look at the MIC and you calculate the MIC to breakpoint ratio. Now, many times, people tell me that look, whichever MIC is lowest, that is the best drug. But it's not the actual MIC, but it is the MIC to breakpoint ratio. So, for example, if you have Klebsiella, which has these MICs, if you compare it to breakpoints, you find that the ratio is lowest with meropenem, and that is why this is the best drug. Of course, its MIC is also the lowest, but you can't look at the absolute MIC. You have to look at the MIC breakpoint ratio. Now, coming to some cases, with that basic about antibiotic sensitivity, you have again a child who has a UTI and you look at the report, and this is a report which is not correct. Nobody should issue a report in the form of pluses, because here it will look, you will see, you think that the one which has the maximum number of pluses is most sensitive. But when you actually compare the zone diameter with the breakpoints, you find that those things which had the maximum pluses are actually resistant, and those which had the smallest pluses are actually sensitive. So this is not the way it has to be reported. So basically, if you look at this urine culture report, it is E. coli, it is ceftriaxone resistant, so it's an ESBL pathogen. Now, but this patient whom you started ceftriaxone, the culture shows resistant to ceftriaxone, but the patient improves. So what would you do in this patient? And that's a very common question which is asked. Modify or continue the same? And the reason why this has happened is because there's a difference between in vitro and in vivo susceptibility, and the concentration of drug in urine and our breakpoints are on the basis of serum. So basically the drug gets such high levels in the urine that it overcomes the resistance. And therefore, such patients, you can continue the same, but you have to watch for late therapeutic failure and relapse, because many times these patients improve and then 2 weeks later will come to you with a recurrence of UTI when you have to use the drug to which the pathogen is sensitive. But remember, if you have a patient who's highly immunocompromised or who is a neonate, then if you see such kind of report, it might be better to actually change to the drug to which the organism is properly sensitive. Now, another thing which you must understand is, let's say this case, this is a patient who comes to you with features suggestive of bacterial meningitis. The patient is started on IV ceftriaxone and vancomycin after sending blood cultures, but because the patient underwent a CT and all, the CSF was delayed. So CSF happened after the patient was given antibiotics, and the CSF is again like bacterial meningitis, and a panel is done which shows that it is pneumococcus. And what happens is 48 hours later, your blood cultures are positive, but the CSF cultures are negative. Now, this can happen because the blood cultures were sent when the patient was not on antibiotics, but the CSF cultures were sent when the first dose of antibiotic was given. So, as per the blood culture report, the pneumococcus which has grown is sensitive to penicillin and is sensitive to ceftriaxone. So the question is, though we have started with ceftriaxone and vancomycin, if your pneumococcus is susceptible, you would de-escalate and give just ceftriaxone alone, or would you give ceftriaxone and vancomycin? So here you must understand this important thing about pneumococcus, that the breakpoints are different for CSF and blood. So what happens is, because the concentration of the drug in the CSF is lower than that of blood, your cutoffs are different. So for example, for penicillin, whereas the cutoffs in the blood are 2, 4 and 8, in the CSF it is 0.06 and 0.12. Now this patient, pneumococcus which you have grown in the blood, has a penicillin MIC of 2. Therefore it will be sensitive here. But if you look at it by the CNS criteria, it is resistant. And obviously, if this patient has pneumococcus in the blood, it will have the same pneumococcus in the brain. Similarly, ceftriaxone, if you look at the non-meningeal breakpoints, it is at 1. But if you look at the you view it from the CNS cutoffs, it is intermediate. So in this patient, you have to be very careful that though the lab tells you it is sensitive, you have to take it as resistant, and you would treat with ceftriaxone and vancomycin here. So important to remember that for pneumococcus, the breakpoints are different for CSF and blood. Now, in this patient, if the CSF was also done before the antibiotics were started, then you would, you would end up with a report which would clearly tell you that the CSF isolate is resistant. Now, you have this patient who comes to you with with what looks like endocarditis, blood culture grows Staph aureus, and it is a dative valve endocarditis because the patient didn't have any valve problem. And look at the culture report. The culture report shows Staph aureus, and it is oxacillin sensitive, and it is also cefoxitin sensitive. So this is an MSSA. So this patient, though there are so many drugs which are coming as sensitive, you know that for this patient, the treatment is either to use clox or cefazolin for 6 weeks. And even though vancomycin is sensitive, you can't use it for treatment. So that means for every pathogen, you need to know the best drug for that pathogen, and you cannot just give any drug to which the organism is reported sensitive on the report. You have another child here, 7-month-old, with what looks like an acute bacterial osteomyelitis. And here, if you look at the pus, oxacillin is resistant. So this is obviously MRSA, and it looks like community acquired because there are many drugs to which the organism is sensitive. So what is important when you are assessing an MRSA is to look at the vancomycin MIC. And because if the vancomycin MIC is more than 1, then though the report will say that vancomycin is sensitive, you will have failure of therapy. So while you decide to use vancomycin, always watch out what is the vancomycin MIC. And then let us look at the last 2 cases, which is of gram-negative infections. And this is something which you will deal with on a day-to-day basis. So you have a 4-year-old child with a febrile UTI. The urine culture is sent and IV ceftriaxone is started. 48 hours later, fever is still persistent and the urine culture grows E. coli and it is ceftriaxone resistant. So you know this is an ESBL. Now, this case is different from the earlier case because in the earlier case, though the E. coli which had grown was ceftriaxone resistant, the patient was getting better. So you decided not to change treatment. But here, the patient is not getting better. So you have to change treatment. So now, what are the options for treatment? You can use BL-BLI combinations like TAS. You can use carbapenems. You can use, and what about aminoglycosides? We'll discuss that later. Quinolones is resistant, so you can't use. And TMP SMX is resistant. Otherwise, this would have been a good drug to use in this patient. So the question which comes is that how does a culture report help you in deciding between a BL-BLI or a carbapenem? Now, how to choose one of it is also dependent on the sickness of the patient, because if your patient is very sick, you would choose a carbapenem. But it will also depend on what are the MICs of the BL-BLI. That means if the MICs are 8 or less, you can use Piptas. But if the MIC is more than 8, you should not use it. And why? Because I told you earlier, this is the thing which I wanted you to see. Yes. So if you look at this, if it is 8, then this is 8, it means it is sensitive by both CLSI and UCAST. But if it is 16, then it is sensitive by CLSI but not by UCAST, and you can have failure of therapy. That is why it is very important that you decide on the basis of the MIC. And you cannot use amikacin as monotherapy here because you can't use amikacin for such a sick patient. Maybe later, if you want to switch to once a day therapy, you can give it, and there's no need to use combination therapy. So if you look at this patient's printout from Vitec, you know that the Piptas MIC is 8 here. So that means this patient was not very sick. That's why we chose Piptas. Remember that because this is coming out from Vitec, even if the Piptas MIC was 16, it would have been set sensitive. But then if you look at, and if you find a MIC of 16, you would not want to use it. So that is very important, not to just look at sensitivity or resistance, but also look at the actual MIC. And then let us come to the last case. This is a 7-day-old neonate, 1.5 kg, who's in the NICU, develops sepsis on day 7. Blood culture is sent, and as part of the protocol of the NICU, we started on meropenem and amikacin. The baby is slightly better, but 48 hours later, the blood culture grows Klebsiella pneumoniae. And look at the sensitivity here. If you look at this chart, amikacin is resistant, meropenem is resistant, cholesterol is sensitive, phospho is sensitive, TG is sensitive. So now the question is that the baby is better. So would you change treatment? Again, the same question comes. So here, this is not the case of a 4-year-old with UTI where you need not change treatment. This is a newborn 1.5 kg who can worsen very fast. And if you don't treat this infection quickly, it may go into the brain. So in this patient, if you have got this report which shows that there is carbapenem resistance, you should change treatment to an appropriate therapy. And how will the culture report help you in deciding that? You have to look at these things. For carbapenem resistant Klebsiella, you have to ask the lab to do cholesterol susceptibility by broth microdilution because Vitek reports are not reliable. You should look at the carbapenem MIC because if your MIC is more than 16, then carbapenem will not help. You should look at the phosphomycin MIC also. It should be less than 32 because even if the MIC is 64, the lab will call it sensitive, but phospho will not work. And you should look at the tigecycline MIC because if you see that the lab, any MIC of up to 2 will be called sensitive, 4 intermediate and 8 resistant, whereas in real life, only an MIC of less than 0.5 or 1, you can use tigecycline, not if the MIC is 2, 4 or 8. So that is why you look at the Vitek printout. Now, if you look at this, cholesterol is sensitive, phosphomycin is sensitive, and the MIC is good. Meropenem, you see that the MIC is 8. So that is less than 16. So that may be one of the reasons why this patient improved on meropenem because the MIC was not more than 16 and tigecycline, the MIC is 0.5. So in this patient, because your meropenem MIC is not above 16, you can treat this patient with high dose carbapenem and colistin. And if your patient is very sick or has CNS involvement, then you should use phosphomycin also in treatment because phosphomycin goes well into the brain, whereas the penetration of colistin in the brain is not good. And if your meropenem MICs are high, the meropenem may not work. So that is why you have to start looking at the actual MICs. So I think with that, I like to end my presentation. I hope I've done it in the required time. And to say that, it is important, not only is it important to send cultures, but also interpret them properly and also not when to send cultures. I mean, don't send cultures of stool, don't send cultures from the ear, don't send throat swab cultures, don't send sputum cultures, which are actually saliva, etc., because they are not going to help you. Don't send cultures from indwelling drains, which have been there for a long time. Don't send swabs from open wounds. But let us say you have sent the proper culture, then you should interpret it properly. You should look at the gram stain and the AFB stain. You should look at the other stains as well, like fungal stain, etc., which have been asked for. Look at the organism. Try and see whether the organism which you have found on culture is the culprit or not. And look at the sensitivity and also remember to look at the MIC. Insist that your labs start doing Vitek sensitivity testing, which I think is now a norm in most cities. And also ask them to give you a printout of the MIC along with the sensitivity report, because in many labs, the method, you can't write it on the report. So you can just ask them to print that MIC thing which comes from the Vitek machine and add it to the report. And then finally treat the patient and not the report, because finally if you have to choose between the patient and the report, I think the patient is more important. Thank you.
I think it was a wonderful presentation, Dr. Tanu. And I think you've summarized it very well. You've given a lot of practical points to us. That I am a pediatric intensivist, so it was wonderful to hear you. I would just like to add few things to it. Like as we were talking about ETS, right, and you said that MDR or XDR, whatever is growing on, you just can't go on treating those MDR, XDRs. So I agree with you that the very important thing which one should remember is the clinical scenario. So it's not just the organism which needs to be treated; it is the patient which needs to be treated. So there are many scores for my colleagues. I would like to tell them that there are scores like CPI scores, which tells you that there are some clinical deterioration in the patient along with the culture reports uh, with the colony count, and then you interpret them, and then you treat the patient accordingly. So the most important things are the clinical scenarios, and then comes your cultures, and those cultures needs to be interpreted very very appropriately as per the condition of the patient. And then talking, so I think the take home message from today's Dr. Tanu's lecture would be we should start looking at the MICs, and that really help us, especially in the critical care areas where you may end up using polymicrobial therapy for MDR or XDRs. So combining drugs or not to combine drugs, or complicated situations, so all those areas. So I think so I just want to yeah. And one more thing which I've just written it out is that UTI. So UTI is such a common scenario which as a pediatricians we see in and out, and every time it will be E. coli which will be resistant to ceftriaxone, and you would see that by the time report has come, the child has already responded to ceftriaxone, and then the clinician will be taking the report and going from here and there what to do with this report. So she has given us a good insight to it, that even if the cultures are saying that this E. coli is not going to respond to ceftriaxone, but if the patient is getting better, we can continue with the same drug with some confidence. That's all from my side. Thank you so much, Dr. Tanu. It was nice hearing you.
Thank you.
Tanu, just one comment from my side. Thanks to Multitop, we keep on getting different organisms every day. As a neonatal intensivist, I can tell you that every day you are on rounds, get an organism which you have never heard of, and then you start looking at books at what is this organism, what is the sensitivity. So the microbiologists are making us run after the organisms now, and we have to learn a lot of things because the technology has really made us learn microbiology better now.
Yeah.
And your talk was excellent. I enjoyed it thoroughly. Thank you so much.
It was awesome presentation.
May I ask a question?
Can I make a comment, please? Excellent presentation, ma'am, and a lot of learning for us. And I think that one place where Mumbai scores over us is that Mumbai has you and we don't have you. This new platform comes to our rescue. Thanks for your presentation.
No, I'm a Delhi girl. Settled in Mumbai.
Thank you, ma'am.
Tanu, I have a
One
question for you.
ma'am. What is the most common nosocomial infection which we encounter in ICUs at present, according to present?
Klebsiella, I think, both in NICU and PICU. At least our top pathogen is Klebsiella, followed by Acinetobacter, Pseudomonas, E. coli, Enterococcus, and Candida. These are the main pathogens we are seeing, whether it's a PICU, NICU, or cardiac surgical unit.
Any sensitivity patterns to it?
So we find that the carbapenem resistance rates are very high in our hospital, like, maybe 30% or so are carbapenem resistant. But yeah, one thing I would like to say that the resistance rates in pediatric and neonatal is lower than adult ICUs. In adult ICUs, the resistant rates are still worse. But still, we also have about 30 to 40% of our isolates are carbapenem resistant. And therefore, if we have a patient in our ICU who has a nosocomial infection and is very sick, then our empiric therapy is colistin with meropenem till we get our culture reports back.
Yeah, I think the isolates in intensive care areas do differ as per the institutions. Like we have more of Acinetobacter, and then Klebsiella is more common in hemato-oncology patients. So it do differ. But it's true that the nosocomial infections, carbapenem resistance has gone up, and that's really worrying. Not only carbapenem, what I am seeing nowadays is the resistance of colistin has also come up, and
Yes.
that is very worrying.
Yeah, so I think I removed that late, in the end. But beyond carbapenem resistance, now you have colistin resistance. But one thing I would like to say is when we find that our isolate becomes colistin resistant, we find that some sensitivity returns. So they become sensitive to some of the other drugs most of the times. So that helps. Dr. Kukreja, you had some questions, sir?
Yeah. My question was anyway, very good presentation, very nice as usual, Dr. Tanu. And I kept the session in the last so that we can talk to you for 2 hours. Anyway, in the last case, Tanu, where you were having a carbapenem MICs of 8, will you also like to give a prolonged infusion of meropenem, which we normally practice?
Yes, you can do that. So you could use a higher dose and you could give it as a prolonged infusion. Yes, you could give it over a period of 3 hours. In fact, that's a very good point because that is the real indication for giving a prolonged infusion over 3 hours. Now, what we have done in our ICUs is to give meropenem always as a prolonged infusion over 3 hours. We have made it a rule because what happens is that otherwise you tend to forget this कि इसको 30 minutes पे देना है, इसको 3 hours पे देना है. So at least in our adult ICU, we have a policy that if we are giving meropenem, we always give it over 3 hours because the carbapenem resistance rates are anyway quite high. But I also wanted to add that this isolate was a odd one out because we got a meropenem MIC of 8. Most of our isolates have a meropenem MIC of more than 16. And when you are saying what it is, you don't know whether it is 32, 64, 128 because the machine will not tell you what is the exact MIC. So more than 16, we don't know what it is. So that is why in those situations, using high dose carbapenems or prolonged infusions will not help.
So here I have a question that, like, as it is said that there is a synergism between meropenem and colistin. Colistin improves the penetration of carbapenem. Is it true, Dr. Tanu? Shall we?
Yeah, that is true if your meropenem MICs are not very high. So this has been mainly demonstrated in Western countries where they have KPCs and they have meropenem MICs which are in the range of 4 to 8. But once your MIC is more than 16, this synergism doesn't really help. In fact, there is a study called the IDA study where they actually found that if you use for a meropenem resistant bug, if you use meropenem plus colistin, the outcomes are inferior than using colistin alone. So we don't know the reason for that. But now we have stopped using meropenem if our MICs are more than 16, and we always try to look for other companion drugs. Like in this patient, you could have used fosfomycin, you could have used tigecycline, and you could have also used ceftazidime avibactam because that's also a good drug for carbapenem resistant CLEP. And our lab is now doing routine sensitivity testing for ceftazidime avibactam also.
So what is your experience with tigecycline?
So,
like my own clinical experience is not great with tigecycline.
Yes, so it is a companion drug and you use it when you have no other option because you have to give something with colistin and nothing else is sensitive. Then you use tigecycline, you use a higher dose, but the problem is in newborns and children it's not approved and it doesn't achieve good levels in the blood. But we use it when we are desperate and there is nothing else to give, that we add it to colistin. But we don't know what is the additive benefit of tigecycline here. And we also have serious side effects because of the tigecycline. Your platelets go down, your liver functions get impaired.
So usually even my experience with tigecycline is not so great. And I would like to ask one more thing. I have added at few instances, I have added in Acinetobacter infections, I have added rifampicin along with colistin. So, and I have found that it do work well. So
So it does, but there was a randomized trial which came some time ago which showed that rifampicin does not add, great benefit. But if you're pushed to the wall, and in Acinetobacter we often use sulbactam as well, because sulbactam, minocycline, and polymyxins you use, and rifampicin. Like we had one patient with a post-neurosurgical Acinetobacter meningitis where we used rifampicin. Yes, so if you are pushed to the wall, then you can add it, even though the trial doesn't show benefit.
So I think we can go on and on because it's one topic.
Yeah.
Which is
final comment from Dr. Kukreja, sir.
I think
Yeah,
it
there is one question from Dr. Chitkara. Can I answer that question? It's
Sure,
sir
sure, ma'am.
asking. So,
Sure.
so it says that good evidence to treat ESBL UTI with amikacin monotherapy if culture sensitive report shows amica sensitive and renal functions okay, spare carbapenems. So, this I think I would like to disagree here, because the patient, if the patient is having a UTI, already the kidney function is compromised. Some of these patients may have a high creatinine. So, in such situations, I mean, though it would be, more expensive to use carbapenems, more tedious to use them, still, it would be better to use them rather than amikacin and produce nephrotoxicity. So, unless, of course, the patient does not want to stay in hospital and wants to go home, then I would use an aminoglycoside.
Is there any vitro and vivo difference of E. coli to ESBL E. coli to amikacin, aminoglycosides? So that's what I used to understand.
Yeah, but again, as I said, that if you have it on the break point, like you have an MIC of 16, you can still use it. But the problem is that there is no role of combination therapy here. So you would then probably use the drug to which it is properly sensitive than use amikacin, unless, of course, you have nothing else. Like you have a situation where carbapenem is resistant and amikacin is sensitive, which can happen. Yeah, that is a situation where you would probably use amikacin and not use colistin.
Dr. Tanu, as a pediatric cardiologist, my interest lies with the endocarditis. And I would like to know that what empirical antibiotic you will suggest in a culture negative endocarditis.
So in children, the commonest cause of endocarditis is Viridans group strep and Staph aureus. These are the commonest causes, MSSA. And rarely you find enterococcus. It's more common in adults and not in children. So normally we use ceftriaxone with gentamicin or ceftriaxone, vanco and genta as our empiric therapy for culture negative endocarditis.
Okay.
It becomes Tanu, very tough.
Your choice also, that is.
Tanu, it becomes very tough to treat for such a long time with 3 drugs. So, for example, we had a child recently who had a MRSA infection and developed endocarditis. And then we reviewed the literature and we found that even the vancomycin can be given BD dose for a long period of time. We gave a BD dose and ultimately child recovered. But one residual thing was he had a lot of thrombophlebitis or the venous vein thrombosis in his arteries and veins both. So that was the only residual thing and he was sent on warfarin. So this is a recent case. And we were surprised to have MRSA as a bug in endocarditis, and we had to treat for something like 12 weeks. Your
so
experience.
that is more culture negative.
And it was right-sided endocarditis, interestingly.
So it's culture negative, this is what you would use. But if it is culture, then you would give definitive therapy. And in such a patient, you could even use daptomycin because that can be given as once a day treatment and it is as good as, vancomycin.
We're a little concerned. We are only pushed to the wall and then we use it because daptomycin, we have not too much of experience. We used in few cases only. We are very comfortable with the vancomycin.
How frequently do you?
Only thing is,
vancomycin
in a long term, after 2 weeks or so, maybe 3 weeks, can we start with intramuscular ceftriaxone? For the
yes,
OPD
in
basis?
fact, now, there is a study which has been published in adults which have talked about IV to oral switch even in infective endocarditis. So if you have a patient who is well controlled, who's culture negative, who's otherwise stable, and you have an oral agent with good bioavailability and you have no option of giving parenteral therapy, then you could even switch to oral. So for example, in Viridans group strep, there is some trial about using oral high dose amoxicillin as a treatment, after giving the first 2 weeks of ceftriaxone. So there is some data about that. So, but what I would do is that I would treat every patient in the conventional manner, offer it as per the guidelines. But then if the family refuses, then I would go to alternative methods and not suggest them on my own. because endocarditis, if there's a relapse or something, then you will always be held liable because you've gone outside the best clinical practice.
Okay, Tanu, it was fantastic. We can go on for another 1 or 2 hours.
No.
It was a pleasure to discuss cases with you. And it was fantastic talk as usual. And we always take out time to listen to your talks. Thank you so much for coming.
No, thank you, Dr. Kukreja, for inviting me. It was really an honor. And I always love to talk to Delhiites because, I belong to Delhi. In one way, I've studied.
Great.
Okay, bye.
Okay.
So it's nice to know that we own you. You belong to us. Wow. Good, great.
Okay,
So
thank you, ma'am.
thank you very much, Dr. Singhal. It was wonderful presentation, and everybody is saying so. And I think they have taken a lot of food for thought for home, and it will definitely help in our patient management plans.
Dr.
So,
Tanu, we have continued for 1 hour.
Thanks, Dr. Tapisha. Thank you so much.
Most welcome, ma'am.
Okay.
Thank you for today's scientific coordinators who did a wonderful job, Dr. Tapisha, Dr. Rajiv, and Dr. Prashant Seth, who started the inning. He was the initial batsman. So, thank you everyone who is sitting here up to now. Or I think this is all your charm, Dr. Tanu. So,
Thank you,
now
Dr.
I
Smita
invite you to...
and Dr. Shyam Kukreja and all the panelists and all the people here. Thank you, Dr.
Thank you,
for
sir.
giving us the opportunity to.
Thank you.
The people did
Another day
great
gone
job.
very well.
Great job.
I must thank all of you.
Wonderful lecture, and I really enjoyed every single bit.
It was a
The
wonderful.
selection of topics were really good. Really good.
We had. And we had a nice day. Tomorrow we are meeting at 8:30. So be there at 8:30.
Okay. Thank you.
Another thanks to Rohit and team, Swapnil and team. Ajay, you want to say anything? Ajay Gupta is there.
No, actually, I just wanted to say Dr. Tanu missed visiting Delhi. She could visit her mother because it was a virtual meeting.
Okay. Dr. Gaba, Dr. Nirupma.
Thank you very much, all of you.
Rashna, thank you.
Thank you.
Thank you, Tapisha.
Pankaj.
Thank you, Prashant.
Good night.
Bye-bye.
Good night.
Thank you, everyone.
Bye.
Thank you.
Rashna, it was really nice interjections. You did very well.
Dr. Rachna,
As expected.
बहुत बढ़िया.
Okay.
Thank you, Dr. Rachna. Thank you.
Okay, thank you. और कल वैलिडेटरी फंक्शन के लिए भी सब लोग रेडी रहेंगे.
Okay, thank you.
Bye-bye.
And come for the morning session, 8:30 to 9:30. Learn about your financial skills. That is most important thing.
First part is how to excel in life by Ravi Malik.
Okay, thank you, sir.
Thank you.
Okay, bye. Bye. Okay. कल poster presentation we are starting at 12:30.
Okay.
12:30 है ना रोहित यही बात हुई ना?
Yes, ma'am. 12:30.
12 o'clock. It was 12:30, no?
Yes, ma'am.
Okay. And you have sent all the invite for the validation.
Yes, ma'am. Already is in a group, ma'am.
Okay. Thank you very much.
Okay, ma'am. Thank you.
Thank you very much. Okay. Have a rest and thank you.
Thank you,
Eat well, all of you.
Sure, ma'am. Thank you.
Raju, thank you very much. You did very, very well.
Thank you,
Last
ma'am.
minute
Thank you,
chip in, but you did wonderful job.
Thank you, ma'am.
Okay. Tapisha, bye-bye. Are you there? Are you left? I'm leaving, huh?
Okay, ma'am.
Just want to say that you've been like really, being ill and still unwell and still really holding the fort. Please take care of your health also.
Yes, ma'am.
I'm fine. Now today is 9th day almost.
Yes.
So I am almost
You're
through,
90%
that
okay
I am
and
coming
tomorrow
out of
will
it.
be 100% fine.
Huh?
Today you're 90% okay and tomorrow will be 100%
Tomorrow
fine.
100% and by Monday I will RT-PCR will be negative. I hope so.
Yes,
And
ma'am.
then
But
go
after
back to
10th,
home.
definitely yes.
It's a really tough time at a hotel, in a hospital room. It's like hotel to me. But anyway, so many days away from family.
कोई नहीं, मैम. Get well soon. जल्दी ठीक होके वापस आओ.
Thank you.
Okay, ma'am. Bye.
Okay, bye. Bye. Thank you.